Comes on. Hello, good morning. About time we need to begin. So for those of us who are outside, kindly get into the hall so that we can begin today's session. Welcome to this, our second day of the conference. We shall be beginning with a plenary presentation. The chair for the session is Dr. Dorothy Mutie, and so I'll graciously request her to open the session with a word of prayer, even as she takes over to chair the session. Welcome, Dr. Mutie.
Thank you, Dr. Aswani. So I'd like us to start with a word of prayer, as has been said. So let's go ahead and pray. Father in heaven, we thank you for this morning. You have allowed us to be alive today, and this is for a purpose. There is a reason why we are here. Lord, we pray that we will fulfill that purpose today. Thank you for the opportunity to gather in this place, to share knowledge, to network with one another, encourage one another in this academic and world, as well as the work, sharing our thoughts in the academics, in our health practice, and in other spheres of life. Thank you, Lord, for the opportunity. We pray that you'd guide us through today. We ask that you'll enable us to be alert and interact effectively, so that by the end of the day, we shall have achieved the purpose for this day. We thank you for all those who are still on the way. May you bring them safely so that we may be together. We thank you for our institution and the management. Thank you, Lord, that we are here courtesy of a lot of work that has gone on. We continue to pray for your wisdom and guidance in all that we need to do. Thank you. We've prayed these things in Jesus' name. Amen. All right. Yeah, so for those who are coming in, please have a seat. All right. As Dr. Aswani mentioned, we're going to start with a plenary session, and I'll be introducing the speaker in a short while. And the speaker will will not be here in person. He will do it online, and I'm told that he's already online. Confirmed? Yes, thank you. We'd also like to welcome our online audience. Feel welcome and feel free to engage with the rest who are here in person using the chat and the Q&A areas within the Zoom platform. And so without further ado, I would like to introduce the speaker, but before I do that, we'll request also that the presenters for this session kindly confirm your presence with Mr. Francis at the back. So if you're around, kindly confirm that you're in, so that once our plenary speaker is through, we will proceed with the rest of the program seamlessly. So feel free, welcome, let's enjoy, let's engage with one another, let's be open to learning and unlearning in some situations, and let's all look forward to having a great time. All right, so our speaker today, this morning, is Mr. Kaboro Stephen Mbugua. He's a Kenyan. And so he's an expert, or rather his competencies are in the area of health economics and health financing. And he has been a key He has been involved a lot in the government setting, in the public sector, both at the national and subnational levels. He has a Master of Science in Health Economics and Policy from the University of Nairobi, and his basic training was in Bachelor of Science from the Jomo Kenyatta University of Agriculture and Technology. He has been involved in various task forces and assignments within the government, being a key member of the ministerial task force that was handling the transition of the NHIF to the current SHA as we know it. Then he was also involved in the joint secretariat to the ministerial experts task force on the reform of the NHIF in Kenya. He has also been a technical advisor on the development of output-based approach programs in Cambodia, Cameroon, Tanzania, and Yemen. Yeah, so to date, he is at the Ministry of Health, Division of Economic Policy and Planning, and Division of Health Financing, where he's the principal economist and a statistician. So he has been involved in capacity building as a trainer in different areas in the finance sector. He's also been involved in the national government budget process and on costing and cost estimation. So basically, we have someone who is rich in the area of financing to help us address our topic for today. So I'd like us to welcome him with a clap, at least for the in-person audience. Let's welcome him with a clap. Thank you. So Mr. Stephen Kaboro, please welcome and take it up. Thank you.
So good morning, everyone. Happy to be here. And thank you for the great introduction, Chair. Unfortunately, I could not manage to attend the meeting physically. So I'll be doing my presentation online, and it is my hope that I can be audible. And as we continue, I would kindly request for the presentation to be put in the video by the team so that this can be visible both by the online team and by the physical class team. I hope I'm audible. Somebody can confirm.
You are. You are audible. You can proceed.
Okay, so as it's somebody in the secretariat to assist in putting up the slide, I will just give an overview on what you're going to discuss today. So specifically, I'll be discussing the issue of strategies in health financing. And as you know, we have been, the country has been undergoing through a lot of reforms under health financing. So I will be speaking to what we have, as a country, have decided and how we have decided to reform our health sector and how we foresee it being constructed in the future. So the presentation will actually be structured in two sections. So the first section, we will look at the policy development process, or the policies that we set up in place for guiding and helping in transforming the health sector. After that, we are going to look at the legal and legislative framework that have actually now been developed to assist in the guidelines, and basically how they affect and how they will shape the future of health financing going forward. So if you move to the next slide, please. Yes, so these are the areas which we are going to discuss mostly today. So under the policy guidelines, we will look at the health financing reforms as proposed. And then the next section, we will look at the legal framework that you have set to ensure that we are able to deliver what is proposed. So in the next slide, looking at the policy framework that helped in guiding the process of health financing reform. So we developed this document called the Kenya Health Financing Strategy. It's a document that was developed over time. And prior to it, if for those who remember, we had a process which we had tried to do in 2004, which was called the NASHIF Bill, popularly known as the Giro Bill. Unfortunately, that process, which was trying to transform health financing, it did not get approval from the president. So it was passed by parliament as a law, but the president had reservations, basically because by then the economy was actually trying to recover from the major stagnations of the 1980s. So we had this document called the Health Financing Policy, the Kenya Health Financing Strategy, sorry. It was started in around 2016 and finalized in 2020. It was approved by Parliament in the year 2020, and the President actually launched it by the year December 2020. And it is the policy document that has guided the major health financing reform that you have been noticing the government trying to implement at the moment. So this policy document had the goal stated as to ensure there is adequate finances for financing health, and that with this adequate financing, we are able to finance our health in an efficient and fair manner so that we can guarantee that all Kenyans have access to essential health services. And for that to be achieved, the specific objectives were stated as three. One, to do resource mobilization, and in this is to ensure that we have enough resources to be able to deliver the health agenda. The second one was to maximize efficiency so that we reduce the many wastages that happen within the health sector. We ensure that we have value for money for every shilling that is invested in the sector. And thirdly is to ensure that there is equity in the way we mobilize resources and the way we allocate the resources so that we ensure that we do not have areas where we take too much money from a section of the population and then another section of the population have less money taken from them. So with those specific objectives, the health financing strategy laid out the key strategies for ensuring that we have enough resources. And the main strategy under the health financing strategy was to ensure we have domestic financing. So domestic financing was a key figure in going forward in the proposed plan, so that we ensure we have enough tax funding that can finance health, and we also have mandatory health insurance, which every Kenyan should be able to access and should be able to pay into. So with that, we had three strategies to ensure that we achieved that key strategy. One was to address the inefficiencies. And when we say inefficiencies, the key issue here was to ensure that we do not just mobilize the resources into the sector and then we have leakages and wastages. So we had to ensure that there is a way we remove these leakages. Some of the key action points we had proposed was to ensure that there is operational autonomy of health facilities, especially public health facilities. At least for private health facilities, we know that they operate in a very autonomous environment. So we needed to ensure we have the same appearing for the public health facilities to ensure that funds that flow into the public health facilities are utilized within the facilities and they do not leak into other sectors. Number two was to eliminate fragmentation in budget provision. You remember, historically, Kenya, we have had so many vertical programs that try to address the same situation. For example, if we have maternal health, we will have very many programs looking at how the mother goes to the hospital, how to finance the baby, and how to finance the hospital. But ideally, all these are not integrated in a way that we can ensure efficiency. The second key strategy was to ensure that we have increased domestic resources so that we stop depending on development partners especially for our key programs and projects, which are strategic for the national development. So in this, we wanted to ensure that we roll out mandatory health insurance for the entire population, where one, they are mandated by law to pay into it, and number two, they are mandated by law to be enrolled into it. And then, of course, we had the private sector. So private sector is one of the areas where we get a lot of resources and a lot of services are delivered through the private sector. So another key strategy, another key action point under that strategy was to ensure that we promote the private sector development. The last area, the last strategy that we proposed in the health financing strategy was to improve financial risk protection. So before we knew that we had people paying different rates for their insurance, and when it came to access to health services, there are also different ways where people can access services. So those who have more money were able to access more publicly financed resources and services. And then those who contributed less had their smaller packages which they could access to. So we wanted to equalize that to ensure that there is fairness in terms of how we mobilize resources. For example, using targeted tools to ensure we are able to see the income and base the contributions from the income of an individual. And then, of course, to ensure that we have well-aligned and consolidated social security programs for those who cannot afford, to ensure that they are able to get financing available for them, or even if financing is not available for them, we ensure there is enough cross-subsidization across the entire economy so that everyone gets the same level of service irrespective of the payment being based on the level of income. So how did we, or did the government now try to actualize those strategies? So the government now come the year 2023, so these 2 years after the health financing strategy was put in place. So around 2022, 2023, the government tried to actualize this strategy, and the discussion was that there was a need to have legislative framework to ensure that all the reforms that were going to be done in the health sector were ring-fenced, to ensure that they do not change, and they were well anchored in law, and they were well aligned with the already existing law. So the government decided to do 4 key legislation, and we are going to go through these legislations and see how they feed into the strategy. And these legislations are what will drive the medium term, Kenya in the medium term and in the long term, in terms of health financing reforms. So we have 4 key legislations. We have the facility improvement financing legislation. We have the social health insurance legislation. We have the data health legislation and primary health care act, both dealing in that issue. So we will start with the facility improvement financing legislation, which is actually the key legislation that is able to ensure the first strategy. Remember, the first strategy we talked about of improving the autonomy of public health facilities and ensuring that they retain funding. So this legislation, the Facility Improvement Financing, or FIF, is critically geared to ensure that that happens. And this legislation specifically applies to public healthcare facilities. It does not apply to private and faith-based care facilities. And the main objective of the legislation is to ensure that there is efficient, secure, and accountable mechanism for correction, retention, and management of revenues derived from health services in public health facilities. So in this way, we wanted to ensure that all funding that goes towards public health facilities are able to be retained within that health facility, so that the facility can improve the level of services that is able to deliver. And we have a uniform way where facilities, if you go facilities in one region, you find they have the same basic framework than a facility in another region, so that there is fair competition between facilities. And this legislation also ensured that there is effective planning, coordination, and mobilization of facility financing. So from both health insurance, private and public, and from their own collections from the public, and also from the financing that they receive from their own county government. So the main thing to note about this act, it was geared to ensure that facilities have enough funding to be able to run effectively without the funding that is mobilized towards the health services leaking into other sectors, specifically within counties. We know for national government health facilities, they usually have key autonomy in a way that they have already established boards, and most facilities in the national government have their own established legislation. So this was mainly geared towards facilities in the county level. So the next legislation which we looked at, and which is very, I would say, either popular or unpopular depending on how you look at it, but at least this one is one you're familiar with, is the Social Health Insurance Act. So the Social Health Insurance basically establishes an authority to be a successor to the National Hospital Insurance Fund. So this authority is called the Social Health Authority, or SHA. And this authority is established mainly to manage three funds. And I will talk on each of these funds. So it manages three funds. The first fund it manages is the Primary Health Care Fund. And this fund is supposed to be to receive funding from the national government, allocated into the fund and specifically earmarked for primary health care services. So you will notice that in the reform, there is a lot of emphasis on primary health care facilities and primary health care services being prioritized to ensure that there is more prevention and at the lowest level of healthcare service. So this act ensures that the fund is established, it is able to receive funding from the national government, and this funding provides services, especially outpatient services, to all members of the public when they register, even before they pay for their premiums. So for this funding, you do not have to pay for premiums for you to enjoy services. You only have to register the dependents through *147# or through afyayangu.go.ke. Then the second fund that is established by this act is the Social Health Insurance Fund, which most people call SHIF. So SHIF is supposed to be the contributory fund. This where every Kenyan is supposed to contribute, whether they are employed with a salary or whether they carry out their activities as self-employed through business or any other activity. They are supposed to contribute to this fund. This fund also can receive funding from national government or county government when they want to ensure their populations, either populations that they have specific interest with, or their populations that they have identified as poor and needing financial assistance. So all this funding has a benefit package, which is now more inpatient and surgical. So it covers all the other diseases that are not covered under the primary health care fund up to a certain limit. And it's supposed to be operationalized once a person contribute to their social health insurance premiums. Once they submit their premiums, the fund is active. So you realize that the first fund is not dependent on premium payments, but the second fund is dependent on somebody actually paying premiums to that. Now, how does one pay premiums? The premiums are determined as 2.75% of income, and this 2.75% of income is agreed as any income derived either from a salaried employment or from non-salaried income that one can receive from other activities in the economy, as derived by proxy means testing. Now, proxy means testing has actually been rolled out. It's still being perfected, but so far it has been deployed, and it has so far been done into around 5 million households, and it's still continuing being refined. I think currently we are in the second version of the means testing instrument, which is just being deployed in the last week or 2 weeks. Now, the last fund that is established under this act is the Emergency Chronic and Critical Illness Fund. Now, this fund is supposed to receive funding from two areas. One, from any excess from the Social Health Insurance Fund, any funding that is unused, and the main financing for this fund is supposed to come from the national government. This fund is supposed to take care of those conditions that are not able to be taken care under the Social Health Insurance Fund. So in case one exhausts their benefits under the Social Health Insurance Fund, they can access this state-funded fund of ECCIF, Emergency Critical and Chronic Illness Fund, to subsidize their costs. And this fund, access to the fund is actually based on two criteria. Number one, for emergency cases, all Kenyans are eligible, whether they have paid for their funding or whether they have not paid. So any Kenyan with a national ID is able to access the emergency fund and the critical illness fund. For those two funds, they usually kick in only 24 hours after presentation of a case. So any case that is presented for stabilization, in case of an accident, in case of any critical illness that is observed in the population, and they are taken into a facility, they are taken care of for the 24 hours by the facility, and the facility actually receives reimbursement, irrespective of whether the individual is registered with SHA or irrespective of if the individual has paid for their premium. The other two funds, the other two areas for chronic illness and for any other critical illness apart from emergencies, you have to be paid up and you have to exhaust your social insurance fund limits for you to enjoy this fund. Now, unfortunately, for the time being, as per this month, we have not operationalized most of the fund, except for the 24-hour emergency. And we have received funding for the next financial year to start operationalizing one, payment of ambulance services. Number two, any other services that will be identified for inclusion, so that when you exhaust your limit under the SHIF, you can get further services using this fund to reduce depending on out of pocket. So funding has been earmarked in this financial year to continue that. So another thing to note under Social Health Insurance Act, this is where there is a legislation that every Kenyan has to be registered. It has become mandatory now. You remember previously, registration into social health insurance has been voluntary for those who are not in the formal sector. It was only mandatory for those who are in the formal salaried sector. But now this act mandates everyone to be part of health insurance. Now, the third act, which was legislated, was the Primary Health Care Act. Now, the Primary Health Care Act basically looks at how we are going to set up primary health care delivery services at the lowest level, That is from level 4 going to level 3, level 2, up to level 1. So how are these supposed to be established? How will there be an interplay between public facilities and private facilities, and how can they work together? So this act establishes a few things. One is to establish a multidisciplinary team. Multidisciplinary means that in case a doctor is available at a higher level, maybe level 4 facility in a sub-county, that doctor, a network can be established, which you're calling a primary healthcare network. And that network, a doctor can move within that network and deliver services even within other facilities that are not his main facility of employment. So it mainly focuses on what we used to call outreaches. So healthcare workers can move to other facilities apart from the high-level facility where they are in. It also establishes how the community units are integrated into the healthcare system. So this is where you find the legal entrenchment of community healthcare units into the healthcare delivery system, so that they can be used both by the local population, and they can be able to link the local population through a specific digital way into the health facilities. So this is a way of devolving further the healthcare delivery system to ensure the households, especially for those identification of diseases, etc., they are able to get services at the lowest level. Now, to ensure all these works together, another act was enacted, which is called the Digital Healthcare Act. It has mainly come into play nowadays. It has been operationalized after the after the Social Insurance Act, but now it is coming into play. This is what you find a lot of people calling Taifa Care. It is basically brings together all these players in the health sector, both public and private sector players, and ensures that there is a way we can integrate the healthcare information system from the highest level to the lowest level, so that when a community health worker identifies that a person is exposed to a health condition, there is a digital platform where they can link that family member into the healthcare system. And there is a way that, for example, a health facility, for example, for those health facilities that do tracing and enforcing to ensure people comply with standard measures, especially for conditions like TB, there is a way that facilities can be able to digitally ensure that these things are devolved and are adhered to in a digital health information system. So this digital health information system is available for both private facilities and public facilities. And basically, the main area also that is informed by this digital healthcare system is to ensure that we move from paper-based movement of information from one facility to the next, and ensure that we have a more efficient and paperless movement. And then we also reduce the number or the duplication of healthcare services that are requested in a health facility. So, for example, a doctor would be able to know pre-existing conditions of a patient before they even get the patient actually gives this orally. So once a doctor requests to access a patient information, the patient gives access to this information, so the doctor now can be able to, of course, the patient has to give consent digitally. Once that happens, the doctor can be able to see the entire history of the doctor for those conditions which the doctor is treating. This way also we are entrenching the issue of telemedicine and e-health to ensure that for those, and also m-health, to ensure that those facilities which are far off from core specialized healthcare workers, there is a way that they can link up together and they can be able to access these services. This mainly has actually been piloted a lot in the county of Kiambu. I think for the last few months, we have been able to see patients in the remote facilities in Muranga, not Kiambu, in Muranga, receiving specialized services from facilities both in Nairobi and in other fields, in other areas. So how are these acts supposed to ensure that we have an integrated delivery of universal health coverage? So the key act, which we talked about, the Social Health Insurance Act, it establishes 3 key areas that are to be funded. Number 1, we have the community-based primary health care service delivery. And these are basically outpatient, promotive, and preventive facility-based services. So all these facility-based services are at the lowest level that are promotive, preventive, and primary care-based that can be offered at that level are able to be reimbursed from the social health insurance system. Then in case there is a referral for these services and a patient is sent into a hospital for specialized services. So for specialized, it means they either need an inpatient, they need either a minor surgical procedure or a major surgical procedure that cannot be delivered at the primary care level. They're able to receive these services at the hospital, and the hospital can get reimbursement from the second fund, the Social Health Insurance Fund, or from the the ECCIF, Emergency Critical and Care Fund. And in case we have services that really do not need an individual either to be identified or they cannot be identified, or we have cases where emergency comes is detected in the community. For example, you see sometimes a person collapsing on the street. That person cannot be asked whether they have insurance or not. You cannot even ask for them for their ID, but they need emergency services, and there needs to be a way how these facilities can be reimbursed. So the public or an ambulance can pick that person, take them into a health facility, and the facility should be able to stabilize that person without fear of where they'll get a reimbursement from. So the facility will receive the reimbursements from this fund, and up until the person is able to respond and or be able to be traced, and they can go back into either of the funds which will take care of him. So with those, we had foreseen that we would have a benefit package which we can roll out universally. Now, one thing to notice is that the rollout of this benefit package is dependent on availability of funds. So funds both from the national government and from the population. So there is a gradual rollout of the benefit package. So there's a team that has been recently gazetted, I think a week, either last week or the week before, by the cabinet secretary, which will be looking at the cash that is coming into the social health authority, SHA, and be able to prioritize which other conditions need to be added into the package. You remember we started with a smaller package, which is was just an increment from what we had from NHIF. So as we mobilize more resources from the public, we mobilize more resources from government, most of these other services are going to be onboarded. I think the last service which was included was the recent inclusion of ICU care. So ICU care received a benefit different from normal inpatient, and the second one was the enhancement of oncology services. So the limits for oncology services were enhanced based on the funding that was received from the National Treasury in the supplementary bill. So with that, ladies and gentlemen, I wish to end my presentation. I see I have almost exceeded my time, but I hope, Chair, that was clear and concise. So with that, I take it back to you, Chair.
Thank you very much, Mr. Stephen, for taking us through this very informative presentation where you handled the strategies of healthcare finances, what is current, and how the future looks like. So thank you. I believe we are all, at least we've added something to our current knowledge. And so we'll get into a short session of discussion where the audience is invited to give their inputs in form of questions, clarifications, and even additions, because we are all we all are contributing to this topic. So the online audience, feel free to send your questions. I would want from the Secretariat to know whether there are any questions that are already on the maybe the chat or Q&A section. So I'm informed there are none. And so I'll invite also the in-person audience to ask any questions or ask for any clarification. And as we do so, I would like to once again to ask any presenters any presenter of the, if you have a paper in this first session, kindly see Mr. Gashanja at the back. Kindly let us know that you are in. That is what we would like to know. So that once we are through with this discussion, we will immediately go into the presentations. So yeah, there's a question here. Thank you.
Sorry. Thank you very much, the presenter, for such a wonderful insights on health financing. My question is, as a way of sustaining these particular funds, especially from the national government, we were told that we are yet to achieve the 15% budgetary allocation. Is there something towards that we can progressively move from the 6 point something percent to 15%? The next question would be, how will you be able to, especially the difficult part for people to pay the 2.75% for the SHA is from the informal sector? What are some of the innovative ways that we can put forward to ensure that we also have them contributing so that we relieve the burden on the salaried individuals? Thank you.
Thank you. I hope our presenter plenary speaker has heard. All right. Yeah, there's another. Yes.
Good morning. I think I'd like to mention something. I think in the past, we have had a challenge when it comes to healthcare financing. I think it's high time that we just say the truth. Like I think in Kenya we have a challenge when it comes to over-reliance on donations, because you cannot tell me that a country like Kenya we are spending a lot, but when you come to healthcare financing, we are only budgeting around 6%. Then if you look at the expenditure at the end of that financial year, we're only spending 5%. Then it means that I could say that we are not interested in what you call system or healthcare system financing sustainability. Because if as a country we are only contributing 5%, then it means we are not giving the health matters the weight that it deserves. So I think it is high time as a country, including the Member of Parliament and Senate, we should have adequate allocation for healthcare services. And again, when you come to issue of SHA, I think SHA, the government is talking much about registration, but the government is not focusing on what to call sustainability of the system. Because if I register, then I don't see the sense of contributing monthly, then the system will collapse. Then I think those people are concerned, especially the MOH, they should change the gears and focus on how do we make SHA sustainable. Thank you.
Thank you. There's another hand over there.
Thank you so much, Presenter. Now I have two questions. Now the first question is about the extent to which SHA or she is covering the client. Now recently I had a salaried client who went for treatment, and she was told her card for SHA is exhausted. So she has to pay out of pocket. That's number one. Number two, a question from a colleague on how to handle the informal sector. I know we have a policy on the salaried or the formal employees. It is very easy to get them because they are on a payroll. These people who are in the informal sector, not all of them are poor. Some of them are even richer than those who are in the formal sector. And I remember we were sharing with somebody, there is a guy who is a welder who makes maybe doors and windows and makes almost 200,000 in a day, but he's not taxed. And those are the people that we want to contribute to this particular social insurance health fund. So how are we going about to have a policy? Because I know there is no policy, and if it is there, maybe we need to have it clear on informal sector and how they are going to be to pay, because they are not on a payroll. They are working somewhere, yet they are making a lot of money and are contributing a lot to the economy. So thank you so much.
Thank you. I think let the presenter respond to those first, then we'll have the next set of questions before we move on. All right. So, Mr. Kaboro, would you like to respond to those three?
Yes, I can respond to those first. And so I will be looking at each as they have been asked from the first one about national government financing for health sector. So we are saying we have a target of 15% of the national government funding going into the health sector, and we are currently only at 6.5. So first of all, a point of correction, the 15% is not national government financing to the sector. It is the entire government's effort, so both the national government and county government. And if you look at the actual definition according to the Abuja Declaration and the subsequent guidance from the World Health Organization on how to calculate the 15%, it goes beyond the national government contribution. It includes domestic resource financing for health. So if we go by the strict definition of WHO, we would say we are almost there. We are headed there. But if you move with the current interpretation within the Kenya system of just government financing without looking at mandatory domestic resource mobilization, which doesn't necessarily pass through government, I would say we are still far behind. Now, there are strategies which we are trying to bring to address those issues. Number one is the issue of ring fencing. Remember, we talked about counties have to ring fence their financing. Now, if you look at most funding from own source budgets for counties, it actually comes from health sector. For most of the time, around half of own budget sources for counties comes from health. And we are saying that we want to ring fence that within the health sector, because once the funds are collected from the health sector, remember, they can be channeled to other areas. And with that, I also want to also bring in the issue of the over-reliance on development partners. I think that was the third question which came. So yes, one of the things we want to do is to ensure we ring fence what we have, to ensure that we move towards that 15% funding, whereby we see we will progressively be weaning ourselves from donor financing. The second area which we are looking on the same, and both for sustaining the funding in the sector and for reducing over-reliance on development partners, is the issue of inclusion of the two other funds which are publicly financed. So the PHC fund, which is funded by the National Treasury, it will ensure there is continuous and predictable financing going specifically for the health sector at the lower level. And then there is the Emergency Critical and Chronic Care Fund, which also is receiving funding from the National Treasury as a commitment by the Act. So those two will see a lot of improvement in the amount of money that is ring-fenced towards health. So it's not only allocating to health, but also ring-fencing to ensure that once the funding goes to the lower levels, it doesn't get it doesn't become reallocated into the other sectors. So with that, I think the issue of the reliance on development partners and national government financing is good. Now, in terms of the informal sector, so the informal sector is very challenging, not only for Kenya, but even when we looked at a review of documentation for other, even for developed worlds, we find that raising funds from we call them the gray economy. So this is the economy which necessarily doesn't go through the normal government finance and tax measures. There are always issues. So, but we noted that in Kenya we needed to think how we are going to go about it, because this is where, as one of the speakers rightly indicated, this is where most of the GDP in Kenya is concentrated. It has the most workers, and it also has the biggest control of the economy. Our estimations are around 70 to 79% of the economy in Kenya is controlled by the informal sector. From the lowest of the farmers and the milkman, watu wa mjengo, to the highest people in the informal sector who are the landlords, who have big businesses bringing a lot of income. So there is a lot of funding, and we have to develop strategies. So for the time being, we haven't been very aggressive in terms of bringing them on board. So because the systems, remember that we are still perfecting the system, but beginning of this quarter, the last quarter of the financial year, we have started now trying to enforce registration. So there are several strategies which we are trying to ensure we enforce these people to pay. Number one, of course, is to ensure that their wealth is assessed well. So one way of assessing the wealth, you remember, is through proximity testing. So in the second version, which I had indicated we have just rolled out, it is able to measure the wealth through consumption measures. So not only asking, you remember the first one was asking the people how their living standards were. People could actually be able to cheat through the system. But in the current system, we have developed a way of analyzing a person's living standards and being able to assess their income correctly. So that is one way to ensure that we assess their income level as well. Number two, to ensure that they actually pay. And for that, we need to ensure we have an enforcement policy. So as you rightly said, we currently don't have an enforcement policy. And the reason being, the enforcement policy that is there has been stopped by the court. So we are expecting to have a ruling before the closure of the financial year. So once we get the green light to enforce registration and premium payment from the informal sector, we will see more more enforcement measures being taken. You remember the informal sector usually pays for their motor vehicle insurance, which is the next mandatory insurance we have in Kenya. The informal sector actually do pay for their motor vehicle insurance, and they diligently pay for that. So we have a policy which will be rolled out progressively, looking at how we ensure that they actually do pay. So there's the issue of the concern about registration. We are concentrating too much on registration. Yes, that is true. So there's a lot of efforts going into ensuring people are registered first to the insurance. And the reason being, number one, after our analysis, we noted that most Kenyans have never interacted with health insurance. They actually do not understand the concept of health insurance. So we noted that there was a need to have a lot of information going into the people actually trying to understand what we mean by health insurance and actually buying into it. So registration is one of the acts of getting people curious in terms of what is this insurance. So before, I think only about 23% of the population had ever interacted with health insurance. But we see with just a registration process in itself, even without the enforcement, without the other procedures, we have managed almost half the country now at least have had a contact with the registration process. They get curious. They want to learn more. So we want at least people to understand what it means before we proceed to the issue of payment. So the issue of payment now is the next phase which you're moving into once people have familiarized themselves with health insurance. And as you remember, a lot of misinformation is out there. So people need, even with the misinformation, the correction process for the misinformation is people actually interacting with the healthcare system. In the fourth question about what SHA is actually covering. So one of the reforms that was done by the act which we went through was to ensure that the benefits that the population enjoys is well documented and is available to the public, away from what we had before, where we didn't have any information on the public on what is covered, and the public could actually get different packages at different times. So this time round, we have a benefit package which is actually explicitly available to the public. It's actually published, and in that document, which is actually legislated by law, you will find that you will have for each condition that is covered, and for each condition covered, how much is covered within that condition, and even up to what is the limit that a person can get. For example, if you look at the issue of a normal delivery, you will find that we have defined that a normal delivery can be covered. We have defined the reimbursement rate for a normal delivery, which is 10,000 shillings, both across public or private sector. And the limit, for example, once a normal delivery is conducted, you cannot claim the same within the financial year. So those limits are also included. So the benefit package is very large. I think for panels to understand how large it is, it would need like half a day for us to go through that presentation of the benefit package. But at your own time, the benefit package is published and is available both at the National Assembly's website, the Kenya Law Reform website, and the Social Health Authority website. So if you just Google benefits and tariffs, you will get that document with all the conditions. And yes, it is true the conditions have limits. So for example, per household, the limit for oncology, which is the cancer, per year, the limit is 500,000 shillings. So you cannot exhaust 500,000 shillings. And then for other conditions, they have specific reimbursable rates. For example, for a surgical procedure, a hip replacement, I think they have reimbursement of 400,000. You cannot exceed that. You can only go below that. But you can, a facility can get up to 400,000 shillings for each hip replacement. So that document has all these benefits and their tariffs published therein. And with that, I think the other questions I have touched in between the last two. So I take it back to you, Chair.
Thank you very much, and for the comprehensive answer of response to the questions. Now, unfortunately, due to time, we cannot take any more questions. We have already short time. So I'll request that anybody who has any burning question, they can be compiled and sent to the presenter, and who will hopefully respond to them. So I'd like us to move on to the first. So before we end that, once again, let's give a round of applause to our plenary speaker. Thank you very much, Mr. Kaboro, for gracing our occasion. And so I'd like us to move on to the next presenter, who is speaking on innovative healthcare financing models and their impact on access to healthcare in Kenya, more or less a continuation of our first session or presentation. So I will ask Damalin Oma, are you here? Yes, please come to the podium, and then I'll request the Secretariat to project the presentation. Thank you. So Damalin will be followed by Daniel Kurui and then Joseph Ndongo. Welcome, Damalin.
So how beautiful upon the nursing hall of this campus are the feet of us, the presenters, who bring the good news of proclaiming peace and equity through our researches to the nation. Hello, my name is Damalin Apoda, and my concern today is about innovative healthcare financing and their innovative healthcare financing models and their impact on the access to healthcare in Kenya. So, in the introduction of this research, access to affordable and quality healthcare remains significant challenge in Kenya. It's true. And according to the World Health Organization, over 35% of Kenyans still face catastrophic health expenditures due to high cost of out-of-pocket payments. Furthermore, this is regressive and often push poor households into debt or cause them to go for treatment. And also, the Kenyan government has prioritized, as my senior most, Mr. Stephen Kaboro has said about the National Health Insurance. It is all about carrying financing reforms under the Big Four agenda, which was under the initial former president, Uhuru Kenyatta, was to concern about health and also to lean as well to the universal health coverage policy framework. That is all about my introduction. And why am I saying about innovative healthcare financing models? The statement problem is, despite Kenya's commitment of achieving universal health coverage, healthcare access remains inequitable, particularly to who? For the low-income population. And most of all, we find that we are all witnesses in hospitals. People enter into their pockets and to pay for their bills so that they may cater and also finish their arrears, and making that a financial hardship and delaying healthcare seeking behavior. So, innovative healthcare financing models, what are they? Apart from the health insurance scheme that we have heard about, the Social Health Authority, Social Health Insurance Fund, we also have public-private partnerships, and we also have community-based health financing that also all of them, they have emerged as a potential solutions to accessing healthcare. Furthermore, we have transitioned from 2023 from the National Health Insurance Fund to now the Social Health Authority. I'm justifying this is because innovative healthcare financing models, including Social Health Insurance Fund, community-based health financing, public-private partnership, have demonstrated to enhance financial risk protection and improve healthcare affordability and expand the coverage, particularly for the low-income populations. The community health-based financing, social health insurance fund, public-private partnership. Those I'm going to dwell in it. And however, the effectiveness, sustainability, and also the equity of these models remain under research. So this study aims to fill this gap by assessing how are these models influence the healthcare access and affordability. So my general objective concerning these models is to assess what is the impact of social health insurance fund, what is the impact of community-based health funding, what is the impact of public-private partnership in Kenya. And also, to evaluate, the specific object is to evaluate the effectiveness of these models and enhancing their access and how their access are they, and also what are their financial protection. Furthermore, my other specific objective will to be identify what are the challenges of these models when they are being implemented in Kenya. And also to propose policy recommendations, in which I thank also my senior most, Mr. Stephen Kabora, has spoken about, in which we shall just brush up with it, to propose policy recommendation for the optimizing innovative healthcare financing models in Kenya. So according to my research methodology, I used mixed methods in each quantitative surveys through the records that are being published at the website, the qualitative interviews from healthcare providers that are from different health institutions, and also from the 10th healthy policy makers and also health insurance officers. And the scoping is using from those counties, from instance from Kisii, Kiambu County, Nairobi, Siaya, Kajiado, Mombasa, those of the counties that are used for geographical scope. And my data analysis will be descriptive statistics for quantitative data, thematic analysis for interview transcripts. So I will proceed to my findings. And according to the effectiveness of social health insurance fund, it has shown an impact that reduction of out-of-pocket spending, it is 45%. And also the increase in outpatient utilization, most especially the primary health care, has increased to 30%. And furthermore, it has improved the financial protection among the insured households, knowing that if I am insured in SHIF, I can access healthcare finance, I can access healthcare in a primary healthcare facility, or I'm referred to other level 4 up to level 6, and that is according to the effectiveness of social health insurance fund. And what is the effectiveness of this community-based health financing? It has emerged that 40% more have primary access, community. And if I say community-based health financing, community-based health funding, what is this? I believe that we come from different communities, that we have certain that we are going to introduce a circle. For instance, when you take, for example, in Langata, we have New Blue Angels, in New Rafiki Jamii, we have different Shining Moses, those different circles that they are community. And as the well, when one is getting, for example, when one in one of the group member in the community circles is sick and unable to fund funds, through those circles, they're able to raise funds that will able to cater the ailment bills for the patient in hospital. Furthermore, the effectiveness of community-based health financing has also reduced the preventable admissions. The cases of diseases that can be preventable has reduced to 20%, and that is a good initiative. Concerning the effectiveness, apologize for that, for the effectiveness of primary, for public-private partnership, we have seen that it has increased patient visits. Which examples? What are the examples of public-private partnership? For example, in Makueni County, they have partnered with the Philips and also with the AMREF for concerning their funding. And also there's an initiative of Shoe for Africa Children's Hospital, which is in Eldoret County, that is also concerning to reduce about diseases and providing more funding for those in the hospital in Eldoret. So what are the effectiveness of those examples of public-private partnership, it has increased 50 patient visits, and also it has a rise in medicine availability by 20%. Now here comes to the implementation of the social health insurance fund, community-based health financing, and also public-private partnership. So, according to the population of Kenya, 38% are unaware of these existing financing models. That is so interesting. That 38% is still a good number, and 25% reported unaffordable premiums they cannot pay according to their income levels. They are out of their hands. And also, the implementation challenges, it is about digital illiteracy and limited rural access is still persisting. I'm sure that we go as healthcare providers to the northeastern, where there is no about electricity, there is no about digital, and then you just introduce about it. You say that Social Health Authority, it is a fund that came, it is digitalized, and they don't have a literacy of digitalization. It will be a disadvantage to them. So, concerning my proposed policy recommendation, I will suggest that subsidize of premiums for low-income groups. For now, the premiums are now, it is 2.7% that is coming from the income. It is catering where it is catering where to, the income levels, whether you are getting 20,000 per month, 50,000, you have to be removed at 2.75%. What about if we reduce to 1.5% to the low income groups who are not able? How will it be? What will be the implementation? What will be the impact? So that is my suggestion. And also, to enhance counties, to enhance themselves about public-private partnerships and community-based health financing. For example, I will emulate and congratulate Makueni Care that they innovate about giving care for free, and you are contributing 500 shilling annually in the age bracket of 18 to 24 years. And when you go to visit the healthcare facilities, you are getting your medication because of the county has improved a system that is emulating. And also, even it is also happening in Murang'a County, and also I congratulate to those counties for emulating. And also for that, the counties partnering with other donors so that they may raise funds. Like also, I congratulate Makueni County, partnering with Amref and also Philip to raise about funds. It is a good step. And furthermore, ensure adequate funding and timely disbursement through the county government, given through hospitals, because the aim of health provider is to save a life, to prevent diseases, to cure. So when things are sent at a timely, the diseases are able to prevent it. And furthermore, when you send, for example, you may have in a hospital, you have the building, it is halfly equipped, and you want to do cancer treatment, but you want to do the cancer treatment, but you don't have the facilities. How will it be done? But if it is being given timely and being given adequately, it will be able to do. And furthermore, as I conclude, that building capacity of healthcare workers, administration through trainings. Yeah, we build capacity through training, and iron sharpens an iron. And also enhance awareness of campaigns in local languages about Social Health Insurance Fund and Social Healthcare Authority. If I go to my county, where I come is in Siaya, and then I proclaim about I say what is concerning this model in my own language, there is effective communication I'm bringing. Unlike if I go to Northeastern, I'm not aware of those language, but when I enhance through the language they understand, effective communication is placed. And also in my conclusion, I'll say innovative models enhance across and reduce financial strain. Disparity still there, that's persisting. Tailored implementation is vital. Each county must adopt a model that reflects their reality. What it is may be working in Wajir is not the same in Nairobi, it's not the same in Siaya. So counties coming with their models, it's on a good stand. And with political will and good investment, Kenya can achieve universal health coverage. Thank you. May God bless you. For any question, feel free.
Thank you very much, Damalin. We'll have a question and answer session. So we'll ask every presenter to remain until the session is over, because so that you'll be available to answer any. I would like to just offer a very special recognition to our students. That was excellent. I think let's give her another round of applause. Thank you very much for representing the entire student community, and in particular KMTC Gatondo. And guess what? Your principal is here to support you. I'd like him to wave. Where are you, principal? Yeah, thank you very much, principal, for supporting the students. And please, the rest, it's a call for all the rest to follow suit. Thank you very much, Principal, for the great support. All right, so we'll have, our next presenter will be Joseph Ndongo. Joseph Ndongo, where are you? Okay. Oh, so the next presenter is Daniel Kurui. Yeah, kindly come, and let's try to.
Distinguished delegates and our online participants, good morning. Good morning again. Yeah, I'm here to just ride on the other presenters. They have done very good work in issues of health financing. I'll be just diverting a bit and talk about cost of training. So we are examining the cost of training a Kenya registered nurse midwife in Kenya Medical Training College. And we are I'm presenting a pilot study report on behalf of my colleagues. And you have seen we are quite a number. Some you may know, but these are a multidisciplinary team. Consists of mainly lecturers and managers in KMTC. We are trying to just find what is the cost of training one of our programs. Next. So in the background, we are saying that World Health Organization has projected that there will be a global shortage of around 1.8 million nurses and midwives by 2030. And Africa will be experiencing the most significant shortage. And so how will we be able to address this? Is that if we know the cost of training, then it will be more important so that you are able to be able to look for resources for training this. And Kenya Registered Nurse Midwifery course is offered in KMTC Pwani, Mother, Consolata colleges, and in KMTC, it is offered in 5 campuses. So the program is mainly tailored towards mitigating on the poor MCH indicators. And this study is mainly to establish the cost of training and running KRNM. And what are our objectives is mainly to establish the institutional cost of training. And of course, we wanted to find the preliminary cost, and then which are the key cost determinants, and then we quantify this. And then our research question is, what is the cost of training a registered nurse midwife in Kenya Medical Training College? Next. So PICOT summary of our methodology, who our population, that is the two campuses, who are, I mentioned this is a pilot study, so we used two campuses. Intervention was training of KRNM. Comparator, we are not comparing to any. And then, of course, what is of outcome is that we want to find the cost of training. And then that is our time of reference was 2021, 2022. And what is, of course, our reference in this, we are using mainly the GIAS, that is Consolidated Health Evaluation, Health Economic Evaluation Checklist 2022, which give these summaries. Next. So our methodology, this is a quantitative cross-sectional study, and we are just collecting routine data, which we usually generate in our campuses. And so we have mentioned that it is routine data of 2021, 2022, which we obtained retrospectively within the two campuses and KMTC headquarters. So the custodian gave us the information, and we were able to complete a checklist. I had mentioned the CHEERS 2022. This is a popular guideline for economic evaluation so that there is uniformity. And so this, the data once we had, we were able to fill into Microsoft Excel template, and then we also use the same to analyze the data. Yes, next. So, of course, very important when you are doing evaluation is to give some assumptions because generally when you are doing costing, you are doing estimation. It cannot be very exact, so you may need to declare some of the assumptions. And our assumptions was that the land, is pre-acquired. And then the cost we mentioned is that it will apply, proportionately as per the number of students served. That is from KMTC headquarters to the campus and then to the department. So there is the cost which the KMTC headquarters incur, then the same to the campus as a general, and then now the Department of Nursing. Then also asset appreciation and depreciation was excluded because we used what we call, the evaluation reports, which already the institution had already done. And then we also, issues of theoretical skills, we were costed at 1,000 just as part of our policy. And then utility expenses were uniformly allocated to the students, irrespective of whether they're boarding or not. And then MOUs and strategic plan, or it was taken that it takes 5 years, and so a fifth of the cost was used. And then the assets were annualized and replacement value added. And so with that, next. So those are our results. We got our cost drivers. Our cost drivers, we have 7, that is, as already mentioned, including personnel, transportation, then the 7, and then the last is the houses, the building. And you can see the greatest of the building, which we said is the annualization, replacement value, and then you can see also the personnel cost is. So next. So our discussion, what is the cost? You see the cost of KRNM is around 209,000 to train one student. And the cost drivers, we will see personnel, infrastructure, and the curriculum. Of course, almost you saw from the findings, all the campuses are almost the same. But what we need to take is that it costs us 209,000 to train. Next. Our conclusions that it is possible to do costing, and that is KRNM cost can be quantified, and then cost drivers identified. And then this will, of course, refine the tool which we are able to now use in the main study. And more importantly is that this tool we can replicate to cost other programs. And we have seen it is doable. Then lastly is that, of course, we have quite learned a lot. As a team, I mentioned we are a team of 13, and then we did also scoping review, which we added some more members. And we have moved together, we have learned, we did research ethics and evaluation, economic evaluation training, which are some are mainly done online. And then we also did a webinar. So we are in the process of our analyzing our main study findings. Otherwise, thank you. That is our findings, and thank you for listening.
Thank you very much. Thank you very much, Mr. Kurui, for that presentation. So our next presenter is Lynette Madenge. Lynette, please come. Who will make a presentation on mental health status and associated factors among youths in Kiambu County. So let's listen over to you, Lynette.
So, honored guests of the annual conference, all protocol observed, I'm here to wave a tale of the mind and the heart. My paper titled Mental Health Status and Associated Factors Among Youths in County Kenya reveals the plights and struggles of our youths in Kiambu County, Kenya. Here is where the struggles of our youths meet the light of hope, and let us journey together as we unveil the possibilities of a better tomorrow for our youth. So let's get into it. Onto the background information. So mental health status is defined as a person's emotional, behavioral, and psychological well-being at a given point in time. That is the standard definition by the WHO. And then the core aspects of mental health status, there are 3 core aspects. That is the cognitive, the affective, and the behavioral. And then what are these factors that contribute to a poor or not ideal mental health status? Those will be trauma, genetics, and some environmental factors. From there, we go on to our problem statement. Why mental health status? Why the youth? And why Kiambu County? This is because globally, 10 million people alive attempt suicide, and 1 million of these actually kill themselves. And then suicide is a major contributor of deaths, and it is a second leading contributor to the global burden of disease. That is according to WHO. Also, Kiambu County in the year 2021 accounted for 109 of the 483 suicide cases reported in Kenya. That is a report by the Director of Criminal Investigation, by then Dr. George Kinoti. Then justification. So Kiambu is among the counties with the highest number of mental disorder, accounting for 109 of 483 suicide cases in 2021, indicating a major challenge matters mental health among the youths in Kiambu. Then our Kiambu are prone to mental disorder. This is majorly because of a spike in substance use among our youths. Then we have limited studies pertaining mental health status in the county. Then the objectives, the broad objective was to determine the factors associated to mental health status among youths in Kiambu County, Kenya. The specifics were to determine factors associated, whether there is an association between socio-demographics, family-related factors, and environmental factors to mental health status of youths in Kiambu County. The research question were is there an association between socio-demographics, family-related factors, and environmental factors to mental health status in Kiambu County, Kenya? The methodology, the study employed a cross-sectional study design. The population, the study population were youths aged 18 to 24. That is the standard case definition for a youth by the WHO. Then the sampling technique, the study was done in Kiambu County, which was purposively selected, Gatundu South Sub-County, which was also purposively selected, and the study was specifically done in Kiamongi Ward. Then data collection was done through structured questionnaires. Reliability was ensured through a pretest. Then analysis was done through SPSS, Microsoft Excel, where inferential statistics was done using chi-square tests. The results revealed that 78% of the youths in Kiambu County had poor mental health status, while 22% of the youths had an ideal mental health status. How did we measure mental health status? We used a Likert scale, which was a 7-aspect tool to assess mental health status among the youths. Then the conclusion is that among the youths age bracket 18 to 24, 78% of course had poor mental health status. Then the factors that are significantly associated to mental health status were socio-demographics. We had age, we had level of education, we had marital status, and then the family-related factors, there were unsupportive families. Then the environmental factors, we had bullying and discrimination, and safety of neighborhood. Then access, lack of access to mental health services. Then we go to the recommendation. The study recommends that the county government of Kiambu should consider scaling up affordable, accessible, community-based, and youth-friendly mental health services. Then campaigns should be done to emphasize the role that family plays in mental health status. Also, the last point, policies should be formulated to address youth unemployment in Kiambu County, Kenya, and substance abuse in Kiambu County, Kenya. This is also a recommendation for further study. My study recommends that a further study be done to determine the association of substance abuse and mental health status. Then the study took into consideration several ethical aspects. The study sought a permit from NACOSTI before data collection. The study also ensured confidentiality of the respondents. Informed consent of the participants was sought, and the study also sought permission from local authorities. So thank you very much for your time. That was mental health status in Kiambu County, Kenya.
Once again, well done, Gatundu Campus, for doing ensuring that students actively participate in this conference. All right, so our next speaker will be Jonathan Taiswa. Please welcome Jonathan. Jonathan is speaking on factors contributing to malnutrition among children aged 0 to 59 months, attending child welfare clinic at Siaya County Referral Hospital. Welcome, Jonathan.
So good morning, all of us.
Apologies. I just want to advise, to remind the online audience, please post your questions in the Q&A, not on the chat. The chat is disabled. So for any questions, use the Q&A option. Thank you.
So thank you very much. My name is Jonathan Taiswa. I'm a nursing lecturer at KMTC Siaya campus, where the first robust presenter comes from, but he's schooling in Gatundu. My research presentation today, which will take very little time, about 10 minutes, is on factors contributing to malnutrition among children aged 0 to 59 months attending the child welfare clinic at Siaya County Referral Hospital. So as part of the background, it is interesting to note that in 2022, 149 million children under the age of 5 were estimated to be stunted. That means short for age. Another 45 million were estimated to be wasted. That is also too thin for their height. And 37 million were overweight. That is according to WHO in 2022. And this is also in line with the rising burden of non-communicable diseases. But half of deaths, sadly, under the age of 5 are attributed to factors around malnutrition. And most of these deaths occur in the middle and low income countries where we belong as Kenya. And in Kenya particularly, there is 35% of children who are malnourished under the age of 5. And in terms of ranking, Kenya is ranked 13th with the highest number of children with malnutrition, according to UNICEF in 2017. And more, malnutrition is prevalent more in ASAL counties. However, the reason we did this in Siaya is because Siaya is coming up. It's not one of the ASAL counties, but it's coming up posting high numbers, especially in terms of malnutrition. So the objectives of the study were, number one, was to assess the level of knowledge on child nutrition as a preventive measure, of course, by parents who have children attending the child welfare clinic. The second one was to identify social-cultural and also economic factors that could contribute to malnutrition among these children under 5. And lastly, to identify any medical-related factors that could contribute to malnutrition. As a progress, we adopted a conceptual framework from UNICEF 1999, which basically highlighted some of the things. In red on top is the outcome, that is the either maternal or child undernutrition. And we have immediate causes there, like inadequate dietary intake, disease, and also we have underlying causes, including income, socioeconomic issues, and also political and social concerns. And in terms of methodology, we preferred a descriptive cross-sectional study design with, of course, taking the most famous Fisher's formula for our sample size calculation. A simple random sampling was done. A ballot method was used to recruit participants into this study. So basically we used a list of children with malnutrition to form the sampling frame, and therefore any of those members had an equal chance to be selected. And ethical approval was also sought, and consent, because we are dealing with very, very sensitive matters, were also sought from the parents. All parents who were diagnosed with malnutrition, at least for the last 6 months, were included in the study, and those whose parents whose children are too sick were excluded at the time of the study, being a cross-sectional study. We collected these using validated questionnaires, using two research trained research assistants, and our collection time was 10 clinic days, a clinic per week. So almost those are 10 weeks done in from February to April 2025. We cleaned the data, entered into Excel spreadsheets, and analyzed the same. And we were able to present data in bar graphs, pie charts, and statistical tables. In summary of critical results as per the objectives were that 88 participants participated in the study, of whom 34% of the respondents were aged between 25 and 35. It goes without saying that, of course, the dominant parent was a woman, and therefore we congratulate women for the good work they're doing in the CWC clinic, we rarely see men there, I don't know why. Then 40% of respondents demonstrate good knowledge in child nutrition, still a concern to us. 38% of these responses attributed malnutrition to poor feeding, of course in line with other studies, but interestingly, we still have in our country, particularly in Siaya, some people thinking that malnutrition could be coming from other black sources like witchcraft. 72% of the respondents blame to the lack of diet to fight financial challenges. So in terms of diseases that are attributed to this, we had malaria, we had also sickle cell, HIV, are some of the medical conditions that are attributed to this. 72% of women breastfeed faithfully up to 6 months of age. And we only have 31% of children breastfed to 2 years as recommended by WHO. In conclusion, therefore, the first objective was to see or to assess the level of knowledge, which we still find an issue. The second objective was to look at cultural or socioeconomic issues, and we point out cultural influences and also financial issues as one of the barriers or associated factors to malnutrition. And lastly, our other objective was to identify any medical related source factors, and we see malaria, HIV, and sickle cell disease being very important diseases when it comes to malnutrition. And therefore, we do recommend that we enhance educational programs to enhance the education. We also strengthen the child welfare attendance and up to 5 years. And those are some of the references. And thank you very much.
Thank you very much. Thank you very much for that presentation. So our next presenter is Florence Gemelli, but this will be presented by someone else. He will introduce himself. The topic is factors influencing adherence to renal diet among outpatients in renal unit, age 35 to 70 years, attending Kapsabet County Referral Hospital. So welcome.
Principal, Kenya Medical Training College, staff and students, good morning. My name is Alex Kibet. I'm an external lecturer, Kenya Medical Training College, Karen Campus, and I'll be going to present the above research study that was actually done by our higher national diploma student in renal nutrition. So the topic, as you can see, is factors influencing adherence to renal diet among outpatients in Kapsabet County Referral Hospital. So it was actually done by Florence Gemelli. This is not my original work, but it's actually through my guidance together with Madam Jane Nyabuti, the Deputy Principal, KMTC Karen Campus. So the next slide. So on the background information, looking at CKD, it's actually a major global public health problem affecting approximately 840 million people globally. So remember, this actually translates to 11% of the world population. So remember, CKD is actually defined as, is actually evidenced by the kidney damage or a decrease in glomerular filtration rate of less than actually 60 ml per minute per 1.73 meters square, and actually lasts for more than 3 months, according to KDIGO 2012. So the prevalence, remember, is actually rising. Remember, the causes actually include diabetes, hypertension. We also have the aging populations, especially in low and middle income countries. So remember, actually, if you look at the CKD, is also referred to as the silent disease, because many individuals actually remain asymptomatic until the condition is actually at advanced stages, majorly stage 4 and 5, where the CKD is actually mostly severe. So the next slide. So looking maybe at prevalence, maybe we actually looked at global, narrowing down to maybe Africa. In Africa, we're actually having 10.7% of the population being actually affected by CKD. So as you come up to Kenya, in Kenya, we're actually having an insignificant amount of the population, but it's actually affecting, if you look, it's actually a great number, but it actually looks small, but it's actually a great concern to the Kenyan population, bearing in mind that we are not only struggling with lifestyle diseases, we are also struggling with also undernutrition and overnutrition in Kenyan population. So adding over to CKD is actually becomes a burden to the Kenyan population. So remember, if you look at, we actually have the management strategies, we actually have the conservative management that's actually typically applied to patients in their early to moderate stages. That's actually CKD 1 to 4, or those who choose not to undergo dialysis. But you also have for ESRD, end-stage renal disease. That's actually where the GFR falls below 10 mL per minute. We actually have the renal replacement therapy that actually have to take place to sustain life of that patient. So dietary management, remember, just back. Remember, dietary management actually remain a cornerstone, a gold standard for management of CKD. Even with drug therapy, you actually have to look at drug management to be able to help these people. And therefore, adherence to renal diet, friendly diet, is actually very essential to manage CKD. So continue. So under the problem statement, the renal patients usually struggle to follow prescribed renal diets according to Lambert 2017. So most of the key barriers are highlighted by these two authors, Kalanta and Forkey 2015. We actually have the socioeconomic constraints. That's actually the low income, limited education. We also have cultural food beliefs and personal motivation issues. They're actually not motivated. So remember, overall, maybe afterwards, you actually have fluid overload. If you don't actually do management, we actually have electrolyte imbalances and actually increased hospitalizations among this population. So we also have limited understanding of how individual or contextual factors affect dietary compliance, specifically among renal patients, if you try to look in the context of Kenya and why we did this research. So the purpose of the study was actually to assess the factors that influence the renal diet adherence in outpatients aged 35 to 70, Kapsabet County Referral Hospital. So the specific objectives, number one, to establish the social demographic and socioeconomic factors of these patients. We also have to determine the dietary factors influencing adherence to renal diet, and then to assess the association between the social demographic and the adherence to renal diet. So on the justification, dietary adherence is actually essential in management of CKD. Remember, it actually slows down progression and also reduces complications such as the cardiovascular diseases. So adherence, remember, it actually remains low due to the factors like the socioeconomic status as reported by Lambert and limited nutrition education. We also have understanding these barriers among CKD patients is actually very crucial for developing actually targeted interventions in Kenya. So this is actually our conceptual framework based on our objectives. This was actually developed by the student with my guidance. So you can actually be able to look at how independent variable actually affect the dependent variable, which is actually adherence to renal diet. Continue. So study design was a cross-sectional study design. Continue the next slide. Study area, this was Kapsabet, Nandi County. Continue. Inclusion, we actually included patients 35 to 70 years of age. Exclusion, anybody who fell outside this inclusion criteria was actually disqualified or was actually too ill, was not part of this study. So sampling and sample size, continue. So we used a simple random sampling to select these patients. But remember, the student actually, if you look, you actually use the Cochrane formula, amounting to 369 respondents. But remember, the student actually used 73 respondents because of the constraints that actually limited the data collection. So continue the next slide. So pre-testing was actually done in Kaptuma sub-county, and data was validated by supervisors. Reliability checks was also done. Continue. So data analysis was done in SPSS version 29. Remember, before data collection, we also had to obtain permissions, NACOSTI, County Director of Health, County Commissioner, and also informed consent. And actually, we ensured confidentiality of these questionnaires or any data from these patients. Continue. So the findings. So you can actually look at the social demographic characteristics of the respondents. The number was just 73. Looking at the male, female, the female were actually more, half of them were actually female. The education level, most of them had actually gone to tertiary education. Continue. Continue ahead also. So we can also be able to look at the dietary practices. We looked at frequency of meals per day, the snack intake between meals, the types of snack consumed. You can actually be able to look at the fruits were actually majorly consumed. And also on the food preferences, the food dislikes. Just go on the next slide. On the food dislikes, you actually have they actually dislike some of the foods. We shall actually be able to look at them later. The major meal preparation method, which is actually very critical in renal patients, the boiling was actually mostly used. 45% actually used boiling. Continue. So dietary adjustments after a post-diagnosis, you can actually be able to look. Engagement in physical activity were more than 50%. Okay, sorry for that. So continue looking at the associations, which is actually our major. We actually try to associate the social demographic and socio-economic. You can actually be able to look at the education level was actually highly associated with actually dietary practices, meaning that the more you are educated, the more actually you are actually practiced or actually had good dietary practices among this patient. And actually, if you look at other factors, other social demographic, there was no significant differences among the variable. Continue. So association between social demographic and dietary factors, you can also be able to see there was no actually a significance there under that one. There was no association there. The next slide. So discussion, continue the next slide. So looking maybe on the meal frequency, most participants consumed more than 3 or more meals per day, which is actually as per the recommendations. Remember, we also encourage small frequent meals to avoid overloading the kidney. Continue. Continue the next slide. So looking at discussion, maybe you can actually, a small discussion on that, you can actually be able to look at the major factors that are actually associated with actually p-values that are actually less than 0.05. But if you look, there was actually no significant associations with other factors. If you try to look at the food allergies or meal preparation also, and also education level and meal preparation, you can actually be able to look at it. It was actually at the borderline. The P was actually 0.085. Meaning that there's actually a significant association between the two with education level. Continue. Continue. So recommendations on the policy and program implications, public health nutrition programs should be prioritized, education-based interventions. Remember, education was actually highly associated with this, with dietary adherence. Also consider incorporating practical cooking and meal planning skills, especially to populations. If you look at the p-value, there's actually a borderline. It's actually close to being, to actually bringing that association. Continue. So thank you for that paper. So maybe something just to add shortly, some of the limitations of this paper was a small sample size was used, but in future, a bigger sample size can actually be used to establish the association between dietary adherence and the social demographic variables. Thank you so much.
All right, thank you very much. Thank you for the first presenters, or rather the presenters in the first session of the day. So we are through with all the presentations. In your program, there is one of the articles is by Joseph Ndongo. It's actually a poster. And so we'll invite you during the breaks, please make time to look at the posters. They are out in the foyer. So Mr. Ndongo's presentation is actually one of the posters. So kindly access it there. So we'll just have a very short time to have to answer any questions to the four presenters who are right here. So they are ready to answer your questions, and we'll limit, and for the responses, please just take about a minute to respond to the questions so that we catch up on time. All right, so any questions from the audience here? Online also, you're invited to send in your questions through the Q&A option. Any questions? Oh, they already have them. All right. So I'll then request them to answer. We will start with, okay. All right. So answer the questions that you have, and just give you 1 minute to respond to them.
I'll start with this one.
Go and sit in.
Okay. Do you have a plan for ensuring? Oh, okay. Okay. Do you have a plan for ensuring the recommendation reach the relevant authorities in Afya House other than publishing? So as I had said earlier, it's a blessed opportunity being here in this conference because it is an international conference, and being a getting opportunity, the conference was being graced by the Cabinet Secretary, Honorable Adan Duale. I definitely believe it will be upholded to the Ministry of Health. And concerning the question that in the utilization of the FAR model, it is only in the inpatient. How can it be in the outpatient? According to the Social Health Authority, the outpatients are being catered mainly in the primary health care centers. From there, when the patient wants to access outpatient services, they start from the primary health care centers. And if the cases is out of hand of the primary health care, they are being referred to the level 4, 5, and 6. And concerning that, they're asking about the initiatives of women. In the past, concerning there was Beyond Zero initiative, which they are using mobile clinics to go and access the pregnant women in the communities, mostly, especially even in the Northeastern. So the recommendation is being enhanced that the Beyond Zero, through the Linda Mama, which is under Social Health Authority, to extend their hands about walking to mobile clinics to access women's there so that to get services also to them. And the other question is, how did you measure the impact of the innovative finding models? I'll say I measured using the records being published by the Ministry of Health, by the through Mr. Stephen, who said in the morning they publish how to strategize for healthcare financing. Those implementation records that were being published by Ministry of Health, by the KEMRI and KEMSA, and also the Social Health Authority are the things that I used for measuring, and also using qualitative surveys from different hospital institutions, asking them about the model findings. And concerning were there identified setbacks to roll out of this finance model? I'll say yes, because typically there was an awareness of other models like community-based health financing, and also about public-private partnership, which was not unaware to other people, but because an awareness is not given, so people will stick with only the Social Health Authority, which is the National Health Insurance Fund, the National Health Authority concerning about it. So, okay, thank you. That's my time.
All right, thank you. Let's have the next presenter, Lynette. You have 1 minute to respond.
Just answer the first one, the rest will answer, will interrupt as we take it.
Okay, so what I have is a comment and one question. So the comment is that mental health status is an amazing topic. I would recommend that you consider publishing your work. So what I would say that is being worked on at a campus level. Then the next question is, which tool did you use to assess your dependent variable, that is mental health status? I pointed out, if you're following my presentation, I pointed out that I used a Likert scale, which was a 7-aspect scale, which was scored. So scores between 16 to 35 were categorized as poor mental health status, whereas scores between 7 to 15 were categorized as ideal or good mental health status. That's it. Thank you.
And maybe for that question, you can see her afterwards for the specific tool that they may have, they used.
So answering on the cost of training KRNM in KMTC. So the reason why we are doing this study, this is more of part of the strategic plan. KMTC is approaching 100 years, and basically we know the fees is pin paid, and somehow we need to find what is cost, because from there then you will be able to, we did even you, when you are approaching an investor or whichever, you need to have findings. And again, of course, this is the first costing of, first time KMTC is costing its programs. So from there, because several questions is asking whether which one is more expensive, but from there, from the findings, I did mention that we now have a tool which we can cost all KMTC programs. So this is the beginning, and we should be able to move to programs. Thank you.
Thank you very much. Next presenter. Thank you for keeping time.
In 1 minute, I will only respond to a few questions. One was the intervening variable in this study was demographic characteristics. Somebody sought to know what was the response rate. We had 88 out of 103 follow-up, that is 85%. And lastly, someone is concerned. Are those worrying findings will be able to be implemented? It's our hope. We've identified them, and we've recommended some institutional and also policy level recommendations. Thank you.
Okay, thank you very much. And finally,
Thank you. I'll also take just 1 minute. What was your justification for excluding renal patients below 35 years of age? So remember, the scope of this study was just 35 to 70, because we know that lifestyle diseases actually affect those who are actually older, more than even 35 or 40. That's actually our traditional understanding. But together, if you look at the current generation, we're actually having an emergency or maybe a surge in lifestyle diseases actually among children. So maybe in the future research can actually be able to include that one. So the small also sample size, I actually acknowledge that in my limitation, can actually be part of that, but any future research can actually include a larger sample size. Thank you.
thank you very much. So we want to appreciate all the presenters of, all the presenters in the first session of this morning. So let's give all of them another round of applause. And we earlier recognized the Gatundu campus principal, but would also like to recognize the research teacher, Miss Helena. Where are you? So we thank you very much for that kind of output. So we appreciate that. All right. So I'd want to make an announcement regarding the next activity. So we'll take a short break for tea. So for those in this hall, we'll take tea outside. You'll be directed. And I would request that we just take up 15 minutes so that we are back back by 10:50. So 10:50, we will start the next session so that we recover the time we had lost earlier on. And for the rest, the online audience will resume at 10:50. Thank you. Thank you very much. The principal, Gatundo, you wanted your team here? Okay. All right, let's take a short break. Thank you very much for your active participation. Thank you.
Let's settle in so that we can begin the session. Please come, get in, get settled. We begin.
So good morning and welcome to the second session for this day, or the 8th Scientific KMTC conference. And we will start this session with a plenary presentation. And in fact, our plenary speaker is here in our midst. So I'll go right ahead and introduce him. So this session's plenary speaker is Mr. Omar. He has been the County Executive Committee member in Garissa since 2017. He currently holds the health docket. He is a key figure in the National Caucus of County Executives for Health and represents the Council of Governors in the Global Funds Kenya Coordinating Mechanism, contributing to strategic investments in Kenya's health response. Internationally, Mr. Omar serves on the International Advisory Council on the Alliance of NGOs and CSOs for South Sudan Cooperation. He has undertaken executive training in leadership, health systems, and climate change from institutions such as Harvard Kennedy School, WHO, UNITAR, the University of Melbourne, and the Nosal Institute of Global Health, the United Nations Institute for Training and Research, I've already said that, and the Macab Center for Law and Cancer, with a focus on resilient, community-centered healthcare. He occasionally contributes to columns in the Daily Nation and the Star, offering insights on public health, climate change, traditional medicine, and the intersection of policy, equity, and systems thinking. So today he's going to speak to us about one of our main themes, which is climate change. Welcome, Mr. Omar.
Thank you very much. Good morning. Distinguished delegates, someone will be helping me to moving at the right time, right? Okay, I'll be alerting you. Distinguished delegates, academicians, clinicians, public health leaders, students, friends, and all those who are here with us physically and have joined us virtually. I stand before you today not as a scientist, not as a medic, not as an academic expert, but as you would see, I stand before you as something else entirely. Over the years, my role in policy making has made me wear many hats. And let's say I wore those hats by necessity. There were days I had to be an epidemiologist without a lab coat, or a climate analyst without nothing but just the weather app on my phone and the outbreak sit reps that I'll receive. But more often, I found myself being a bridge between data and decision, between reports and reality, between people and institutions. So today, I seek your indulgence, because this presentation may not follow the traditional arc for such events, that traditional arc of graphs, or conclusions later, the academic statements and all that, because the hat I wear today is not a technical one. It's one of duty. And of course, these 3 days of conference will offer you many graphs, many data sheets, many rigorous models. So take this moment perhaps as a break from that routine. Not a break from science, but a reminder of where science lands. And sometimes where it struggles to reach. I bring you a message about what science looks like through the lens of overwhelmed health systems, in flooded villages, and in crowded camps. So I ask you not to judge this presentation or this talk by citations alone, but by questions it leaves you with. Questions about how we govern, how we prepare, about how, and above all, how we listen to the weather before it speaks in fevers. As the county executive member for health in Garissa County, I'm a witness to growing crisis. A crisis that is quite literally biting us in the form of mosquitoes, ticks, vectors, diseases. This, as you will agree with me, is the age of climate-driven diseases, where viruses travel a lot faster and farther, and fevers bloom with seasons, with weathers, with rains that are unpredictable, or even after those seasons. There was a time when we lived under the comfort of predictability, when climatic patterns obeyed statistical norms, and disease outbreaks aligned with historical trends, demographic distributions, and well-defined geographical boundaries. But things changed. We had failed rains that cracked the land parchment. Then came the rains again. But when they came, they were not so gentle. They came with vengeance. Rivers swelled, latrines dissolved, wells turned brown. Diseases did not emerge by chance. They appeared where systems broke, where sanitation failed, where humans, goats, and garbage shared the same shrinking ground. For instance, we used to think of malaria through the calendar, and you know that this will be the season of malaria. But now we think of it through the weather, an increasingly volatile system whose seasonal cues no longer align with historical norms or epidemiological forecasts. The calendar that weather relies on is not even understood by the weather itself. And it's the same with other vector-borne diseases. For instance, we are currently experiencing an upsurge of dengue fever in Garissa. Perhaps if you go to the next slide. I hope that can be seen, but still it's what I'm trying to take you through. In Q1 of this year, Garissa County recorded 800 confirmed dengue cases. That is a dramatic rise from just 92 in Q1 of 2024. Hope you can see the comparison. 891. That's what I'm referring to as a dramatic rise. Well, Q2 is still unfolding, but already we have recorded 232 cases. This is compared to only 14 cases in the whole of that same quarter last year. So you can imagine that. So I will not call this an outbreak. I will call this, God forbid, an ecological tipping point. If you go to the next slide, please. Then these are the sub-counties in Garissa, and you see the most affected sub-county is that one that is in blue, dark, and in light blue there, the Dab. But generally, I'll take you through what the weather there is so that we get a comparison. So in Garissa Township, we have higher usual temperatures of up to 38 degrees centigrade. Of course, situations of poor drainage. This is actually causing early and persistent water pooling. In Ijara sub-county, the edges of the of the forest rather, experienced warm, humid storms. In Fafi and Hulugo, we saw flash floods, creating shallow, stagnant swamp zones. In the Dab, human-made water storage systems within the camps, we have the refugee camps there, kept mosquito habitats alive even without rainfall. So that's probably one of the reasons why we are having more cases there. Of course, to add on to the climate refugees that we have there and the refugees who were even there before. But what does this mean, and why am I mentioning all this? These are textbook conditions for the Aedes mosquito, which spreads dengue. So what does science tell us about this situation in Garissa? Perhaps we could go to the next slide. And here I will refer to a landmark paper, what I will call a landmark paper, published in 2022 by Ma et al. In the Journal of Biology, which is published by MDPI, Multidisciplinary Digital Publishing Institute, which I'm very sure you know is a credible and well-respected institution. This paper offers a clear scientific lens. This paper summarizes 10 publications on the impacts of climate change on ecosystems and human health. Then it synthesizes the other existing literature to more broadly explain how climate change drives the transmission and spread of vector-borne diseases through an ecological perspective. So the others outline 5 mechanisms by which climate change drives the emergence and spread of VBDs. Let me walk you through them one by one while anchoring them in what we are experiencing in Garissa. First, the paper talks about nonlinear temperature effects. So this may sound a bit technical, but here it's all what's all about. As temperatures rise, the risk of diseases like dengue also rises, but only to a point. That is what is demonstrated there. So it rises only to a point. There's a temperature range where mosquitoes thrive best, usually between 23 and 29 degrees Celsius. But even above that, they can still survive, especially in urban areas where buildings trap heat. That's what we have in Garissa. So in early 2025, Garissa Township recorded temperatures of 36 to 38 degrees. That is hotter than the ideal range, but still well within the threshold of Aedes mosquito to remain active. And when you add poorly drained streets and standing water from short, intense rain, what you get is mosquito paradise. So yes, climate change has made Garissa hotter, but not hot enough to kill mosquitoes, just hot enough to make them multiply. Second, the paper focuses on time-lagged effects. Diseases don't erupt. The moment it rains, climate is like slow brewing recipe rather. It adds ingredients, waits a little, and then serves the outbreak. In January and February 2025, we had early rains and rising temperatures. Then, like clockwork, dengue cases spiked in March. Ma et al.'s research confirms this. Most disease outbreaks follow climate anomalies with a delay of 1 to 2 months. This means our response systems must not just react to disease, they must anticipate. We must learn to interpret rain and heat as early warnings, not ordinarily, just as weather. Third, perhaps we could go to the next slide. You mentioned 5 issues. So the third issue is the U-shaped impact extreme events. This one is important. Ma et al. Show that both drought and flooding can increase disease risk, but for different reasons. When there's too much water, we get pooling. When there's too little water, people store water in open containers. Mosquitoes breed there too. So in 2025, Garissa saw both floods. Garissa saw both floods in places like Olugo and Fafi, drought in Dadaab, and both extremes made life easier for mosquitoes. This U-shaped relationship that you are seeing there between climate and disease means we no longer have safe seasons. Every climate event is a potential trigger. The fourth issue is land use and human mobility. This one hits close to home. Urban expansion into seasonal floodplains, displacement from Somalia, deforestation as the growing population now also from Somalia searches for firewood, livestock moving with drought. All these changes bring humans and disease vectors into closer contact. In Garissa, this is our reality. Our health geography has shifted. Roads now carry disease, markets carry disease, camps carry disease. Disease is no longer a boring visitor, it's a traveling companion. And fifth, is the pandemic aftermath. Of course, the COVID-19, which disrupted everything. Surveillance systems told, budgets were allocated, systems that looked like dengue were misdiagnosed. And once the lockdowns lifted, the disease returned with vengeance and we were caught off guard. So if you're wondering whether this surge is, in dengue is random, I assure you, it is not. It is the outcome of climate dynamics meeting systems fragility. Kwanza ni dengue ama ni dengu? So we are not alone. In India, India is seeing dengue in dry zones. Europe is reporting ticks. You know those animal ticks. Europe is reporting animal ticks in high altitude villages. In Ecuador, mosquitoes have reached towns once too cold to host them. I think we also had a similar phenomenon in Kenya, where high altitude areas experienced mosquitoes. So this is no longer now, we should not be calling a tropical disease. It is, we should be referring to it as a climate disease. Of course, they still remain tropical diseases, but they are exacerbated by climate change. So diseases emerge when systems stretch too far, from deforestation to poor sanitation, from equality to disinformation and misinformation. Madaktari wa TikTok. Outbreaks so don't emerge randomly. They reflect the condition of our climate, of our communities, and of our capacity to respond. Climate change takes every box of what I mentioned just now. It expands the habitat where mosquitoes can live. It disrupts water and flood systems and food systems. It undermines chronic care. You know, it multiplies poverty and of course also multiplies confusion. Climate does not create new diseases. It just uncovers our old vulnerabilities. We used to have those quiet seasons where, as I earlier on pointed to, malaria would come with, let's say, rains, or if the Valley fever will be, you know, will be there with us every few years and will be cyclical. But now, diseases no longer follow calendars. They are chaotic. They follow chaos. Let's personalize them. So climate stress also pressures life to evolve. Mosquitoes adapt, pathogens mutate, drug resistance rises, and in humans, we are now learning that prenatal exposure to heat, hunger, and stress can change how infants grow or in the womb, or the embryo grows in the womb. I think this was some research that was done in northern Kenya. So while research on the direct effects of heat on DNA in human populations in Kenya is limited, evidence from other contexts show that high temperatures can cause DNA damage and potentially alter genetic material. I'm very sure this is something that you can actually pursue and have a look at so that we see what grim situation we are facing or we are in the middle of. So what are we doing wrong? Our methods remain, unfortunately, reactive. When we see cases rise, we scramble. When the flood comes, we respond. When the drought bites, we send relief. Isn't that the case? But climate crisis is not episodic. It is continuous. And our approach must shift from disaster response to what I will call ecological intelligence. We still treat dengue like a weather accident, when it is now an ecological outcome. We build clinics where roads flood. I mean, we aim to provide care, but place the facility in a location where patients and ambulances can't reach it when they are needed most, such as during climate-induced emergency. So you wonder what is the purpose of that health facility. We set response budgets without predictive analytics. We fund vector control after the mosquitoes have long worn. What is the purpose of the budget then? This definitely has to change. Let us make a hard question. Let us rather ask, or let me rather ask a hard question. And this was some of the questions that I was earlier on in my opening remarks was referring to. Does Kenya have a vector-borne control strategy? Maybe we go to the next slide. Of course, yes, Kenya has. And as you can see there are quite a lot of them. You can read them there. But how effective is the implementation? Are these strategies being implemented? Of course, from a point of information, I'll tell you no, it's not effective implementation. And even if it is there, the strategies are there, and even if you had implemented them, then do they align with the complexity of climate change effects? This is one question that I'll actually leave you with. The Global Vector Control Response 2017-2030, developed by WHO, offers an integrated cross-sectoral roadmap, but it requires more than a paper and promises. It requires power and implementation. Annex 4 of that document connects vector control directly with sustainable development goals. Let's try to unpack that. We go to the next slide. Turudi nyuma kidogo. Let's go back. Yeah, tulikuwa hapo, umepatiana like hapo. So yeah, that Global Vector Control Response 2017-2030 by WHO, in Annex 4 of it, if you look at it, of course, it is available online. Out of the 17 SDGs, 12 of them are directly connected with vector control. So you can imagine how demanding vector control is. It's not just that easy task that is so simple. If it cuts across, it cuts across 12 out of 17 SDGs. And some of these SDGs are SDG 1, which is no poverty. VBDs disproportionately affect the poorest. In Cambodia, dengue drove families into debt. Ending VBDs means breaking the poverty trap. SDG 2, which is zero hunger, malaria, kalaza, and lymphatic filariasis. You'll excuse me if I don't pronounce this very well. I think I gave a disclaimer in the opening remarks. Reduce productivity and labor output in rural economies. Healthy farmers feed nations. SDG 3, good health and well-being. Of course, that is very obvious, but more importantly, VBDs account for over 17% of the global burden of infectious diseases. Over 80% of the world's population is at risk of one or more VBD. SDG 4, quality education. Children who survive cerebral malaria may have learning disabilities. SDG 6, clean water and sanitation. That's very obvious. Stagnant water is a mosquito factory. Drain swamps, piped water, sealed containers. These are tools of disease prevention. SDG 8, decent work and economic growth. A 10% reduction in malaria boosts the GDP growth. The economics of health is not charity. It's always an investment. SDG 10, reduced inequality. VBDs hit the bottom billion hardest. Ending them narrows the health divide. This is what we need to do so that we achieve health equity. And I think that is in line with the theme of this conference. SDG 11, sustainable cities. We must design urban slums not to incubate disease. This is what we are doing now, unfortunately, because of our poor planning. So that means drainage, waste control, and intersectoral planning is supposed to be well taken care of. SDG 12, responsible consumption. Waste removal is a vector control strategy. Less waste, fewer breeding grounds. SDG 13, climate action. Climate change makes VBDs unpredictable. Policies must account for that. Mitigations must come before medicine. SDG 15, life on land. Deforestation has unleashed vector habitats, biodiverse Kambafa disease. And finally, SDG 17, partnerships. The most successful VVD programs are built on coalition. No, as you will see later on, no single ministry can fight VBDs alone. It's not a health matter, but we will come to that. So in short, what are we saying? From this, what we are saying is that vector control is a development work and must involve multiple sectors. So How do you implement this in real life? In the same report that I'm referring to in the Annex 5 of the WHO framework provides a clear list of actions beyond the health sector. It lists the works of the Department of Public Works, Waste Management and Environmental Sanitation teams, the private sector, the Ministry of Education, Ministry of Agriculture, Ministry of Livestock, Ministry of Housing and Microfinance, Ministry of Local Community, the local community groups, so forth and so on. This is what it mentions. For us to have an effective vector control. And that is what an integrated vector control strategy looks like. What we are here today, talking about VBD probably, or in even our ministries, done by the Ministry of Health alone. Can we surely win that war against the vector control? Is one of the questions that we need to ask. So integration does not happen in workshops. It doesn't happen in, it happens in mandates. It happens in shared dashboards by multiple sectors, in WhatsApp groups, where health officers talk to meteorologists. I ask myself often, how do does the health sector come into contact with the meteorology department? How often? This is supposed to be very regular. This integration, more importantly, and as our policymaker, I would say, must be in performance contracts that reward anticipation and not reaction. In those performance contracts that you're having, you should not be asking officers what they have done to respond, but rather what actions they have taken in anticipation. And that's what I mean, that reward and anticipation and not just reaction. We must no longer ask which ministry owns this. We must ask who else must be in this room. Who is missing in this room? This is what we must ask. And above all, we must finally honor the climate or the weather health nexus. This is really important because this is one issue that we keep on denying and ignoring. Why? Because the sky has always spoken. Of course, it has. It told us when to plant, right? It warned us when to harvest. It can also now tell us when to prepare for fevers and diseases. That's the reality. Unfortunately, that's what now the sky has become, thanks to climate change. So we need to digitize this dialogue. We need to have our community health promoters receiving alerts from weather satellites. Let rainfall forecasts be uploaded to hospital dashboards. Is that really happening? And let farmers and nurses read the same data. Do our farmers and nurses, for instance, or our frontline health workers read from the same script, reading the same data? This is not happening. So it just shows you the long way that we need to go. Climate intelligence must be built into public health, just like the thermometers and the microscopes and the stethoscopes. We must also have that climate intelligence inbuilt in health systems, because when the rain changes, so do the mosquitoes, for instance. And when the mosquitoes change, the maps change. This is the reality. And that is why when I'm talking about maps changing, that is why we are having diseases in areas that we never used to have. So what do we do? Tuende kwa ile mahali umeliki sasa. What do we do? This is what I will propose, the 4 R's. Rethink our training, redesign our response, redefine our readiness, and reclaim research. We will go into each of them. We need to rethink our training. Climate health must be part of every curriculum. From the health education or empowerment that we provide community health promoters to workers, the clinical officers, the lab technologists and technicians, the nurses, so forth and so on. They need tools that can track weather alongside symptoms. Let them learn that rainfall is not just a hydrological event, it's an early warning. Unafaa kuingiza baridi kama mfanyakazi wa afya, ujue kwamba saizi mambo yatabadilika na yatabadilika tofauti na vile ilivyokuwa hapo awali. Let the syllabus teach that a dry spell can spike or humidity can awaken dengue, or let the training be adaptive. This is what I mean. Let the training be intuitive and ahead of the surprises of climate change. Climate change is surprising us. Let us surprise it before it surprises us. This is what our training and our curriculum should do. Secondly, we need to redesign our response. For instance, we are in the age of AI, so we need to we need to use AI to match disease trends with weather forecasts. Let us not wait for the rain to flood, to be flooding everywhere, including our health facilities. Let us act before that fever. Let the dashboards light up before ambulances do. And I want this to sink in. Let those dashboards that you are seeing, that you are monitoring, light up before we see those flashlights on the ambulance lighting up. We need to be that much proactive. And let climate be our call bell, not our postmortem. Thirdly, we need to redefine our readiness. And how do we do this? It's not just about protocols, but posture. Let us power. We are already doing this. I mean, as you are trying to power our cold chains with solar, let us also strengthen that. Let us also build mobile clinics that reach where the roads dissolve, because this is one unfortunate scenarios that we are facing. More importantly, let us use digital platforms like TikTok to fight misinformation and disinformation faster. Let our resilience not be measured in reports, but in response time. Let our resilience not be measured in reports. Oh, Garissa is resilient. Oh, Turkana is like this. No. What was the response time? Let us try to measure our resilience through that response time. And that's what the real resilience means. And finally, let us reclaim research. And let us not do this as an academic luxury, but as a survival tool. Let us find studies that begin in the village and end in the policy brief. Let our CHVs or our community health promoters become citizen scientists. Let the healthcare workers, the frontcare health workers, like the nurses, co-author with the climatologists. Is this really happening? I mean, when we are having papers, we are having the health sector authoring its own papers. That approach of multi-sector co-authoring is not what you're having. So what we are seeing here is that we need to have a totally different kind of an approach, where we're having multi-sectoral approach in even authoring our papers and doing our research. And let research grants follow mosquito maps, not just the university rankings. I'll not go into that, it will be too political. Because if we do not investigate our outbreaks, others will write our story. And when they do so, they will write in the past tense. We must research not only what the virus does to the body, but what weather does to the system. Not just what happened, but what should have been prevented. This is what we should research. I mean, researching just what has happened. So you talk about remember historia, although it's also very important. Because knowledge that lives in journals but gathers dust is a rumor. It's just a rumor. But what kind of a rumor is it? It's an expensive one because of the resources that went into it. So we need to make use of all this knowledge that we are gathering. Climate change, as you have said earlier on, creates cracks. These cracks created by climate change, we must plant something stronger. What is this something? That is preparedness, partnership, purpose. Those cracks that have been created by climate change, that is what we need to plant in. Those 3 P's. We need to be prepared, we need to have partnership, and we need to have purpose, of course. Because climate just raises temperatures. It raises the stakes. So we also need to raise the stakes so that we have a better way of managing climate change effects, including VBDs. In the case that I mentioned as an example of what we are going through in Garissa, it'll be a model of our resilience, but not a map of neglect. Let Kenya, and not just Garissa, in that instant, all the counties of Kenya, and let Kenya focus. Let us be focusing our epidemics. Let us not be fearing them. We must not fear these facts. We must fund them. These are the facts that you must fund. We must not wait for outbreaks to teach us again. Let us lead with knowledge, not regret. Let Kenya focus the fever. Let Africa not only endure, but instruct the world on climate health wisdom. Let Africa show that when the rivers rise, we do not sink. We build, we rise, we act, and we do so well in advance. A community health promoter in Garissa once told me, in one of the villages in Garissa County, we don't fear the fever. We fear the silence after the rain. Let that sink in. We fear the silence after the rain. That silence between the flood and the outbreak, between the forecast and the fever, is where the real work now must begin. As we speak of silences, let us not be silent about our borders. Diseases don't carry passports, do they? Mosquitoes do not go through custom checks, do they? So let us force regional partnerships with our neighbors in Somalia, in Ethiopia, and with regional bodies like IGAD and AU. Let us share not only intelligence, but strengthen sharing of strategy on surveillance, on mobility, and on resource pooling. I've deliberately used the word strengthening there because there is something currently in place. Naona watu wamelala kidogo, nishike break kiasi. Wenye wamelala wameamka. I think I have still more time. Okay. Okay. Any more minutes? So, because no county or no country can do this alone. So as I close, let me do so not with repetition of what I have said, but with resolve. We must not fear these facts. We must fund them. We must not wait for outbreaks to teach us again. Let us lead with knowledge, with courage, and with coordination. Let our counties be models, as I said earlier on. Let Kenya be a vanguard. Let Africa be the teacher the world didn't know it needed. When the rains come again, when the rains come again, may we be ready, not only with medicine, but with memory, not only with hope, but with hardwired systems. Let us focus the fever. Let us interrupt the silence. Let us answer the rain. Let us clap for me. Thank you.
Next slide. You took up the slides. There was a next slide. All right. Okay. Okay. Thank you very much. We can now see why you're a columnist. You do have a way with words that is amazing. So we have time for a few questions. Any questions from the audience? Yeah. Anybody else? I can just see Dr. Mutuka. Okay, so two people.
Yeah, thank you. Thank you so much, Bwana Sisi. Mine is a question stock a comment. Is a question and a comment. Let me start with the comment. In the context of healthcare systems in our country, I saw strategies vis-a-vis strategies and the policies that have been put in place. Quite a number of strategies and the policies that have been put in place. And I would request if you could agree with me. Is a problem developing those policies and strategies? If they are existing, to me, that is not a problem. Some people, some experts took time to check on the feasibility, applicability in the context of our devolved healthcare system. I'm now referring to climatic change and population health. Then we still have some gaps existing, and these gaps are multifaceted as you have put them. For instance, we have researchers here, and I can agree with you. At a very low key, do we ever do what we call integrated approach, like meteorological department and Professor so-and-so? What do you think would be the most contributing factor into that not happening? It is already a gap. Then why would it be happening between the institutions? And I think that's a comment together with the question. That is the only area. Policy strategies, then integration is not very feasible. Then why is it? In your own norm, why do you think could be the cause to that? Thank you.
Take the second one as well.
Yes, thank you. Let me stand up. To me, I have two not necessarily questions, but discussions. First of all, is to acknowledge that you are a good orator, isn't it? Yes. So mine was about the early warning sign. I think in each county there's an element of early warning signs, and it must be factored in the CIDPs. So I wish to know how Garissa is prepared. Then, if I forget everything that I've heard today, there are two quotes that I will not forget. The first one is, our health dashboard should light up before the siren and the rise of an ambulance. Then a research that is done and is gathering dust in the shelves is a rumor, and an expensive one indeed. Thank you.
Did you introduce yourselves or I missed your names?
I'm Joseph Mwangi, your neighbor there, Tana River County.
So to the question of Mukuka John from KMTC, yes, we have strategies and policies in place. This is actually a step in the right direction. This is something actually we should be celebrating. This is not something we should be whining about. But the issue, as I said earlier on, is about that implementation. And that will have the same answer on the same issue that you asked about integrated approach. Basically, it's about attitude that we have as the people of this country. Unfortunately, what we have from sectors is that we do not see each sector complementing the other, but we see each sector competing with the other. We want to operate in silos, and that's where it starts from. I always say that systems, the most important component of any system is people. And when the people fail to work together, all the other systems will not work together. They are non-living things, and it is us who are supposed to make them work together. So that is where we are supposed to start from. And if I take you further, and I did some writings on this in line with public service, it comes out of passion and commitment and dedication. With that, which also builds up to patriotism and humanity and empathy, all these things are cycles that are interrelated. I think we can get it right. That is the only answer that I would have as to why we have investments so much on software, on all those tools that we have developed, on all those documents, but we are not seeing the results in terms of implementation, or rather the actions in terms of implementation. Mwangi from Tana River. Well, we have early warning systems, the same thing. Actually, at one point, and I attended a number of forums, we would have early warning systems that are sectoral. Health has its own early warning system. the public health operations emergencies, and then we have the Department of Special Affairs and all that having its own, and then we have the meteorology having its own. What we lack is that integration. And on getting integration right, Kenya is full of intellectuals. We know the benefits of integration, but even how we do and the approach that we take is something that's questionable. And that is why, as I'm seeing even some students here, I would advise them is that let us always work from our heart, and let us always work to serving the people to our best, because that is when we can do every other thing. Every other thing now becomes secondary in terms of even making effective and having that efficacy of the integration that we are supposed to be having. And that early warning system itself goes back to the same thing that was raised by Muguka on integration. Early warning system is there for it to be effective. It has to be very much integrated, and all of us must talk to each other, the nurses and the farmers, as I had earlier on said in my presentation. I hope I answered your questions.
Yeah, thank you very much. We have two more questions online. Two online questions. One is from Dr. Lucy Manyara. She says, in the interest of sustainability and protection of the environment, how are health systems, machines, and applications in health affecting climate? And what can we as health practitioners do to protect the environment? So are we doing things to harm the environment as health workers in terms of what we do? Then there's a second question from Susan Kinyeki, who asks, how do we promote governance mechanisms to strengthen and seal corruption loopholes and avoid the blame game, considering that health has devolved? I think maybe her question is around the fact that we need to work together, yet health is devolved, to address these climate change health issues. So if you could take those last two. Thank you.
Thank you very much for the questions. As for Dr. Manyala, in terms of greenhouse gas emissions, GHGs, from health sector, we are not doing so bad as Kenya. I think just like we are not a culprit in all other areas of the emissions, the health sector in Kenya is not a culprit as such. Like, for example, the UK is, with all the systems that they have and the emissions and all that they do. But having said that, we have a very big role as a health sector to play in environmental protection and empowering people. But before we even go that, we must go back to where we need to understand and empower ourselves that we have a role in environment protection, on climate change and all that. And that will actually make work easier for us. Because if I take you a bit back, you will realize that right now, in realizing our UHC dream in Kenya and making our PHCs, the primary healthcare, effective, one of the biggest burdens that you're having is the climate change effects, the burdens of the diseases that you're having right now. I have taken the example of Garissa and the dengue fever that you're having there. The resource that is going into responding to that is the resource that will have gone into strengthening our primary healthcare systems and into attending in all areas of healthcare. So what it means is that when I am empowered as a healthcare worker, I will be very much proactive to be informing the people. And when I'm even in the management, whether it is the middle management or the senior management, what will be happening is that I'll be taking actions in ensuring that we are proactive, we do not get the diseases, or we rather lessen the burden. So we have a very big role to play. And that is why I always say that in all health departments, we must have an active climate change department or environmental conscious or whatever that we will call. In Garissa currently, we are encouraging all our health facilities to go to plant trees, because there's some research that actually shows on the benefits of that green site on the patients and all that, and all those people who are having probably undergoing those mental health issues and all that. So yes, we have a big role to play, and we need to think outside the box, and we should not just confide ourselves into curative care. but think about how we can expand our world in terms of preventative care. On Dr. Susan, on the issue of corruption and the world care and the blame game, well, these are things that I said is about the attitude that we need to change. That where the junior most officer for example, in a county government will say si hata wakubwa wanaiba si wacha sisi hata tuibe ama we don't do anything and all that. So it just needs some that kind of an attitude change. Yes, health is devolved, but in terms of policy and all that, it is the national government's function. And once that is done, in terms of implementation, then there is always supposed to come that support from the national government. And as much as health is devolved, were resources that were commensurate to the devolution of health also devolved? These are some of the questions that we need to ask. But more importantly, is the thing that I mentioned earlier on competition and complementation. This is what we lack. And in as far as we have, there's that kind of a competition between the national government or says that health has been failed by devolution, and devolution, our devolved systems and counties saying that, oh, we have been failed by Afya House. I mean, we will not do as much. Na fahali wawili wakipigana on the whole issue of addressing the corruption loopholes, I think that's a multi-sectoral thing, and that needs a whole nation approach, and it's beyond the scope of my topic today. Thank you.
Thank you very much. We have been told that climate change exposes our vulnerability. It causes confusion, chaos. The pathogens are getting clever, maybe cleverer than us, but anticipation is key. We have been called to action, haven't we? Yes, to rethink our training, to redesign our response, to redefine our readiness, and to reclaim research. We are very appreciative of you, Mr. Omar. That has been a wonderful presentation. Our minds have been open. We will not be looking at the meteorological reports just to see whether to carry umbrellas and whether to put on sunscreen, but it will be so that we can respond, anticipate the problems that will come because of climate change. So thank you for opening our eyes on that. Can we give him another round of applause? Thank you. We want to give you a small token just to say thank you for taking your time to come, and I will ask Dr. B to hand it over to you. So you can start.
Waziri here. I read some of his articles. They are thought-provoking. Sometimes I tell him he's a genius. You should read his articles. You will be very surprised. And the person who introduced me to him, Habiba is not here today. They are with the principals meeting. She would share the articles, and I came to know him because of it. I think for me, I remember in the research, we've been promoting micro-research about collaboration. Let's work with each other to do a research with other people, multi-sectoral, other disciplines. Can you imagine if we hadn't gotten him? We just got another doctor. The presentation would have been the ones we know, isn't it? And the research should start from the village. That one has gotten to me. So the students, we are very happy this time we've had students presenting. Those times when you go to the rural experience, please talk to the communities, come up with a research. We will support you. Thank you, Waziri. And God bless you. Thank you.
All right, so thank you very much for your attention in that session. We had to move it up, but we'll continue this climate conversation in the afternoon. So the papers that are on climate change will continue in the afternoon as planned. So I want us to shift gears now to go back to the session that we had planned, which was on digital transformation. And I have a co-chair who is Dr. Nyamai, and I will hand over the mic to him. My name is Dr. Wagaki Gisheru, and I'm the head of e-learning, and I will continue to assist Dr. Nyamai. So Dr. Nyamai, over to you.
Thank you, Dr. Gisheru. Let's have some claps for Dr. Gisheru. When Dr. Gisheru talks about digital transformation and the e-learning, every person course in KMTC. When the former speaker was speaking, he said we rethink our training, we shift our focus. There's something we call in health, One Health. And yesterday, Mr. Kolute talked about interprofessional education, whereby we put all the professions together. Dr. B has talked about microfinance, whereby we put together different professions. Micro research, where we put different professions and they work from the grassroots. Sisi ni watu wa mashinani, micro research. On this note, as Dr. Gisheru said, we are shifting our gears to digital transformation, artificial intelligence in health and education. And to unpackage these, we have several presenters. So the presenters include Caroline Owino, Jim Gitonga, Maureen Kipkemboi, Maureen Areva, Cyrus Bali, and Francis Kogoyo. When I was looking at the topic digital transformation, somebody told me transformation comes from two words, where it comes from trans, then formation. Then we are moving from analog to digital, including in the learning and in health. Currently, we have telemedicine, and we have e-learnings and the virtual meetings. KMTC is in the forefront of embracing technology, led by our very own Dr. Gisheru. So the presenters, you'll have around 7-10 minutes of presentation. Then the questions will come thereafter. So please, if you have any question for any presenter, just write it and forward it to us. Then we shall have the questions answered at the end of the presentation. So I welcome Madam Caroline Owino to take us to the next presentation. Let's encourage her with some claps.
Good afternoon. My name is Caroline Owino. Standing here on behalf of my research partners, that is Marion Chelimo and Purity Gadhama, to present research findings on factors influencing the utilization of digital learning technologies by higher diploma students, nurses from selected KMTC campuses. Next slide. So just a bit background on digital learning technologies. As we have heard, there's so much digitization going on. Technology is moving faster than we can keep up with it, some of us. And KMTC has not been left behind. So we are utilizing the digital learning technologies to transform our nursing education. And this is happening globally. And the reason for that is to enhance flexibility, to enhance student engagement, and also to improve access to learning resources. There are several studies which have been done before on digital learning technologies. As you can see, we have studies which are done in Egypt, and they reported slow to be one of the barriers that influence digital learning technologies. Other studies found that digital literacy was a factor that influenced learning for both faculty and students. And also in South Africa, the student mentioned intermittent internet access, low technical support, and also insufficient training. So in KMTC, digital learning technologies have been expanded post-COVID, and there's minimal evidence, and particularly for higher diploma student nurses, on what are the barriers or what are the facilitators for using digital learning technologies. Next slide. So the main objective of this study was just to look at which are these factors that influence the utilization of digital learning technologies by higher diploma student nurses. And the specific objectives were, one, to determine the individual factors, for example, the digital literacy, self-efficacy, that influence the use of digital learning technologies. We also wanted to assess the contextual factors, for example, institutional support and curriculum integration. We also wanted to evaluate the technological factors, that is device access and also internet quality, and how they impact digital learning technologies in nursing education. Next slide. So our study was anchored on the theoretical, on the theory of technology acceptance model. I thought it's important for us to mention this because when you look at technology, it comes faster, and before we learn it as maybe nursing students, we want to learn our nursing, but before we do that, we have to use these technologies. So for somebody to be able to use technology, they must have a perceived ease of use or ease of utility of that technology for them to perceive it as useful. And once they're able to perceive it as useful, then they'll have the intention to use and actually use it. Next slide. So with that, our methodology, we used a descriptive cross-sectional method design, and we had 7 campuses, that is Nairobi, Mombasa, Thika, Embu, Kisumu, and Nakuru, and also Machakos. We selected 153 higher diploma nursing students from specific courses, that is anesthesia, critical care, nephrology, and pediatrics. We got a response rate of 73%, and we used a self-administered questionnaire, which was pre-tested at Kilifi campus. And in analysis, we looked at descriptive analysis and also just association, and we used the Mann-Whitney, U, and Kruskal-Wallis tests. Thank you. Next slide. So these were the findings. Generally, there were more female students compared to the male, that are 71%. And majority of the age was between 21 and 30, and again 31 and 40. Specialization, most of the students came from critical care and nephrology. And the campus representation there, Nairobi campus had the highest number of students, that is 25%, but the other campuses, there was even distribution. Next slide. Still on demographics, we had a question on use of the use frequency. How frequently do you use the digital learning technologies? And the questions included, do you use it daily, 3 to 5 times a week, or once a week? So majority of the students responded that 37.5% of them agreed they use the DLTs daily for their studies, and only 22.3% spent more than 2 hours per day on the digital learning technologies. And while 13.4% spent less than 15 minutes on those digital learning technologies. And when they were asked why do you mainly use the digital learning technologies? 74% said they use it to access course materials. 48% watched the recorded lectures, and only 18% said they use it on collaboration on peer projects. Next slide. So the other objective was to look at the key individual factors that influence the use of digital learning technologies. We had a topic on digital literacy, and 70% of the daily users were confident in using essential computer functions, and you can see it's statistically significant. And the daily users had the highest proficiency in ability to access the academic resources online. On self-efficacy, that means, are you confident in utilizing the digital learning technologies? And only 46.4% said they felt confident in using the digital learning technologies. And out of that, we found that they had more proficiency as compared to their peers, and had a mean rank of 64.77%. And you can see that it's also statistically significant. In terms of perceived utility, around 69.5% said they find DLTs useful in their studies. And of course, daily users reported an enhanced academic performance. Next slide. So again, on the objectives of contextual and technological factors, in terms of institutional support, only 45.5% agreed they were oriented into utilization of digital learning technologies. I am happy the team for e-learning are here. 34.8% said they received technical support when they were facing difficulties. And again, 42% agreed online multiple choice questions were effective. So the other modes of assessment, we had asked whether they use the discussions, the collaborative learning. So only 42 are able to agree that MCQs were actually effective in assessing their learning. In terms of curriculum integration, only 43% agreed that digital learning technologies enhance understanding of their course content, and 38% said that DLT activities align with learning objectives. In terms of technological challenges, one of the main barriers identified was slow internet, there was lack of devices, and again, infrastructure gaps. And of the four categories of students, the anesthesia, nephrology, pediatrics, and critical care, the pediatric specialization students spent most of their time using digital learning technologies. That's a mean rank of 76%. Next slide. In conclusion, in relation to the objectives, the first conclusion was individual motivation and digital literacy are key predictors for utilization of digital learning technologies. And therefore, one of the recommendations was capacity building. KMTC should implement a structured digital literacy and self-efficacy training programs for students and faculty. The second conclusion was infrastructure and pedagogical integration also matters. Recommendation, we invest in high-speed internet, digital devices, and also a responsive ICT support system in all campuses. And another point still on that is to train educators to effectively embed the digital tools into instructional design, and also to align the digital resources with curriculum goals. And the last there is institutional and curriculum alignment is essential. So one of the recommendations is there should be institutional policy reform, whereby DLT policies should be clearly developed and integrated into the curriculum, and also conduct regular platform evaluations. Thank you for your time.
Thank you, Kara, for your presentation. You have clapped before I said you clap, so you'll clap again. Clap for her. The next presenter is Jim Getonga. Kindly come to the podium. Jim Getonga. Let's encourage him with some claps.
Thank you. I'm Jim Gitonga, just an engineer with my HOD, Madam Agatha Simama Wasarimie. There she is. So basically, I'll start with the first one. I'm a bit tensed, but so yeah, so basically I'm dealing with what we are calling AI-powered graph attention neural network. We refer to it as a GAN for drug-to-drug interaction. So even if I've not done pharmacy, I have an experience in artificial intelligence. So what I'm doing basically in a graph neural network is basically I'm training drugs to be able now to say how drug react with another drug. So that now means there are some drugs, when you take them together, what happens? It weakens the other. So basically I'm basing it on the molecular, on their molecules, on the structure, and then the known interactions. Then from there, I can be able to predict if drug A is mixed with drug B. How does it do it? So those are some of the limitations, as you can see it. Now, the reason why it's called graph attention networks is that I'm taking drugs as the nodes, and then their interactions as basically now the edges. So that's why we refer to it as a drug. So it's like a connection in between. It's like a ring. So I have trained on it. I've built a model. I've trained on it on 1,098 drugs, and it's able to predict them well and be able to tell if one drug interact with the other, what will happen. If it will basically, the interaction will be severe or something else. We go next. So now those are my aims. So basically, build the comprehensive molecular feature and extraction pipeline, and the rest now. Go to the next one. So this is now my model architecture. So what I'm basically doing is the first thing, you have the drugs. So basically, I'm using the database in UK. So then the second thing is that I'm doing the feature extraction. Now, the feature extraction, I'm using what we call the Morgan FP. And then the other one is the max keys. The max keys is basically the structures, which is basically 48 bits. And then the next one is what we are calling descriptors. Descriptors, I'm basically basing them on 18 kind of descriptors. So on there, then I construct the graph. From the graph now, I build now what we are calling my DDI, the GNN. Next, then from there, I do the training. On the training, you can see I'm using an algorithm we call W optimizer, which is basically RLU, which is at 0.005. And then the other one, I stop at epoch of 15. From there, I also go to the 5-fold cross-validation. I validate if what I'm training basically is correct. Then from there we do the comprehensive metrics, and then we do the prediction, and then we go to the visualization and the reports. So on this side, it is the input. On the other side, it is the output. So that is the data pipeline of what I was explaining. Are you understanding me? Okay, let's proceed. So then that is how the graph attention network design looks like. The first thing is 18 layers. So I talked about 48 bits or 40 so Marquez keys. Then we're having 167, then 188. Then when you add all of them, you get 223 bits. So then I feed it to the second layer, 512 feed units and 8 attention ends. Now, 8 attention ends is how those drugs are interacting. Each drug is getting connected to 8 nodes. I mean the 8 severities. Let's continue. So these are my results and performance. So on the first one, I got the AUROC, we refer to it, the area and the receiver operating characteristics, which is basically is used to measure that drugs, the way they interact in terms of the accuracy. We are talking about a score of 0.96, that is kind of like 97%, and the target stereo target is at 0.80. So then the ARPLC, that is basically area under the curve between precision and precision and recall, I got at 0.95, and the stereo is also at 0.80. Then the F1 score, I got at 0.840, and the stereo is at target is at 0.7. These other ones are not that nini. We go next. From there, when I was training, this is what I got. And I used what we call a PyTorch, the Facebook thing, the framework. And I built using Python program together with my HOD. So next. This is the software I built. So you can see the first drug is KMBL2. The KMBL2, when you look at it here, is a prazosin, which is basically then drug 2. The drug 2 is a KMBL677. Its name is prazosin. So when you mix them, I mean, level what? Doctors, I don't know that name. Anyway, it's your name. So you get, it was able to predict it correctly. That one, next. And that is the conclusion. We'll use some of those ones to test. So I'll go to the next presentation. Next one for the MRI. And first, so that I cannot eat into your time. Okay, so there we are again. The next one I'm doing now is what we are calling AI-powered MRI coil fault detection simulator. So you realize sometimes MRI machines, they have the coils, and those coils might end up having the fault. So, and then the engineers, they are not aware. So I've built also an artificial intelligence models. It's basically a simulator that can also be used to train how the machine basically can be able to identify the faults in that coil. And when you hear about AI, remember AI is data. With no data, AI can't learn. Yes, so it's data fed. So the remittent opportunities, you realize the artificial intelligence is the new thing in town, so a lot of people are not acquainted. And then now remember also again, we are training our our higher diploma students about the machines, the computers, the programming, and they need to be able to have these basics and understand when they are coming out, how does the machine do A, how does it predict A, how does it predict C, which procedure is it using. So such a software, I've also built the software, it can be used to train our higher diploma students. And it's all mathematics behind the software. So next. So specific objective, create realistic fault patterns using deep learning. It's a part of AI. The AI is the bigger picture of it. Then you go to visualize, make decisions, standardize technical about in the institutions, reduce maintenance cost, and then improve diagnostics. Continue. So the platforms I've basically used, I've used what we call TensorFlow. TensorFlow is built by Google, and also Keras. Keras is built by an engineer in Google also. So then the other one is the CNN, or what we call convolutional neural networks. And then the data format that I'm using in hospitals, or the people of the imaging, you know, you use DICOMs, right? Okay, so we continue. Now, on the key components, I'm feeding on 32 by 32 image of by 1. So, and then I am having the first convolutional network. That is why it is starting. I have the input, that is my data. I have the first convolutional network, I train through. Then I have what we call max pooling. Now, what I've trained now, I expand. Then I have the second convolutional network. It's like a loop. I take it back. Then from there, I have the second max pool. Then from there, I flatten my data. As I'm flattening my data, you can see now it is at 8 by 8 by 22. Then from there, I make it dense. I do the final what we call batch normalization, put the data together, use the radio algorithm, and then the dropout. Then from there, I have my output. Here down are technical specifications and the performance metrics. Next. So well, how it is doing it is just the AI is basically working like the brain. So how does your brain work? How does it reason? How does it recognize patterns? There it is. Continue. Next. That is my results and performance. So for the fault, when it is normal, it was able to get it at 0.97, precision at 0.98, recall 0.96. For a crack, it earned an accuracy of 0.93. For precision, 0.92. For recall, 0.94, where 0.94, 0.93, 0.95. Next. Oh, next. So impact, there it is. I will run there and then I will demonstrate how it is working. Okay, so I go with this, or it will have problems. So tuanzeni here, drag, copy your link. Drag, copy your. Yes, kuna ingine hiyo nini MRI. The second strand. So, but this one I also copy. Laptop, no, but I can use it from here. Yes, I can use it from here. I built it. Niliweka kwa yote ni kwa nini sasa, not running in my machine. So, have I been so fast? Yeah. So.
We are waiting for our stimulation.
Yes, there it is. There is the platform. So as you can see, it is telling me enter the first drugs. So the drugs, I'm not entering them with the names. I'm entering them as the chemical standards in the industry. So basically, I'll copy my first drug name. Where are they? So here it is. Assume I have Chemlip 5. I don't know what it is, but we'll discover what it is. So I come here, the first drug, I paste it. Then I come, get the second drug. Then assume I get 9. So then from there, I can be able to paste it. So I paste it, then predict. It has run the prediction. It has told me that drug, it is basically, there are 2 drugs there. Now it's basically telling me drug 1 is maxilic acid, then the second one is norfloxacin. So, and their chemical formulas are there. Then it is telling me when the both drugs are taken, when they interact, it will be severe. So then we'll go to the next one, which is basically MRI. So on the MRI, what you can see, basically the first thing we do when we are there, we say generate synthetic data. So from there, I'll generate the data. Then I'll tell it, how long do you want to train the data? So I mean, how many epochs do you need to run to train that data? I'll tell it 50 epochs. So then from there, change the batch size. How many batches do you want to feed it? It's like how many spoons do you want? So then I tell it, train the model. So it's training it, and as you can see, it is training balanced 49 epochs, already accurate. It has given me predictions of normal. They were correct, true positives, true, which is basically 12. Then the one for the crack 11, and then the other one was 7. Then there are the graphs here to show how it was training and how it was learning. Then from there, we can go here down. We can say test with the normal data that we generated. It is telling me it is normal at that 4. So, but it is now comparing with others. Normal at that 4, why? Because the first one crack and that 1%, and the other one and that 4.36, the where. So we can go to the crack one. We see. So on the crack one, you can see now it is telling me it is crack with a probability of 47. So, but it is no more at 26.88, and it is aware there's somewhere at that 2.65. So then it is giving you all these details. So somebody might want to ask, how did my AI alive to that? So basically, then we go to the first thing, which is basically we check the layers, the ones that you are hearing me talking about. So then the next one is the dropout, and then the output. So we see the visualization. So let's see the visualization, how the computer is visualizing that information. So look at how now it looks at that information for it to arrive into that conclusion, the first convolution, which is basically the feature maps, what it was checking through, what it was checking until it came to the realization it was a crack. There it is. It is showing you the patterns it was checking. And that is it, and I'm done.
Wow, let's continue clapping for him. Now you know when you hear an engineer saying he's tensed, that's how he can be able to do. You see, the end justifies the means. Now, we may not have understood a lot, but we have understood the results. I could see Dr. Marcella trying to look at nalidixic acid and norfloxacin, but now when they were being presented here, I could not understand well, but now I understand the results. Let's clap for him. That is what KMTC is made of. we have engineers around, we have pharmacists around, we have radiography and imaging around, we have diagnostics, and we have many other courses around. The next presenter is Maureen. Keep going. Let's clap for her as she comes.
Standing on the protocols already established by my previous presenters, good afternoon. It's a privilege to stand before you to present a paper on electronic logbooks in health professional training. And these are the perceptions of diploma clinical medicine students at Kenya Medical Training College. So this paper was co-authored by Mr. Richard Kibet Korir, who is the principal in KMTC Mosoriot campus. Next. So in health professional training programs, almost all programs would require some percentage of practical training, or if you like to call it clinical training. And it is basically the cornerstone or the backbone of health professional education. And for one to assess the competencies that have been acquired in the clinical area, then logbooks become very essential tools in terms of monitoring the acquisition of the learning outcomes, the skills, and the progress towards achieving these outcomes. So they are very, very essential. Next. And in Kenya Medical Training College, the clinical medicine fraternity use the physical logbooks, or what we call the traditional or paper-based logbooks to track and monitor and evaluate the learning outcomes of students within the clinical area. So there have been some inefficiencies that have been seen, but not documented with the physical logbooks, which would include issues to do with clinical learning, supervision and evaluation, citing cases where we have, inefficiencies in data analysis capabilities, which now hinders the tracking of these learning trends that we have in the clinical area. We have issues to do with, gaps identification in clinical exposure, etc. So this study actually endeavored to evaluate the clinical medicine students' challenges with the physical logbooks and view what they perceive to be the benefits and, of course, the anticipated challenges in terms of transitioning to an logbook platform. So it was a baseline study which took an exploratory, descriptive, cross-sectional design. Data was collected via electronic questionnaires from 255 clinical medicine students across various KMTC campuses. So moving on to the results, in matters use and satisfaction with regards to the physical or the paper-based logbooks, it was determined that the physical logbooks were not optimally utilized in the clinical area. From figure 1, you can actually be able to see that 23.1% of the students utilized the logbooks on a daily basis, 31.4% on a weekly basis, 9.8% on a monthly basis. And of course, the lot that would worry us as lecturers is the 36.7% that would rarely utilize their logbooks in the clinical area. There was varying levels of satisfaction that was seen as we moved from year 1 to year 3 of study, so that as the students progressed to year 3, then the level of usage and satisfaction also increased. And of course, this can be attributed to so many things, such as, when they come in, you are doing clinical sciences, you don't really see the need of a logbook. But when you are in third year, now the professional has been inculcated. You are going to the rural areas. The rural areas have, research and clinical coordinators who probably would enforce the use of logbooks. So some of the challenges that were cited by the students in regards to the use of the physical or the traditional logbooks included the risk of loss or damage. So there are students who said that they misplaced their logbook and they are yet to find it. Someone said that it gets lost, it tears off, it gets wet. So probably this student, got rained on from the clinical area. And of course, that was another story with the logbook. And then there was the issues to do with delayed feedback from supervisors. So as some students mentioned, difficulties in finding mentors to actually sign the logbooks at the end of the procedure. And then there was issuance period where some people mentioned that the logbooks were insufficient and therefore they did not receive one. And of course, all this now brings in the question of how was the evaluation done? And of course, it feeds into the quality of training that we are very passionate about as KMTC Next. So in terms of their perception, in regards to e-logbooks. So the students perceived the e-logbook as a more efficient alternative. And this was the case by 70.6% of the students. And their greatest benefit that they anticipate, to get when an e-logbook would be part of and parcel of their training was easy access to records. And then we have the reduction of damage and risk of loss. And I'm thinking these are the ones that got rained on or something. And then we have the time saving, improved data, and the rest. Next. So the challenges that the students anticipate with the onboarding of an e-logbook system, the most important one for them was the internet connectivity issue, followed by technical difficulties with the devices. Some of them cited lack of training on usage might bring up problems. And then very, very important, we have security and data privacy concerns. And then finally, there was some issues to do with resistance to change from both the students and the faculty. So on matters of device accessibility and readiness for transition from the paper-based to an e-logbook, very, very positive. 90.2% of the students noted that they have a regular access to a smartphone, a tablet, or a computer for logging in entries if an application or software was tagged as part of their training. 89.8% of the students actually believe that the integration of an e-logbook system is very important in their training, and 89% of them recommended the transition from the paper-based to the e-logbook system. So in conclusion, the study concluded that the integration of e-logbooks in the clinical medicine program of KMTC is actually feasible, and it might offer benefits to the students, and of course also some benefits would spill over to the faculty. There would be significant enhancement in matters clinical training, learning, and experiences for our students. And it aligns very, very well with the KMTC Strategic Plan 2023-2028, which endeavors to digitalize the processes in KMTC, especially innovation, digital application in the learning and teaching processes as a way of enhancing quality of training. So the study recommended or recommends the adoption of an e-logbook with possible pilot studies to be done just to make sure that the application is up and running and effective before the full rollout. Thank you.
Very important to embrace technology. The next one is Maureen Aleva. It's good to clap for her, please.
All protocol observed. Good afternoon. As you've already heard, my name is Maureen Areva. I'm an external lecturer from KMTC Webuye. I want to start by a special mention to my principal, Mr. Nathan Masengeli, Webuye campus, as well as Mr. Daniel Kurui from Teso campus. I'm making a presentation on the major cyber attacks on health information and how the same attacks can be mitigated. As I progress with my presentation, I want you to think about that private photo you took that is now trending online, or a conversation you made with someone that we are now listening to, or a screenshot of a confidential conversation that you took, but now it is in the public domain. And you keep asking yourself, nani alitoa? So that is what I want to address, and particularly with regards to health information. We all consider our health data private because that is information that should be between me and my healthcare provider. Why is it that everyone now knows I have gonorrhea? Kwani daktari alienda kuambiana? So that is what I want to look at. Next slide, please. So I start with the background of the information. From the global perspective, healthcare is increasingly becoming vulnerable because we are adopting digital systems. We have some acts of parliament regulations from different countries that ensure that such data is protected as much as possible. We have the HIPPA from the USA. We have the General Data Protection Regulation from Australia, from the European Union. And then we also have the Australian Privacy Protection Act. When we come to Africa, 91% of the health facilities in Africa are also adopting a digitized healthcare system. Most facilities in Africa are using what you call open MRS. You remember yesterday, Professor Kimayo talked to us about MRS. So most facilities in Africa are adopting the same system. When we talk about facilities in Kenya, we have hospitals either using the commonest is district health information systems. We also have hospitals that are adopting an in-house or outsourced EMR or an electronic health records management system that they use to store, manipulate, archive, and process medical information. Because of all these technologies that we are using, patient information has become vulnerable to security breaches. We are not very sure that this information is safe while it is held in that device or while it is on transit on a network. So because of that, we have noted some of the major cyber attacks that several facilities have witnessed. We have something like insider threats, that is a threat by the employees themselves. We also have software, social engineering. We have ransomware and quite a number of other attacks that these cyber attacks are directing towards medical information. Next. On to the problem statement. I'll start by what happened around 2022. There was a case in court. A patient had sued Aga Khan University Hospital for one of the employees had inappropriately used this patient's data. So Aga Khan University Hospital was ordered to compensate this particular patient because her information was wrongfully used. You can see that is an example of an insider threat. It's an employee who violated the patient's data. When we look at other records from breach level index, this is a public site that tracks how much vulnerabilities we have. And you can see that site recorded slightly more than 9 billion attacks on health data. We also have the common vulnerabilities and exposures database that recorded 15,000 attacks also in the early months of 2017. We also have dark reading, which reported slightly over 1,000 data breaches, again, on half of 2017. We also see the journal from the regulation in the US that said in 2021, they reported that the healthcare industry suffered the most number of attacks. And why people are attacking all this health data is because from the last point there, you see that this data sells at 20 times more price than credit card information. So if I have your health data, I can use it to blackmail someone and I make 20 times the money someone would have made from any other kind of data. So you can see why we have a lot of cyber criminal offenses against health data, because the price of that information is very high. And that is what forms the problem statement that warrants that research. We had the broad objective was to describe the cyber attacks that are against the health information in Kenya and how the same attacks can be mitigated. To the specific objective, the first one was to first of all describe which electronic health technologies are in use in Kenya, because it is the same technologies that will be collecting the patient's data. We also want to look at which are these cyber security attacks that are directed towards this particular kind of information, and also describe the measures that we can use to mitigate the attacks. To the methodology, this research, I adopted a slightly different approach. I used the systematic review, which you'd otherwise call secondary research, and I made use of the PRISMA checklist to go about data collection. A total number of 113 articles were searched from the internet using Google Chrome. The search results, the 113 articles were then exported to EndNote library for analysis. In that library, I looked at the abstract for analysis. And then out of the 113 articles, 38 were found out to be duplicates, so they were eliminated from the search. 46 other articles were excluded for not focusing on the study topic. And then out of the ones that remained, 18 articles were further removed because they did not highlight the content in detail. And then the total number of articles that were finally analyzed for us to get the results was 16. There's a slight error in the number there, but the number of articles that were analyzed were 16 for us to get the findings. Yes, please. I had the inclusion and the exclusion criteria. I included only articles that were authored between 2001 and 2023 from different libraries where we can get the said articles. And then I also included newspaper articles, reports from different facilities, and any publications that were in line with the topic of study. Excluded were articles that were not written in English. Also, any publications that were talking about protection of health data, but not particularly articles about Kenya, and then also articles that were not talking about the topic in detail were excluded from this study. Data was managed in several ways. All the reviews, the articles that were being reviewed, they were kept in password protected files, because remember, we are talking about security. So you didn't want, you've gotten people's information and then you are not also keeping it secure. So we had password protected files for the security of the data that was collected. Data was then extracted and put in Microsoft Excel for purposes of analysis. An iterative process was followed for the analysis, and then the results were analyzed qualitatively and also presented in form of tables and charts. It is good to also note that only aggregate findings were reported, not findings for a specific facility, because there are very many facilities in Kenya. So only data that was coupled into one basket was reported. All the findings were summarized into one slide. I remember the first specific objective was concerning which technologies are in use. Okay. The technologies that were found out to be used in Kenya include an electronic medical record system and electronic health record system. We also have telemedicine, we have mobile health, and then we also have blockchain technology and wearable devices. Maybe some of us are using this technology, especially the wearable devices. Also noted that some of the common cyber attacks directed against patient data include data exfiltration. We also have phishing, which is also known as social engineering. We also have insider attacks. We have ransomware. You can see they were categorized into different facilities that are tasked with handling health data. There are some of those that are facility attacks. Others are directed. You can see we have directions to the Ministry of Health, Kenya Medical Supplies Agency, KEMRI. Different forms of cyber attacks are directed towards different kinds of data, depending on what facility or what institution is holding which kind of data. And then to come to the strategies that are used to mitigate these attacks, there are quite a number. One of them includes application hardening. We also have training your employees on the importance of data security. We have quite a number of them. You can see from the slide, we have those strategies that can be used to prevent an attack. We have those ones that can limit the attack surface. We also have the ones that can be used to recover. To some extent, you may not be so much be able to prevent, but you can recover from an attack. So we have different kinds of strategies: preventing, limiting, and also recovering from an attack. Let's proceed to discussion and the conclusion from this research. We can see that from this research, some of the common cyber attacks that we found out included malware, hacking, denial of service attacks, and also flooding were the commonest that most of the facilities in Kenya face. The study also found out that the leading cause of these cyber attacks includes data exfiltration and phishing, which is what the employees themselves do. And these data breaches are normally led by the employees themselves, and the second thing is from the technology that we are using. This study also found out that it is from risk and compliance that we can be able to manage these security attacks. So it is not something that can be done by one person. We need to come up as a group, and everyone needs to know what they're supposed to be doing. In conclusion, health data or patient data and facilities have become more reliant on information. I mean on digital systems. And therefore, it makes the data, the patient data, so much vulnerable to cyber attacks. And because of that, cyber criminals are also not resting because they're taking advantage. I think we realized this when with the advent of COVID. That is when we all had time to use the internet. And that is when we realized most of the attacks are happening. So as much as we are concentrating so much on preventing these attacks, we should also be aware that the cyber criminals are also putting in as much effort. Next, please, and the last slide. From my recommendations, we can see that the process of medical data, I mean, there is need to process medical data in accordance with some acts of parliament, the ones that are really enshrined towards protecting patients' data, several kinds of acts like I've listed, as well as the simple right from the Constitution that says everyone has the right to privacy. It is also important that healthcare facilities also, it is necessary that they measure, I'm sorry, my eyesight is not so good. They ensure security and privacy, because we know from the normal slogan that we always use, security starts with you. So it is good that as a health facility, you also train your employees on the importance of data security, because we've seen the leading cause is insider threats. The employees themselves leak out the information. So it is good that we train them on how to handle the patient's information. Thank you.
Let's continue clapping for her. How safe is your information? That is what cyber security talks about. Our next presenter is Cyrus Berry. Cyrus Berry, please. Let's clap for him.
Yes. All protocols observed. Good afternoon. I'm Cyrus Ashivira Bali from TESO campus. I'm standing in for our student who is engaged in Rwanda at the moment. And we are the three of us who participated in this. That is Epael Okotula, Cyrus Ashivira, and my principal, Daniel Krui. I want to say this, that we appreciate his support in terms of financial support and also the psychological support. And even he has promised to go ahead and assist us in publishing this particular document so that our student is seen on the map. Now, this particular study is all about EMR adoption in the healthcare system. And this particular EMR has globally, if you look at it globally, you can move to the next slide. The adoption globally, the aim of this particular EMR is about improving health service delivery to our patients in the hospital. And it has met many impediments or obstacles in relation to adoption. That is at the global level, even in Africa. In Africa, citing, for example, Ethiopia, we have Nigeria. These particular countries, they have tried to adopt, even Kenya included. Remember, we are in low-income countries. So the adoption is, it has met great challenges. And some of the challenges, you can be able to see there, we have got the technological know-how, we have got the organizational challenges, we have got social issues that are facing this adoption. Also, in addition to this, you can be able to see even in our country, the way I already mentioned, we have many challenges regarding the adoption, and mainly now in the area of the study, that is Busia, TESO not included, we have got many obstacles that are facing this particular implementation of this particular adoption. Next slide. Looking at our problem statement, despite the fact that this particular EMR has got numerous benefits to our health sector, we have got many challenges. Thus, the implementation becomes a challenge. Now, looking at Busia, you can be able to see the adoption is very poor, but we have got many because of many challenges. And that is the curb that made this particular researcher to go ahead to do this particular study. Justification. Okay, sorry. On broad objectives, first, the main broad objective of this study was about to determine the predictors of EMR in adoption in TESO North Sub-County Hospital. Secondly, we were looking at how to analyze the influence of capacity building. Secondly, the influence of infrastructure. And then lastly, the influence of perception on EMR adoption. Now, justification is all about informing our stakeholders to come in so that they can be able to support the implementation of this particular EMR in our health sector. Secondly, also, we are very much interested in informing the Ministry of Health, also to fast track the implementation of this particular EMR into our health sector. And then lastly, to the academic sphere, it will be able to form a baseline so that even our staff, our students can be able to even to go ahead and even work on this, and then they can be able to modify furthermore. Okay, that is the conceptual framework of this particular study. We had 3 major independent variables. That is capacity building. We looked at infrastructure, and then lastly, perception, whereby it was having influence in relation to the adoption of EMR in the health sector. Next. Okay, looking at the methodology, we used cross-sectional analytical type of research design. Secondly, this study was conducted in Teso North Hospital, which is found in Busia County. And the study population was 58 participants who participated in this. And the departments that were included is where we had the EMR. And those departments that were excluded will not have the EMR. And then we used the purposive type of sampling method. Data collection was by the use of a questionnaire. And then analysis, we used the SPSS version 28. And the ethical consideration was observed throughout this particular study. Next. Okay, these were the findings of the study, whereby from these findings, you can be able to see very clearly that more than a half of the study participants were female, whereby they were aged between 30 to 45 years. And you can be able to see more than also a half, they were holders of diplomas, whereby the least were having masters and PhD. And the experience you can be able to see from this particular graph, it is that they had an experience maturity, were having an experience of 1 to 5 years. Thank you. Next. Okay, you can be able to see on reference to capacity building, it is evident that it was about those who are trained were around 50%, the p-value of 0.01, whereby it was statistically significant to the adoption of EMR. Next. You can be able to see in terms of infrastructure and perception, there was statistical significance of p-value of 0.02. Next. Okay, this is the discussion, whereby you can be able to see clearly that capacity building, infrastructure and perception, they are correlated to adoption of EMR in the health sector. Next. Now, looking at the conclusion and recommendation, it is evident that capacity building influenced adoption of EMR together with the infrastructure and perception in Teso North Sub-County Hospital. Finally, we have got 3 major recommendations in relation to this, whereby this study is recommending that we need to have a formal training and a follow-up mentorship program regarding EMR utilization in the health sector. Then lastly, we need also to consider this particular element of infrastructure in terms of having ICT incorporated into the health sector. Although we have, but now we need to put more efforts regarding the adoption. And then finally, we need also to ensure that as KMTC, as much as we are having ICT, but we need to reinforce. Because if you look at the way I am here, I'm a nurse practitioner, if you look at our curriculum, it is evident that we have got very small content regarding ICT. So we need to review our curriculum. Thank you so much for listening to me.
Let us clap him again. You see, he has said finally 3 times. So I say finally. Finally, we're having our last presenter for this session. For those who are following us online, please post your questions on the chat box. We shall be able to give them to the presenters at the end of this presentation. The last presenter is Francis Kogoyo. Let's clap for him as he comes forward.
Situmpigie makofi.
Afternoon. So we'll be discussing on the prevalence of rheumatoid arthritis among patients attending Nyahururu County Referral Hospital. So first of all, my name is Francis Kimani Kagoyo. I am a student in KMTC Kitui. The research was supervised by Dr. Promina Muya. She has walked me through the whole research. And so we'll start. The title, as I've stated, is Prevalence of Rheumatoid Arthritis Among Patients Attending Nyahururu County Referral Hospital. So we'll start with the background. So what is rheumatoid arthritis? Rheumatoid arthritis is a chronic inflammatory immune disease that primarily affects the joints. So we have to understand that it is an autoimmune disease. It affects the joints. It affects people of all ages, although it manifests differently. In young adults, in young people, it is known as juvenile idiopathic arthritis. It is almost similar, although the juvenile idiopathic arthritis, it's a combination of many diseases which manifest similar to this, but the tests are different. That's why the research will cover mostly the people aged 45 and above. So it is an autoimmune disorder which increases with age. The condition, although affecting all ages, tends to be more prevalent as one ages. So the problem statement is that this disease is undiagnosed in Kenya and remains untreated, particularly in low-income regions of Kenya. That's why I preferred Nyahururu, because we cannot compare it to a region like Nairobi. It's a bit behind. So anemia is one of the most common yet overlooked complications of rheumatoid arthritis, affecting nearly 30 to 70% of patients worldwide. So most of the times when you get a patient with a positive rheumatoid arthritis, they also tend to have anemia. So justification, understanding rheumatoid arthritis and relations to anemia will help improve diagnosis and treatment strategies. Through this understanding, prevention of irreversible joint damage and immobility will be achieved. Next. So we start with the questions. So first we are going to ask ourselves which gender is most affected by rheumatoid arthritis. Then we'll have the age range of those affected by rheumatoid arthritis, how frequent is anemia in patients diagnosed with rheumatoid arthritis. The research questions form the base of our objectives, since we will cover the gender, understand the age distribution, and know the frequency of anemia of those affected by rheumatoid arthritis. So the study site, as I've stated again, was done in Nyahururu County Referral Hospital. The design used to get the data was a descriptive cross-sectional design. The sample size was 200, and from 200 samples, a sample size of 145 was obtained through Sloven's formula. And the inclusion criteria of the patients was all those aged 45 years and above. And the exclusion was any sample that seemed to have a problem, like a hemolyzed sample, aged samples, samples poorly transported. All those were excluded. So before we get the data, we had to get the permission from the patient. So we followed all the ethical considerations. So the approval was obtained from NACOSTI via the institution, that is KMTC Kitui. The hospital and the hospital laboratory consent was also obtained from patients, and no incentives was given to the participants. So this is the process of data collection and analysis. Those the instrument used were the syringes, needles, red stops to obtain the serum, EDTA blood collection tubes that was done to obtain samples for complete blood count, alcohol swabs, tourniquets, and consent forms, which was necessary. So the procedure was vein puncture and laboratory test, that is anemia test using complete blood count, and rheumatoid arthritis test results, which was done using the RF, where we test for the rheumatoid factor. So analysis, descriptive stats was using the Excel, and the focus was to analyze by gender, age, and anemia frequency. So from all that, we got the data, and we found out that from the sample, from the 145 patients, 99 of them tested positive for rheumatoid arthritis, with a 59.6% who were female, indicating high prevalence in female, more than the 40.4% in males. Also, the age distribution from the 99 samples which were positive, the ages 55 to 64 had the highest prevalence rate of rheumatoid arthritis, and the lowest ages were 40 to 54. And next. So from the 99 patients who tested positive for rheumatoid arthritis, 64% of them tested positive for anemia. The highest prevalence was women, with 59.4% of women testing positive for rheumatoid arthritis, also testing positive for anemia. Ages between 55 to 64 again presented with most cases of anemia while being positive for rheumatoid arthritis. So here's the graph presenting the anemic patients who also presented with positive rheumatoid factor. So next. So this is the discussion. So from the results, we concluded that rheumatoid arthritis is more prevalent in women, as this show it is linked to hormonal and genetic factors, as the previous studies had stated, like the McLean's and Sachets in 2011 in England. So you may ask, why is it more prevalent in women? We can say it is associated with hormonal factors. As you have seen, ages 55 to 64 were the most common. We can relate this to the menopausal time when the hormones are not, there is hormonal imbalance in women. Also, we have increased a genetic factor, which is increased production of the women response system is faster compared to men, which leads to a likelihood where women may develop autoimmune disease faster than men. So that's why we find out that rheumatoid arthritis is more prevalent in women more than men. Also, the peak incidence was recorded as 55 to 64, aligning with the previous studies that rheumatoid arthritis progresses with the increase in age, which was Pincus et al. In Nigeria. High anemia rates due to chronic inflammation and medication effects. This disagrees with the study of Almanos, which reported high anemia cases in women, where in my study, I reported high anemia cases in women more than men. So, slide. So, my conclusion is that rheumatoid arthritis and anemia are highly prevalent in women, and other adults are, and older adults are most affected. So recommendations: routine screening, manage anemia in rheumatoid arthritis care, improve healthcare access and training, policy focus on autoimmune condition. Suggest for further studies should focus on public awareness of rheumatoid arthritis and risk factors in order to improve early detection rates. The last slide. So these were where my references were from. And we thank the KMTC Kitui, Nyahururu County Referral Hospital, our principal, and Dr. Promina for making this opportunity possible. Thank you.
Hey, let us make a better clap for him. He has done it well. Congratulations, Francis. Thank you for your supervisor. Good work. I was looking at Dr. Modoka when the presentation was being done, and they could imagine how he presented for his postgraduate. And this guy is doing a diploma. Let's give him a better clap. And that tells you that KMTC, we are producing an hybrid in research, both in academics as students and in academics as lecturers. Lecturers, we clap for ourselves. So in the next moment, we are going to receive the questions. So the presenters, please come to the front. The presenters, please kindly come to the front. Yeah, you can have the executive seats for today. You can have the executive seats.
Gitonga, the engineering team presented by the HOD engineering. Just take a seat. Because you have all the questions, kindly now I'll give you instructions. I know most of you are teachers, so you're instructed to give you instructions. So you have 2 minutes to summarize your questions. Thank you. And we begin with Madam Caroline Owino.
Good afternoon. I'm glad I've received about 11 questions. It shows you're listening. And I'll just summarize them into just a few responses to make good use of the time. So I was asked, how did you collect data? And a structured questionnaire. We went in person just to increase the response rate. It was Leicat. And I think you can see me after this. You see the kind of questions we were asking. I was asked again which digital learning technologies were being assessed. There were many, from just using basic email to Microsoft Word to video conferencing apps such as Zoom, Google, Microsoft Teams, to learning management systems and KNet. Again, I'm being asked when was the data collection done, because now there's a digital learning, digital literacy class. So we collected data between September 2024 and November 2024. And the group of students were from 1.2 to 2.2. So by then, the digital literacy classes are not begun. Recommendations for this study, further recommendation, we are saying frequent training of students on use of these digital learning technologies, because we know they're coming up every other time. So if a lecturer is intending to use, let's say, for example, Google Meet, the students need to be orientated on how to use them. If they're going to use certain search engines, then they need to be orientated on that. And the last question was, is gender and the use of DLT linearly correlated? So we did associations by the Kruskal-Wallis test. And I mentioned it's only specialization that had a significance in terms of correlation, whereby pediatric specialization was seen to have a high use of digital learning technologies. And gender and age did not have any significance in terms of correlation. So we even thought maybe age will have a correlation in terms of Gen Z and the millennials, but apparently even the millennials and even the boomers were quite good in using technologies as compared to the Gen Zs. Thank you.
Let's clap for her. Next one is Madam Heather for Jim Gitonga.
Okay, thank you. I have with me about 8 questions.
Kindly summarize them.
I'll try to summarize them because they are more of kind of different, but I'll try to summarize. So there's a question from one of us who is asking, on the developed system to track the drug interactions, is it possible, in your opinion, to use drug names instead of the codes in order to make it more user-friendly? So I'll say no, it's not possible to use the drug names, because you see the drugs that are there, we have the scientific name and the medical name. Like, for example, paracetamol, it's a medical name for the drug, but we have the scientific name. The scientific name, it has chemical compounds. So when I talk about a compound is a group of atoms of different elements. So like, for example, I can talk about hydrogen peroxide. We have hydrogen and peroxide, H2O2. So they are different. So how will AI predict this? It will only predict it with the data. The data is the chemical name. So when you want to look at the interaction, you must have drug A with its chemical compound names and drug B with it. So it will be able to now predict how they interact. And of course, the interaction you're talking about here, you know, there are so many factors that can bring drug interaction. It could be the chemicals themselves, when now they oppose how the drug should work in your body. It could be the food you're taking. So in the software we were building, we were concentrating on the chemical compounds that make the drug A and drug B. So if there's introduction, if there's, interactions, then the software should be able to predict and advise the doctor that this drug and this drug cannot be administered at the same time. Then on the second one, in your own opinion, should AI be integrated in health profession training? Yes, it should be integrated, incorporated in all the curriculums. Yes, even in nursing. Medical engineering is a special profession because it is a multidisciplinary. When we work in the health sector, we don't work in isolation. So how will the doctor or the nurse be able to know that the machines that we have are having a problem? For example, it could be a human factor. It could be sometimes in the display, it is showing you something. So if we integrate AI, we've already integrated it in medical engineering. Yes, when we reviewed our curriculum at certificate level, but I would advise that it should be integrated because in the medical field, we're using this equipment, which are digitized, which are using machine learning. And the basics is, if there's a problem, anyone can be able to solve it if it is a minor problem. But if it is a software problem, that is where now the engineers can be involved. For example, there's no display on the machine. Should you go and call an engineer to come and look for that? So if you have that AI knowledge, then of course, yes, I say it should be integrated in all the curriculums. Then on the third one is was about the model applied in teaching at KMTC. Of course, I've said in all profession, we can apply it and it is possible. Explain in layman's language the importance of your findings in relation to the health sector. And of course, AI predicts. It's about decision making. It's about solving problems. And solving problem, an engineer must not sit there all the time because just of a power cable which got disconnected. If it shows you on the screen, then you'll be able to know, even if you're a nurse or even if you're a doctor. The equipments we use are both for therapeutic and diagnostic. They treat and they diagnose. So anyone should be able to know that. Then there's also another question here that can the AI MRI simulator autocorrect the identify errors? Yes. If so, the autocorrect mechanism, it cannot, of course, remember, you are training, AI is about training. You are training the machine to work like a human being, like a brain. So if it is able to predict that this is what is happening, and it will not wait until maybe if the equipment now is down, but it will be,
madam.
yes, I'm summarizing. So yes, it should be, in as much as it can predict, it should also be able to autocorrect automatically. And how will it be able to autocorrect? Give it data, then it will be able to do that. Then lastly, there's one.
Thank you.
Okay, it's okay.
The next presenter is Maureen Kemboing. Kindly summarize your questions in less than 2 minutes, kindly.
All right, thank you. So the question was, how would e-logbooks assist the department in terms of real-time assessment, monitoring, and follow-up in relation to accountability? So my response would be the main element in the electronic logbooks, it is in the data collection. And of course, when we get data in real time, then we are able to offer feedback in real time as well. When it comes to the physical logbooks, the main issue is in, the going through probably 50, 60 logbooks, getting to find out what the student did, and then you come and plan for the assessment. So with the e-logbooks, you're able to generate a report. So it saves time in terms of, that report formulation, which is a requisite in, the planning of assessment. And for accountability, again, the e-logbook can be integrated to the ERP so that, people can actually see that students can be able to account for the time that they have been in the clinical area. And of course, lecturers can also be able to account for, the assessments they have done. And yeah, it basically enhances all elements in terms of, the clinical training aspect. Thank you.
Thank you, Maureen. The next one is Maureen Rivera.
I have about 5 questions.
Kindly summarize them in a minute.
There was a question that was asking about regulations in Kenya that control the use of medical devices. I think the one that governs devices is the Kenya Data Protection Act of 2019 because it deals with handling sensitive data. And then we have the regulation that controls the use of also medical equipment. We have the Health Act of 2017 and the Pharmacy and Poisons Act of CAP 244. Another question was asking, isn't 2001 to 2023 a wide range of time? The paper I've just presented was my master's project, and from our instructions, that is the range you are supposed to cover. In your methods, what were the search words? I used electronic medical records, electronic health records, computerized patient record, e-health, and m-health. Those were the keywords. Which search engines did you use apart from Google Chrome? It was only Google Chrome because different search engines will give you the same results. So I just used Google Chrome. Can a newspaper generate credible data in research? I have to admit that there were not so many newspaper articles that I got. So I think they're also not credible. You mentioned about a hospital in Nairobi where you got data. I wish to confirm that I personally visited the hospital and confirmed that this case was actually in court. Do you think 16 articles is less of a representation? I mentioned I used the Prisma checklist and it landed me on 16 articles that I was supposed to use for review. So that's it.
Thank you, Maureen. Cyrus Barry, summarize.
Okay, mine are just positive comments. One, it was a good study and a wonderful presentation. However, we need to work on our justification. We try to amend the justification so that we have got the justification and we have got the significance of the study. Lastly, the EMR is taking shape in our hospital setup. So the government required to strengthen it, even our managers. Thank you.
Thank you, Mr. Cyrus, for keeping time. Francis?
So I have not received any questions. Seems like you understood, or I don't know, but it's good. Yeah, also a recommendation, like we should try and study more about rheumatoid arthritis. It is less covered, particularly in Kenya. We encourage all those who are learning, the students, lab, clinical medicine, even nurses. We can do it. Thank you.
Wow. Let's clap for our presenters. That is what it takes to present a paper. We are growing. See, when people not ask questions, maybe they have understood everything or they have not understood anything. And then the Bible tells us those who have been given much shall be demanded from them. That's why we had so much from Heather, because of the medical engineering issue. Thank you, presenters. Take your seat. So as our presenter sits down, I invite my co-chair to give us the next order of instructions. Then let's clap for her.
Thank you, Dr. Nyamai, for being a very good co-chair. Let's give him a hand. Thank you. It was very hard to manage that time, but you really tried and assisted here by your timekeeper, I could see. Just one comment. We have been now we've been utilizing an e-logbook in some courses in clinical medicine for the past 3 years. So if you want to know more about how to do it, please feel free to reach out to the e-learning department and we can tell you more. Our session is over. Can we clap for ourselves? Thank you for your patience. Thank you, presenters, for taking us through and helping us to understand the space that we are in digital transformation and the use of AI. Please, we really need to see the medical engineering team. They really seem to be ahead on AI, and we will seek them for more information. It is now time for lunch. So I'll invite you to take your lunch and be back here at 2 p.m. Please be back here at 2 p.m. so that we can really catch up with the time that we have spent. Enjoy your lunch. Bon appetit.
So it's coming immediately after. Yes. applications before 3, because for the one for 3 is online. Karibu sana, karibuni. Karibuni, karibuni. Hello. Poster people, we can get in now. Let's get in. Let's get in. Thank you. Thank you for coming. Let's get in. Hello, let's get in. If you can also push, here in front, that will be very good. We can begin.
Good afternoon, everyone. Yeah, I think for the sake of time, we won't actually keep on waiting. Members will trickle in as time goes by. And this afternoon, I'll be your chair, assisted by Dr. Peris Kibet. My name is Muduka John. I believe most of you know me here. My students, good afternoon. There's a student who presented here today, the gentleman. Munikumbushe jina yake before I finish my session. That the young man who presented about rheumatoid arthritis. That's I did not have a chance to tell him something. That's a research in the making. That boy will go far. Yeah, I see them before they are born. That one, that's a game. So as I said, Muduka John is my name. And when I was a young boy, my grandfather told me, when you want people to start dancing, even if there is no music, just start moving like this, even if there is no music. So they will start assuming there is music. So let's start dancing before the music comes in. Now, we are going to have an interjected section with some presentations as usual, and then exactly at 3, we will have a break where we will having our keynote speech on the agenda for today. But I would request for the presenters that are in this afternoon, we are going to have one which is going to take place right now. That one is not, the presenter is not here physically. The presenter is in Nashville, United States of America, from an institution called Meharry Medical College. Her name is Professor Rosemary Nabawesi. She's an associate professor and a medical doctor. So we will be following her presentation online, and then after that, the others, maybe 1 or 2 before we go to keynote speech. We'll pick on, then after the keynote speech, probably we will have the normal routine for questions as usual. So I would ask the technical team if the USA presentation is ready. Please, you can right on go. But before that, just to mention something, Meharry Medical College is one of our potential partners in waiting, whereby we are looking forward to collaborate in matters of research and resource mobilization moving forward. And we said we should not limit ourselves. Let's try and move across borders in terms of research. And if you be having any questions for her, then feel free to do as we have done. So we go straight to the recording, and then after that, we pick on the next physical presenter and maybe another one, and then at 3, we shift gears to the keynote speech. Then after keynote speech, we pick the other 2 or 4 or 5, and then we see how it's going to proceed. So technical team, please, you may share the presentation for Professor Rosemary. So as they prepare that, the other presenters, if you know you are presenting today is by the schedule, you need to be ready. And in fact, I would be happy if you are this afternoon presenter, it would be also be obliged to request you. You may come and take the front seat here so that we know who is not there and who is not there. Maybe probably I might be forced to make a reference to the names and what have you of those who are presenting. However, we can do that just immediately after this presentation.
Thank you so much for this opportunity for me to share the work college with you. I am Rosemary Associate Professor in the Department of Political Determinants of Health, Global Health. Our work was funded by CDC. This was a supplement to Nationwide Children's Injury Control Research Center. And part of this work was done looking at the effectiveness of street solid as an intervention and looking at the implementation effectiveness as well. And we're also collaborating on messaging and dissemination. This is our program evaluation team, Dr. Vince Morelli, who's in the Family Community Medicine Department at Meharry, and Mr. Ron Johnson, who leads the Street Solid facilitators. Again, why was Street Solid established? We see that for people under the age of 35 years of age, homicide is the leading cause of death, and suicide is right behind it. But once people get to 35 years of age and older, suicide rates take over the homicide rates. And the other important factor to note is that both in suicides and homicides, most of these unfortunate incidents happen in male population. And so Street Solid organization was developed to try to provide an intervention to violence in certain communities, in both the youth and adults, without necessarily involving the police. Our program really looks at structural interventions. How can we be able to address the physical environments or social environments that the youth and adults find themselves in? How do we promote pro-social bonds? And promoting this should be able to interrupt the violence among our young people. So what is Street Solid's mission? The organization's mission is to support social emotional growth among young men and young youth who've been involved in the justice system here in the US. Typically, these are people from underserved communities, less resourced areas, and the goal is to help them get on a track to become productive citizens. So what does the Street Solid intervention involve? It is a facilitator-led program which helps build strong relationships with the participants and helps them change their thinking through cognitive behavioral therapy and social emotional learning. Again, this is what I spoke about. The Street Solid sessions are set up to have 16 sessions, and we cover 15 modules, which I'll show you in the next slide. And again, the techniques are grounded in cognitive behavioral therapy. And the goal is for all participants to reach their potential. So the 10 modules typically touch on emotional intelligence, addressing trauma, like I spoke about, including adverse childhood experiences that the participants might have gone through. We talk about their identity, self-esteem, relationships, resilience, and leadership. And while delivering these educational, while delivering this knowledge, we're intentionally building opportunities to develop relationships, for people to be comfortable, for people to connect with the facilitators as well as connect with each other. And hence we have the introductory session, review sessions, and then we also build in some flexible sessions if we need to go back to something that we discussed prior to the session, or a topic that is that the specific cohort is very much interested in. And then at the end, we have a graduation session. So again, this project was called Violence Injury Prevention Evaluation. And the objectives, as I mentioned earlier, were to determine Street Solids program effectiveness in transforming formerly incarcerated young adults and youth into productive citizens. And the other objective was to evaluate the program's implementation effectiveness. So when the facilitators are delivering the Street Solid program, what's the level of fidelity to the core components of Street Solid? How acceptable is the program to the participants? And we're also looking into the sustainability of the program. And then, of course, we'll design a dissemination plan for this specific program as well. So for successful implementation, what are the determinants that are going to facilitate or hamper implementation? So we know mentoring is an important one in these learning sessions. Active listening is going to be an important one. Then, of course, the major factors are going to be the social determinants of health. What social factors are going on in the participants' lives? For example, in the neighborhood that our youth are coming from, or the participants are coming from, were there gunshots that took place the night before, such that our participants did not get sleep, or perhaps it was someone they knew that got shot? That is going to impact their participation in the Street Solid session. Other social determinants of health are like, were they able to get breakfast before they came to the session? Do they have food in their homes? Is it calm? Are there stressful situations in their homes? So such things can impact not only the attendance, but also the participation in the sessions. And then truancy and rearrest. Of course, if we enroll people into the program, sometimes stuff happens and they get rearrested, or they don't come to school. So that can have an impact on the numbers who complete the sessions. And I didn't mention this, but typically for the youth, we meet on Saturday mornings at 11, from 11 to 12:30. And we have that every Saturday for 16 weeks. So mechanisms of change for the intervention, we're looking at behavioral change at the individual level, we're looking at organizational change. So within the schools, the middle schools that the students are coming from, is there going to be a particular change to sort of help support the students? And then systemic change, if we're thinking about the prison places, the incarceration systems as well. How do we make an impact on those? So the specific implementation strategies that Street Solid harnesses include adapting and tailoring the core content of Street Solid to the specific context, right? So if you have students from one county, maybe they have specific priorities that are not particular to another group. If you're working with youth, you might be able to change some things in the Street Solid training message compared to young adults. Of course, engaging customers. This is really intentional on getting active engagement of participants in Street Solid. Facilitation is a big one because we train the facilitators and they're the ones who help the participants learn. And training and educating the stakeholders, those are major implementation strategies, right? So we conduct ongoing training, not only for the participants, but also for the facilitators, which is the last one, train the trainer. In fact, we have several of the participants, once they're done with the 16 sessions, some of them are so invested in the program that they feel they want to get the training and become facilitators themselves. Of course, we have some educational materials that we distribute to the participants, and then we also ask for their input. We conduct surveys with the participants, and we'll also conduct focus groups. So our data, we collected our data through observation. I sat in through the Street Solid sessions. We have pre and post surveys that we administered before and after the 16 sessions. And then we also give the participants an opportunity to give testimonials on what they got from the Street Solid sessions. And then we conducted a focus group as well. So these are some of the results from our session. This was a federal cohort, people who were imprisoned by the federal system in 2023. And when you look at the self-efficacy, their attitudes and their knowledge about the information we taught them through Street Solid, most of them, their performance increased. They felt more able to take themselves out of difficult situations, be better at decision making, their attitudes about trauma improved, and the knowledge, they show that they gained some knowledge from the Street Solid session. When we're thinking about adverse childhood experiences regarding that training session, again, self-efficacy regarding ACEs, the knowledge increase, as well as the attitudes about ACEs and how to overcome them. This shows that at least in the immediate time frame after the session, people grasp the knowledge and their attitudes about the traumas they face as children improved, or they had better understanding of that. So to conclude, Street Solid cognitive behavioral therapy and social emotional learning intervention improve participants' knowledge, attitude, and self-efficacy in the specific social emotional skills we trained them. So we will be analyzing a focus group we conducted last week, and we will be combining the qualitative and quantitative data to come up with a wholesome picture on what we did. I would like to acknowledge our team. We had a summer intern, Kiran Bicham, on this project, who did most of the data collection and analysis. And then again, I would like to also acknowledge our dean, Daniel Dowes, who leads us in the School of Global Health and is very supportive of this work. Thank you so much. In case you have questions, just let me know. And thank you again.
Thank you so much. For those who had not joined us, I have to mention that was a pre-recorded presentation. The authors are on board wherever they are right now. They're in Nashville, United States. And when we start asking questions, we'll post questions to them. And we have gotten some concepts, on cognitive behavior therapy in terms of empowering the youth and the adults. And this is basically to interrupt violence. Now, I know someone would ask the relevance of that topic in the audience. Some cities that have already grown, violence has become a public health threat, technically. And then it is trickling down towards the young ones. And in the context of Black Africans or Black Americans, especially in the United States of America. The upscaling of this idea with the researchers came based on some excessive killings, and those killings are mounted from very young people because of social issues that are compromising their livelihoods. And it's very common in North America, even some parts of Canada. It's very common, and they're calling it the Black youth violence, and it's becoming a public health threat. In the context of Africa, we might not see it in that way because all of us are Blacks. But you need to know now in the Western countries, like in the US and Canada, we have Black Africans, Black Americans who are in the midst of the whites. And now the concept of racism and what have you was a driving factor. As you have heard, the author has said, these are preliminary findings. They are now working on quantitative data, which they are looking forward into amplifying their findings. If you have any pertinent question, you may just put it down, especially in terms of methods that they used, and probably more so upscaling and the reliability and applicability of the same concept in the context of Africa. So when we are conducting this research, let's not just limit ourselves into the domain where we are working. Be global, and that's how you can create an impact. That's the reason we had to rope in such a presenter to demonstrate the etiquette of research can cross borders, and anything that happens in someone who is in USA could as well happen to someone who is in Africa. Without much ado, I'll read the following, and maybe you just be ready at 3. We might be stopping to go for plenary presentation. Is Rachel Ireri in the house? If Rachel, you are there, please come in front. Meshak, Shiundu, those are the presenters for today. And then we have Wangari Mutuku, and then we also, Rosemary has presented. Then we have Rachel Moli and George Lucy Adie. Do we have any of those here? Yes, George, you are there. Wangari, Shiundu. So I think if Rachel Ireri is not there, I'll follow this program. The next should be Wangari. Yes, Wangari, you take the podium, and I'm giving you strictly 10 minutes so that you not stop in the midst. You have 10 minutes, Wangari, for your presentation. And I will allow the technical team to prepare that. In the meanwhile, the floor is yours. You may take advantage as they load. I know the work is here. You can as well start presenting.
Good afternoon. My name is Wangari Mutuku. I am a lecturer at the Kenya Medical Training College, Taveta campus. This work was done while I was working, doing my master's. Why we are doing male partner participation in ANC. The main question is, why are we doing it? And the reason, the main motivating factor as to why we were doing this research is pregnancy is something that has been associated for the female people alone in Africa. The male not necessarily put in a lot of effort. So we wanted to understand what are those things that are contributing, not male being kept like this is our business. We wanted them to mind their business and put themselves in this pregnancy so that it can be a whole thing. People can be more comfortable. We can adapt it so that when we are having challenges, then we are looking at it as a whole, like a family. How are we going to go better? Our background of study, the main contributing factor was we are not yet there where we are required to get to the neonatal mortality rate. Our current neonatal mortality rate is 21 per 1,000 live births. That is where we are at. But where are we expected to be? We are expected to be at 12 per 1,000 live births. Now the question rises, what is this contributing to these live births? What is this contributing to this neonatal mortality? And some of the factors that were contributing it was a skilled labor delivery, people being there to just advocate for you while you're giving birth. And that's the person, that's the male partner. Now we brought in the male partner so that they can be doing this job and see if you're gonna put the neonatal mortality to a lower rate. Our objectives were to determine the socio-demographic factors, to determine the obstetric factors, to go ahead and determine the prevalence and also establish health system factors that are contributing to the male partner participation in the area. The study was a cross-sectional analytical study that was conducted in Kangundo Level 4 Hospital during the month of July and August 2023. The target population was 250 mothers, and it was a systematic random sampling, whereby we were sampling every fifth person in the whole entire place and was in our criteria of inclusion. We used Crunch Bar Alpha to ensure we had a good internal consistency, and our KS Mayer Olvin value of 0.75. And all this data was analyzed using R, a software. When you look at the major key findings, we did, as you have seen, the second objective was to determine the socio-demographic factors. When you look at the socio-demographic factors, there was nothing that was really interesting to give people in the policy making. So you wouldn't find any answers in socio-demographic because there was nothing that we can use in the policy making to bring about any change. So it was so insignificant. We never bothered to put it. But what was very interesting was the number of A and C visits that was done. When you look at it, we're starting at 1 to 9. When you go to 9, it's showing you that people who were most likely to go for 9 A and C visit were most likely to be accompanied by their spouse. These people were accompanied by their spouse. When you look at it, you'll ask why 9 and not the 4 that were there. During this study, that hospital was encouraging that female go to their whole antenatal care clinic for whole 9 months. So that's why we are having 9. The overall male partner participation in that area was 29. 82% of the annual ANC, 82% of the women attended more than 4 ANC visits. And the highest proportion of the male partner participation was the age group between 20 to 29. That shows you something. Maybe the young generation is putting this into consideration, is thinking this as an holistic view, which is very interesting. Why? Because we're imagining our old people are the ones who are holding the families together, bringing about tradition. So we were likely imagining it will be the older population, but it was 20 to 29. And then lastly was people who have gone for higher university education contributed to 68%. We were imagining these people who have gone to higher education will be busy working, but these are the people who are there in the hospital with them. So the question is, what are we not doing, and what is this information that is not there? We went ahead and analyzed this data using linear regression, and these were the variables that were so interesting for us to find out. And the most interesting was that when health education was given, then the probability of someone going for antenatal care visit was high. That is at 34.12 odds ratio. Basically, what are we saying is that next slide, please. Basically, what you're saying is that the key finding with health education, we can get there. Pregnancy complication was one of the contributing factor, but what we do if we get to look at this pregnancy complication, that means you're gonna go far, while the partner request also contributed a bit part. So it means that if I request my partner, my husband, to accompany me to the facility, then probability of him accompanying me was very high, meaning he will advocate for me the way I'm supposed to be advocated for, and I'm gonna receive the better healthcare at all. What we are looking to in the policy briefing into it is that we are looking in ensuring that we incorporate the male people into the ANC clinic. For us to do that, we need policies, and that's why this research was very interesting to put into cross so that we can bring about the policy part of it. Next slide. The discussion is that when you look at it, Kenya, we are at 29%. Other countries like Rwanda are at 87%. Why are we using Rwanda? We're using Rwanda because Rwanda has borrowed our own policy and is using our own policy. So if it's workable in Rwanda, then it's also workable in Kenya. Acknowledgements, I want to acknowledge the Mount Kenya University I also want to acknowledge the Kenya Medical Training College and my mentors, Dr. Mutono Nyamai and Dr. George. Yeah, this paper has been published by the Willis Publishers and Hindawi Publishers. So it's out there in the Google Scholar. It was published 18th April 2025. Thank you.
Clap for her. That was very nice and you kept time very well, very sensitive. So next we will have, please keep your questions on record. We will have, the next should be, is it Meshak Shundu? Yes. Meshak Shundu, you have 8 minutes.
Good afternoon. And our study, we are focusing on storage-related hematological and biochemical changes in sickle cell trait donor blood. So this study, I did the study during my MSc in hematology and blood transfusion. And it's good that I should...
Just a minute, Shundu. Technical team, are we bringing that on board? Okay.
I was doing this work under the supervision of Dr. Michael Walekwa from Kabarak University, Dr. Mbugwa Amos from JKUAT, and also Dr. Caroline Mangare from Southeastern University of Kenya. Next slide. So if you look at this study, we were focusing on sickle cell trait donor blood. So please, let's mark that a sickle cell trait carrier will be qualified to donate based on what we call Kenya National Blood Transfusion Guideline, because you're looking at the HB 12.5 and other factors like a good status. Now, sickle cell trait is a genetic condition. And in this condition, we have one hemoglobin beta allele with that gene condition, that's RS3340, and also one normal allele. Then we have what we call sickle cell disease, SCD. And this condition, we understand that this is a genetic disorder that is characterized with, we have the glutamic acid being substituted with the valine in the beta globin, what we call the 6 codon. Globally, we need to understand that we have approximately 20 million SCT carriers. I've said it is important that we understand at this point that if you are a sickle cell trait carrier, you will qualify to donate as per Kenya National Blood Transfusion Service Guideline in this country. Next slide, please. This study was focusing on what we call hematological and biochemical changes. When we donate, the blood will be collected in the blood bags. What comes in immediately or almost immediately is what we call changes. And these changes could be biochemical or hematological. Now, looking at the problem statement, we are in Africa. Africa is our business, and therefore, nearly 7 million blood donations are required annually. But as a continent, we're only meeting half of this. So we have scarcity or we have inadequacy in this area. Now, coming to Kenya, every 10 minutes, about 7 Kenyans are in their need of the blood or blood product. So this will justify that if you are a carrier, then there's high chance that you're likely to donate and your blood will be used in the process. Now we are focusing on the objectives. And our general objective or broad objective was to evaluate storage-related hematological and biochemical changes in SCT donor blood at Kisumu RBTC. Specific objective, 1, we were to determine the prevalence of this SCT because initially the information from the online, the last this study of this kind that was done, it was in 2016 by Usman. So we are trying also to update what we call the database on this information. And again, we need to compare, we compare the storage changes, both hematological and biochemical in SCT and normal hemoglobin blood, HbA. And again, you also compare the issue of demographic factors and how they can be associated with the SCT status distribution. Please, at this point, we need to understand that in this paper, we were able to truncate this paper into 2 as per the requirement by the Kabarak University, which funded the project. They funded me with the 500,000 Kenya shillings. So one of the requirements was to ensure that we publish 2 papers And that's why if you check online, you realize that we have 2 papers for the same funding. Next slide, please. Now, methodology, we use cross-sectional laboratory-based experimental study design. And once we obtain the blood donors who are voluntary blood donors, they met what we call Kenya National Blood Transfusion Guidelines. We recruited those people to donate. Then from there, we were able to do what we call screening. We screen using what we call sickling test. Sickling test, we are using sodium biometasulfite. Then we confirmed using what we call the sickle scan. Then we are able to check what we call hematological and biochemical changes. And this was done successfully from day 0, which was a baseline. We moved to day 7, 14, 21, and 28 successfully. So we are looking at various parameters, like in hematology, we are able to do what we call MCV, MCH, hemoglobin, percentage hemolysis, among other parameters. And also in a biochem, we did ferritin level, LDH was among them. We focused on bilirubin, sodium, potassium, among other vital biochemical. Next slide, please. So, and we need to remember that before we did this study, we followed what we call ethical consideration. We obtained the ethical clearance from JQuat. Then from there, we obtained NACOSTI. Then I went to Kenya National Blood Transfusion Service Guideline, just behind us here. The office, headquarters, I obtained permission from there. They sent me to Kisumu Regional Blood Transfusion Service, where I also obtained another permit, even from the county government, under the county offices for health services. Now, looking at this study, 10% of the people we screened were positive for this condition. That is 33 out of 336, which means that in every 10 people, and here we are referring to voluntary blood donor, 1 could be positive for sickle cell trait. So the number is high, and the study was done in Kisumu. Let's move, please, because of time. So these are some of the parameters that we analyzed. And if we check on your right, we have the sickle cell trait negative, and also positive. So we are checking the parameter from day 0, which was our baseline. We moved to 7, 14, 21, and 28. Next, please. Next. So in hematology, we focused on hematocrits, MCHC, white blood cell, and platelet. And if we check this study, I'm sure because of time, this study is online. You can even log in and check Shiundu Meshach, you get the information. So you get this information, and it's very crucial at this level, because I believe that this will be the beginning of, we could even come up with a policy, especially in sickle cell trait and sickle cell disease endemic areas like Homa Bay, Kisumu, Siaya, and counties in Western Kenya. For example, let's move. I look at the percentage hemolysis. By week 4, there was an increase in HB level in what we call SCT, positive. And this was more pronounced as compared to HbA. Those are misspelling there. And please, this percentage hemolysis was a very important parameter for evaluating the quality and potency. Because if you are giving a patient blood or a blood product, then you should give the item and not the tomato sauce. If you are giving me the blood that has lost the potency, then that's not blood. Yeah. So on biochemical changes, we focused on LDH and sodium, ferritin, potassium, among other biochemical tests. Move to the last slide. Recommendations. So we have the implication of this transfusion safety. What is the effect of transfusing this? For example, we could talk of hyperkalemia, we can talk of hyperbilirubinemia, reduced oxygen carrying capacity, because the blood is already deteriorated, and looking at the ingredient is not there. So it's like you're giving something that looks like blood, but not blood product. And some of the recommendation, we are recommending the increased, so looking at this, we can practice what we call shorter storage duration. If you go through the finding, you realize that if we give blood within the first 2 weeks, then the blood will help the patient as compared to giving the blood from day 21. But I understand that in Kenya, we have a shortage. And that shortage it's an advantage to us because when you donate, the blood will be used within the first week, which is working for us. Now, can you imagine 20, 30 years from now, what will happen if we don't correct the situation? Periodic monitoring and the biomarker, we could check the ferritin level, the glucose level, and see whether the parameters are within what is recommended so that we can transfuse or not transfuse depending on the parameter. And again, we can do what we call pre-transfusion testing for hemolysis markers. We can test the hemolysis. Lastly, and again, we also recommend what we call we can also do what we call the HB variant testing. I always believe that if we have what we call if we can ensure that we have what we call appropriate resource allocation, Kenya can come up with a machine in what we call sickle cell disease and sickle cell trait endemic area so that we have a system whereby we can test people. When you have a baby, let's say at 6 months, we know the status. And let's have a database so that as a country, if you have a baby in those regions, when the baby is admitted in the hospital, we key in the information for that baby, then we get information on the sickle cell status. Like in this case, we are using what we call the HB electrophoresis, and we can also use what we call HPLC, which is affordable for our country. Thank you.
Thank you so much. Thank you so much. You've done very good work. I know your study was intense, and there is always that desire to explain, and I can understand where he's coming from. And you said the work is published, and then I think that's a good. They should have provided the links to that, so that because I think it's a new concept as well. So we'll have one more presenter as we give our keynote speaker a few minutes to rest. So you have, we have George Lucy. George Lucy, I'm giving you 8 minutes. Ile ukweli. Ile ukweli. Hata unakaa hata 3 unaweza. Unaona venye umedunga? Uko tu sawa. Like you can summarize your work. Trust me, you better. Thank you, sir. You're most welcome. Let's clap for him.
Thank you. Hello, everyone. Good afternoon. George Lucy Adia is my name. I'm an external lecturer in Segawet KMTC, and this is found in Kericho County. I'm going to do, my presentation is on HIV. What I know as introduction, HIV is a pandemic. 2, if you are not affected, then you are infected. I'm going to work on factors influencing utilization of HIV among exposed infants at Segawet Sub-County Hospital in Kericho County. Next. Background information will be narrowed down from globally. Those are just prevalences. Those are just to do with the figures. Global, sub-Saharan, in South Africa, in Kenya, and in Kericho County. Prevalences states that in globally 7.9 million people are affected. This was done in 2018. Of these, 36.2 million were adults, and 1.7 million were children less than 15 years of age. UNAID 2018 states that. Sub-Saharan, we can see that 22.5 million are living with HIV, and this represents 68% of global HIV AIDS, whereas 4 in 5, that is a ratio, among adolescents 15 to 19 years of girls aged 15 to 30 years are twice likely to be living with HIV than men, and this was done by UNAID 2018. In South Africa, what happens, 40% of dead children less than 5 years of age are attributing to HIV, and that was done by Dorrington et al. In 2010. In Kenya, it is estimated that 1.6 million people are living with HIV, In that one, we can see, narrowing down to Kericho County, the related childhood mortality is still high, despite the availability of ART. We must appreciate the work of the Kenyan government and the national government in that. Next. As problem statement of my study, we can see that the children that are exposed, what is the magnitude of these children in Sigowet sub-county hospital? The magnitude says that the situation in Sigowet sub-county hospital annual report revealed that roughly 35% of infants were not tested, though their mothers were HIV positive. That is a point to note. Communities in such a rural area setup usually have high rates of infant mortality than in modern setting. For instance, Sigowet Hospital has an infant mortality rate of that one per 1,000 living compared to 72 per 1,000 nationally. KDH 2018 states that the study focused on diagnosis among infants because of what? The consequences of HIV infections leave them more vulnerable compared to other ages. Hence the gap, we want to do that. CT, continue. Research objectives and research, the broader objective is to assess the influential. Specific one is to determine the prevalences of HIV infection. 2 is to determine the enabling factors. 3 is to determine the need factors. Hence, the questions are there to be answered. Next. Next slide. The justification, why this? The researcher worked on according to the justifications were done according to the specific objectives. So if you can look at that, you will stand the understanding prevalence of HIV by unveiling the factors, enabling factors, and the study identify needs factors. Hence, the finding will be shared at different levels of policy planners and smooth implementation of utilization. Next. Conceptual framework can tell you the outmap. Independent variables were there, determinant factors, enabling factors, and need factors. We have the intervening variables. When we follow these, then we will we'll achieve the outcome. And this one will zero in to Vision 2030, whereby we will have reduced infant mortality rate. Hence, we will have a percentage of children that will be tested. Next. Methodology study design was a cross-sectional study that was done during April-June 2019. Targeted population were 199 HIV positive mothers. Criteria selection, inclusion criteria, consenting HIV positive mothers and exposed infants. Exclusive criteria, HIV negative mothers and HIV positive mothers who doesn't actually consent. Then, city. Results, democratic. Why democratic was visualized by the researcher. 1, all the participants were tested and they participated. Hence, there was no biasness in the study solution. Then, next. That is what was there according to mothers and guardian ages. Then we can see there was a Pearson correlation, analysis of personal factors influencing. There was a positive correlation between the relationship of next of kin to hay and that marital to mothers. That was a p-value that was stated at 0.05. We can see a p-value of 0.02. Last. Conclusion, the study also concluded according as per the following one, specific specific objectives. Then we will see how the conclusions were done, and this one we can see. Next, recommendations were, long-term recommendations were made, and Sigowet Hospital should devise a mechanical enhancing hospital deliveries. Then Sigowet Sub-County collaboration with relevant stakeholders should enhance early diagnosis, then Ministry of Health, that is national and regional government, should enhance the social support system. And therefore, further research will be done in that order. Thank you, and may God bless you.
Thank you so much, Lucy. Thank you so much. Now, clap for him again, please. Yes, sometimes I know there was a bit of time factor. The work was intense and he needed us to get more. So is the work published? George, is your work published? So we can access the work. So audience, I think we are good to go. That's a good thing about it. People are publishing, so it's also prudent. Whatever you present, maybe the audience might not be in a position to capture everything clearly. Just refer them to publication, and that's how it goes. In fact, it improves your score. Now, members, in our midst, we have our keynote speaker for today, and I would kindly request him wherever she is, because hatujui lakini tunajua jina, Dr. Meshak Dirango Wanjuki. Sir, you may come, take the front seat as I introduce you to the audience so that they can see you. Yes, you may just take a seat. I need like 1 or 2 minutes. It's good that we know whom we have before us. Dr. Dirango Wanjuki serves as the country director of AMREF, Health Africa in Kenya, and he leads a dynamic and a diverse team of over 500 professionals and managers. And on that same note, he has had a couple of grants which has passed under his leadership, some to a tune of 70 million. I'm seeing another tune of 350 million, not Kenyan shillings, US dollars. So you may start converting that and then tell me what are we looking at here, man? So, and yes, and when you look at him, can you see that? Can you see that in the head? You can as well see mine. As a visionary leader, Dr. Dirango has spearheaded large-scale health initiatives, securing over 350 million US dollars in funding and driving transformative outcomes. That's a game, transformative outcome, and that's why we are here. His expertise lies in optimizing operations, fostering best practices, and driving sustainable growth trajectories. He excels in cultivating strategic partnerships with development agencies, philanthropics, foundations, and governmental entities to drive development agendas. He is committed to talent development. So for the young ones who are here, talent development and organizational excellence, Dr. Dirango is an accredited executive coach dedicated to nurturing emerging leaders and fostering inclusive and supportive work cultures. Just to mention a few, Dr. Dirango holds an executive Master of Business Administration, Master of Public Health, Bachelor of Medicine and Surgery, and post-grant diploma in executive coaching. And that is where I'm focusing on, that part of executive coaching is a gist where you need to utilize the head before it starts to get tired, especially for the young ones and colleagues around here. Let's learn to network with the like-minded people. So you may grab a copy at a local bookshops or find it on Amazon based on the work that he has done. People talk of bookshop and Amazon. Now we are talking of different audience here in terms of publication and dissemination of work. So without much ado, we welcome Dr. Wanjuki with an applause, please. Let's clap for him as he takes the podium. Welcome, sir.
Thank you very much for such flowery introduction. I truly appreciate, and certainly I'm not Mr. Moneybags, eh? But I truly appreciate. Good afternoon. It's truly an honor to be here. Today I'm going to talk about something that is very close to my heart or to my mind as a profession in the medical sector, health sector. and also to AMREF, the organization that I worked with for more than almost 20 years today. I'll be talking about how we can build smarter health systems and how specifically we can use AI to build those systems, helping to reach everyone faster with better care. So I don't have a presentation, but the title of my speech is Smarter Health Systems. How can AI help Africa reach everyone faster? So distinguished colleagues, policymakers, health professionals, students, and partners, it's a true honor to join you at this 8th KMTC Scientific Conference. And indeed, congratulations for hosting the 8th conference. And thank you for inviting me. Allow me to disclose, not a conflict of interest, but Dr. B here, we were in public health school together when I was doing my first master's. As you heard, I have 2 of them. Yeah, we're in public health school together. And I never knew that one day you would be inviting me to talk about AI. It's a testament of how we must keep rediscovering ourselves. I think when you were in public health school about, was it like 10 years ago? I don't think even in our class we ever talked about AI. We talked about statistical modeling. We talked about SPSS, logistic regression modeling, and all those things. We never talked about artificial intelligence. So well done, Dr. Ali, that we are evolving even as we are aging. And that's the whole spirit of today's conversation. Congratulations to KMTC for convening a timely and impactful event by bridging the best of academia and real-world practice. You have created a powerful space for meaningful conversations and bold ideas. Over the past 3 decades, I've had the privilege of serving at nearly every level of Kenya's health system, from the local district level to the national level. And just a few weeks ago, and you did not mention that, sir, I completed a course, a 12-week course on artificial intelligence and machine learning at MIT. That is the Massachusetts Institute of Technology. And so, again, it's a reminder to us that us in the health sector, sometimes we only look at courses in KMTs, in medical schools and health areas. But we need to start thinking about how do we learn from data engineers, data scientists, and the like. That is the only way we do not allow ourselves, even our careers, to become at risk. That experience left me both deeply energized by the possibilities ahead and aware of the work still to be done. Colleagues, allow me to tell you that from what I have sensed as I have interacted with what is possible from artificial intelligence and machine learning, we are starting at a moment of rare opportunity. Tools like artificial intelligence, machine learning, when you combine those two, they are called data science. So when you hear of data science, you can always say in brackets, machine learning and artificial intelligence. And additional tools like genomic sequencing that are happening, that are no longer abstract concepts, even in our continent. They are rapidly becoming part of our healthcare toolkit. Before healthcare toolkits or the laboratory things we were talking about, the PCRs, the most advanced we could talk about were the protein reactions and all those things, molecular testing. But now there are toolkits beyond molecular testing that are more advanced, artificial intelligence, genomic sequencing, and all that, and what it could, and others that are coming up. Friends, please do not be left behind. Learn about these tools, not only to remain relevant, but to ensure that Africans like you and me, also are able to get the care they need from such novel technologies. Remember, years ago, there was a huge debate about antiretroviral medicines. A lot of people said ARVs cannot work here. They said we do not have the organization, and all that, and the coordination to deliver ARV adherence. Didn't we do that? Exactly. We did that. You did that because the work that you do every day is what is driving that. And we have, in like 2 to 3 decades, we have made huge gains in HIV programs. I want us to do the same. I encourage us to do the same in these novel technologies, artificial intelligence and machine learning. And when you have a moment, begin asking, what is what is genomic sequences, what is genomics, and what is its role in moving us towards what is now being called precision medicine. If those things they are already happening elsewhere, and if we are not practicing them here, then why would we call ourselves elites? If the elites of Africa, we do not practice these things, that means we're letting down the village where you came from, your parents who invested so much fees in you to become an elite. I encourage us to become elites properly by ensuring we are at the leading edge of the health sector development, not at the middle edge. In the worst case scenario, at the trailing edge. Yeah. How do we make sure that these tools, novel tools, serve our people, not just in big hospitals, but at the last mile? Today, I want to speak about artificial intelligence, how we can all deploy artificial intelligence to accelerate Africa's journey towards equitable, resilient health for all. We know the challenges that we face. They are not secret. Achieving universal health coverage, social authority, health insurance, and all that. Reaching the most remote communities with the services that they need. Building systems that can withstand shocks like pandemics, epidemics, and climate disruptions like flooding and all that. Now, within the context of these real challenges that many of you face, I once worked in Turkana for 5 years, and I knew what it meant when the rivers flooded, and we could not deliver even vaccines, and we do not have drones. We did not have drones. Fortunately, those days during the campaigns, we could charter a helicopter during the immunization campaigns, and the helicopter would take the vaccines wherever. Of course, these days we have drones that do that at a cheaper cost, and they are powered by AI and machine learning algorithms. Now, how do we use AI within this context? AI is not a magic word. It's not magic, but it's a powerful tool in our wider health toolkit. When applied creatively and responsibly, we can deploy AI to move faster and smarter towards these goals of UHC, health system resilience, and doing the most important thing, reaching 55 million Kenyans, wherever they are, irrespective of where they live. Picture this, a clinical officer in Turkana, where I worked for 5 years, using a portable digital X-ray machine for timely tuberculosis diagnosis. That helps ensure timely diagnosis because it has a machine learning algorithms trained with over 4 million chest X-rays and is out there in the field, not in the X-ray department. They're able to say, this is TB, this is sarcoidosis, this is something, this is chronic bronchitis and all that. Often with high accuracy than radiologists. Picture that. Already AMREF and the Ministry of Health National Tuberculosis Program. We're investing in this. And I know a number of you have come across AI-enabled digital X-rays as a very good example of how we can begin looking at everything we're doing and asking, how do we extend it further by using artificial intelligence? X-ray is one example, and there are so many more. Or a pregnant mother chatting with the medically validated AI chatbot, like the one developed by Jakarta Health to offer trusted guidance during pregnancy, ensuring that whichever language you speak, even in Swahili and all that, there are chatbots that are able to offer that trusted guidance without the mother having to always come to the clinic. They're supposed to make, is it 4 or 8 ANC clinics? 8. But in between that, what happens when they have a question? Are we ready to be part of training such AI chatbots, or shall we allow them to be trained and then later on we wonder, where did these come from? These are not dreams of tomorrow. They are already here, as I've given you examples. Kenya's digital transformation journey from M-Pesa's mobile money revolution to the electronic community health information system, what is known as CHIS, and the dozens of startups in AI and machine learning in the health sector that are happening in Africa, at least several in Kenya, like Gigi Health, formerly Damusasa in Kenya, These are signs that we are ready. But this momentum is not enough. I want us to think of AI, artificial intelligence, like a powerful vehicle, whether to you that's a Mercedes or a Tesla or whatever vehicle that is. Now, without roads, good roads, without fuel, without a trained driver, you won't get far, however good a vehicle you have. Without laying the foundations for AI in ourselves, in our country, in our continent, however good AI is said to be, will not make much use out of it. That's why we must now invest in 3 things. The right foundations, number 1. Number 2, we must build relevant use cases of AI or practical applications of AI, not theory. And number 3, we must work to manage the risk that comes with AI development. The same way when you're driving the car, even if it's a Mercedes, you have the brakes so that you don't just go crashing. Remember the first cars when they were made, they crashed because they had not thought about how do you stop the car. So what are the brakes we are putting on AI? But colleagues, before you start thinking of brakes, you must have the car first. Do you see that? Sometimes we talk so much about governance, regulation, but you do not have the car. We talk so much about brakes, but you do not have the car. We do not have the use cases. And that's a challenge I give us. As we talk about policies, governance, it's very important. Those are the brakes, they are the boundaries. But we must ask, what are the use cases for AI in our context? You see that, eh? Let me speak briefly about the 4 critical foundations. I said foundations is one of the areas that we need. Think about it this way. If AI were a building, AI in health were a building, what are the 4 pillars that would hold that building together? The first one is robust infrastructure. And here we're not talking about roads. We're talking about every health clinic needs internet, electricity, and digital systems, connectivity, because without these, AI won't run. Think of it like fuel, roads, and the rights for the journey. Number 2 is skilled people, and that's why you're here. Technology, AI, machine learning is useless without people who understand it. We must train ourselves, doctors, nurses, students in AI and digital tools, starting with the KMTC classrooms. If we are not doing that, let's start doing that on Monday. And we are happy to start walking that journey. I know you are, because I've read about what you're doing, but I suspect we need to do so much more. Number 3 is smart governance. More of these breaks, the breaks I talked about. We need fair, flexible rules to guide AI in health, so it stays ethical, safe, and human-led. Kenya's Data Protection Act, the draft National AI Strategy, which was released just the other day, and also even you look at the region, the Africa Union's AI's vision, and WHO also, they have their own guidance, all point to this governance, which must keep pace with the technology to protect rights, put people first. Always asking, how do we ensure that AI is under the control of humans, not machines? But if the humans ourselves do not understand it, how shall we control that? Sometimes you do not need to know everything about AI. You don't need to know how to write code. But being AI literate, it means you're able to offer oversight to AI programs and all that. And then the 4th pillar of our house, remember, is deploying AI in the health sector, is bold innovation ecosystems. By bold innovation, is what I mean is let's back our local health innovators. We have startups, we have students, we have scientists. So African-made AI can solve African problems and create jobs in our communities. This calls for public-private partnerships with tech leaders like Microsoft, IBM, and collaborations with partners like Amref and others. whose sole focus is to offer catalytic support so AI helps unlock human potential from a health perspective. With the foundations in place, we then would have the opportunity to turn the incredible opportunities that AI offers to reality. So let's talk about those opportunities, those use cases that I said. Before we build the bricks that I've talked of, we must also have the use cases in place or the practical applications. I like to think of 7 bold opportunities for AI in the health sector. And to make it easier, I group them into 3 categories, each already taking root in our continent, Africa. The first category is, how do we use AI to provide better care and service delivery? That interaction between the nurse, the clinician, and the patient. How can we use AI? And here, there are 3 types of use cases you can think of. Use cases that help us improve quality, use cases that help us improve access, that last mile access, and use cases that deploy what we call Internet of Things to build health system resilience. And do not worry, I will share these remarks. You can get the entire speech. Let me briefly talk about each. Smarter care quality. AI can raise care quality in every encounter. Think of tools that guide antibiotic choices in TB treatment through genomic sequencing. That's already happening, like antimicrobial AI. So people get the right care the first time. That's precision medicine. AI gives providers new tools for safer, more consistent evidence-based care. Quality. Let's talk about access, reaching the last mile. Perhaps AI's most powerful promise is reaching remote villages. We're already training algorithms to read X-rays and pathology slides where specialists ask us. And us in Masterbit could use an AI diagnostic kit to detect TB on the spot, or X-ray, a digital X-ray, to be sure this is TB and start treatment without any delay. And the third area under the first category of better care service delivery is the Internet of Things. Internet of Things means gadgeting or connecting to the internet. Think of this, connected devices can monitor vaccine fridge temperatures, KEPI, EPI, oxygen plants, PSA plants. We are already piloting a system to monitor oxygen plants. Solar power systems or borehole systems. We are already doing that in AMREF, using connectivity so that you know how the borehole is doing or the 100 boreholes are doing. But this is how the magic happens. Once you have these smart sensors in this medical equipment, when we build machine learning algorithms to run from these sensors, we can then detect risks early and prevent breakdowns. The machine learning algorithms begin to learn and to help you know this borehole is likely to fail in 6 months based on the algorithm that you have built, trained over time. It's not just a sensor that said you're on alert, but you create new intelligence that the human mind would not be able to see or process within a short time. Rather than waiting for the pump to fail, you already get a red signal. This is likely to fail based on what we are learning. That's the first category. The second category is public health. Public health security, global health security, or allow me to call it precision public health. Because once we begin using tools like AI, precision mapping, and all that, we are now going to the field of precision public health. And there are 2 things I would like to highlight here. One is decision intelligence, and the other one is predictive public health. Decision intelligence is where AI can supercharge decision making. Dashboards that can flag outbreaks or drug shortages in real time. AI can automate audits, analyze care cascades, like in the context of HIV, and we need to build more care cascades for diabetes, high blood pressure, and all that, so that we have better control, more differentiated care models, not just for HIV, but for all chronic conditions. You are the leaders to build this. There's no PEP for diabetes, no PEP for money for high blood pressure. But I said, we are elites. How come we use PEPFAR money to build differentiated care caskets for HIV programs, but we are not building differentiated care caskets for diabetes, high blood pressure, and the like? Just because they are not global health security problems, but they are our problem. I'm sure your parents or yourself, you might have, or I might have this. Caskets and support clinicians with the differentiated care plans. Then the other part on precision public health is predictive public health. AI can help us act before a crisis hits. Remember COVID-19, that was used a lot to predict the pathways for the pandemic. Predictive models can show where cholera or malaria might emerge. At AMREF, we are already working to work with others to leverage and build models around cholera tracking using AI. With AI, we can better target mosquito net distribution, nutrition programs, and vaccines. For example, KEMSA, the other day, used AI to target mosquito net distribution, algorithms that would help show exactly where the gaps are, predict gaps, and ensure we do not have imbalanced distribution where there's too much of this in this corner of village and too little of the nets where they're needed the most. When you're trying to do that manually, you would have to have almost a whole team working on such details. And Africa CDC used AI a lot during the COVID pandemic. The third category is important. It's human capital, empowerment, and jobs. And here, I would like to talk about two things: frontline worker empowerment and inclusive job creation. Listen carefully. AI should support, not replace you and me or health workers. But if you are not careful, over time, that could start happening. Let nobody lie to you that that could not happen. You know, some people will come and tell you AI cannot replace you. 10 years from today, we'll have AI algorithms that will be more accurate in a lot of reasoning, clinical reasoning, than 95% of doctors like me. What's our role during that time? The secret is to become AI literate and know how to work with AI so that you're working with AI, not wondering what is this black box being called AI. You know, there are apps that guide CHWs on treatment and referral, or connect them with remote specialists, smartphones with offline AI to help monitor chronic conditions and refer patients and all that. So for that, I encourage us, please let's become AI literate so that, like me, I'm now AI literate. So I think I'm old, I'm not young. I keep asking Dr. B how she keeps so young because she looks like 10 years younger than me, but I suspect we are age mates. But I have decided I am not going to be left behind. I want to be in the leading edge of AI in Africa. I encourage you. What is stopping you from doing the same? Is it fear? Isn't KMTC ready to provide the platform to take away those fears? Because what is not known sometimes scares us. And the final one, in terms of the human capital empowerment and jobs, is inclusive job creation. AI will change how we work. It's changing how we work and open up new jobs. Kenya's startups are hiring pharmacists and engineers to build AI tools. Are you ready to be hired for such jobs? With support from programs like Google Health AI Accelerator, young Africans are building the future. And KMTC must lead by building an AI and machine learning laboratory where nurses, clinical officers, lab techs, and radiologists can learn AI literacy, and many will launch careers from it. Do we have at KMTC an AI and machine learning laboratory? Do we have? Yes. If there's one thing that I would want to come from this conference, is getting that in KMTC. It doesn't take a lot. Don't overplan. Don't build bricks before. Build the car first, then give it bricks. These 7 opportunities across care, public health, and workforce and jobs are not science fiction. They are already unfolding. And what I would like to encourage us is AI won't replace you. It won't replace nurses or clinicians, but it will help them act faster, smarter, and more humanely. But I must add, those who are AI literate. With even modest adoption, McKinsey estimates that AI tools can boost health efficiency in Africa by up to 15%. But let us proceed with our eyes open. The same way you drive your car with your eyes open. With opportunity comes risk. Maybe these are the real breaks, not the foundations. Wise readers must confront 3 types of risk that AI poses. The first one is trust. The second one is fairness. And the third one is the fragility of the foundations of AI. In terms of trust, AI can feel like a black box to both patients and providers. You know, black box. We must ensure AI is explainable, that we understand AI models. Whenever you look at AI data scientists presenting models and you don't understand what they are saying, there are 2 possibilities. You are AI illiterate or data illiterate, or the data scientist or AI data scientist does not know how to do things in ways that are explainable. Let us make sure that our journey in AI is not jargon, but it's based on explainability. Tools must show their reasoning, and clinicians must be trained to interpret them. WHO reminds us that trust comes from transparency. That means audit trails for all AI and machine learning algorithms, version tracking, and clarity on what data powers, which data powers the recommendations or insights that come from AI. So that I want you to see, and that way, see AI as a colleague, not an oracle or a mysterious figure. You have heard of agentic AI agents. A lot of companies now are beginning to ask what parts of their jobs can be replaced by AI agents. And that's already happening. So see AI as your agent. How do you build AI to be your agent? Beyond the chat GPT that you are using. I've given you 7 examples. The second is fairness. Fairness failures, or you can call it equity. Africa's diversity must be reflected in AI systems. Algorithms trained only on foreign data may fail African or Kenyan patients. We must build AI with data from our communities, urban, rural, young and old. We must also design for inclusion apps that run offline, like the X-ray machines that do run offline, support local languages, Kiswahili, and reach basic phones, because it's not always that people have smartphones. So equity must be built in from the start. And we have seen that, like this one, I'll not mention the owners, but I've seen like one genomic data app solution for genomics and AI to optimize antibiotic use in the environment antimicrobial resistance. 98% of the data is based on Europe and North America, the North, and 2% in Africa. So when we realize that inequality, then it means we're being left behind. But why is that happening? Most likely it's because we are not literate. We are not AI literate. We are not doing our part to drive adoption of these novel technologies in our work, in our clinics, in our training. The third one is the fragile foundations. Yes, AI will replace some jobs. Let nobody lie to you that. Let nobody give you a good feel that AI will not replace jobs. That's already happening. Please. But we must plan ahead. Reskill workers. Protect patient data. That's very important. The Data Protection Act, ensuring we go through ethical review committees and all that, and enforce strong governance. As someone has said, AI won't fail Africa because of bad code, because of bad governance, when we have not thought about the breaks we need in place. So let's ensure the laws that we have, the strategies that we have, we understand them, we are following them. As we train, let's teach our students on the breaks, the governance foundations for good AI. But as I said, if you want to train on governance and we don't have the vehicle, the applications, then we are losing it big time. Now more than ever, our actions must be guided by values, African values. We must co-create AI projects with communities, listen to patients, and measure success in lives improved, not the lines of code. How do we humanize AI? That's one of my biggest challenges right now, so that you don't see AI as a toy, a cool thing in a corner, but as an agent that is helping you give better care. As I close, let me speak directly to KMTC leadership here today, and all of us in Kenya. You have an extraordinary opportunity. Kenya's leaders have prioritized AI and digital health through the Digital Economy Master Plan, the new AI strategy recently approved, and other policy frameworks that do exist. I believe we have adequate policy frameworks. We could build more, but I think we have enough. KMTC is already moving forward. I did due diligence on KMTC, and I saw you already have a new partnership with Edith Cowan University on this. So you're already making a step in that direction. Now my challenge to us is, let us take the next steps. Number one is integrate AI-related ethics, and that whole idea of digital literacy into every health curriculum. That's number one. Number two, let's work to have every nurse and clinician or technologist graduating with basic AI fluency or literacy. It's like a language. Imagine if you are in KMTC and you don't know how to use the internet or email. Now, I want you to imagine that AI machine learning is getting to that stage that we need to build that. Whatever your age is, I came here to talk about this at my age so that you don't blame your age. In fact, allow me to say that I've found older people are catching up on AI than younger people, and I've not understood why. Number three, build use cases. Do not allow AI literacy to just stop there. Keep asking, what problems are we having in these clinics? Diabetes, high blood pressure, and all that. And what use cases can we build to drive care quality, care access, and all that? It's easier than you think. Once you have the data, it's easier than you think to understand the problems the patient face at group level, to analyze data, to build a machine learning algorithms, train it, to fit a model. Once you see it fits well, to use it now to help you predict what will happen to these other patients and guide you to offer better care, and then to integrate that into your health system, integrate that into your data system. Let's build use cases and teach people how to build them and interpret them. And then, number four, let us partner with the right people. Edith Cowan is a great, great start. Please do know that in the medical sector, sometimes we suffer because we're in a corner, especially doctors and nurses sometimes, we're in a corner with ourselves. We need to think of sectors in technology. I said IBM, Microsoft, Ambref, and others. And there are several digital startups like Gigi and others. How are we collaborating with them so that they can, for example, provide internship opportunities for our students? Because again, this can be so theoretical until someone works with the people deploying solutions. It's about experimentation and figuring out what works. So once again, I challenge KMTC. I challenge you, our KMTC, across the country to become Kenya's national hub for AI in health training. Offer workshops, launch certification courses, imagine modules like AI for maternal health or AI-powered public health. I also encourage us to partner with innovators to test new tools, work with incubators, as researchers have said, and let our hospitals where you work be living labs for AI. If it's not you doing it, then ask yourself, who is doing it? Allow me to say this. as I learned about AI, I learned one thing. Artificial intelligence is not about just data. It's about understanding data, computer science, but bringing domain expertise. You are domain experts in health. When you bring those two together, that's when magic happens. Sometimes we trust this work with data scientists who never stepped in a nursing school or medical school. And sometimes, as we do that, great things happen. But sometimes it's also garbage in, garbage out, because there's no domain expertise. Do you see what I mean? It only works when, because you understand the problem of the patient. You see a patient and in the whole day you are wondering, how could I help that patient better? How come we could not predict that? Yet with big data, data about patients, 1,000 patients, 2,000 patients, it's possible to have those things more visible to you. Data scientists just who has never seen patients, it will take some time before they understand what problem you're trying to solve. That's why I encourage us. Please, let us combine domain expertise, medical health, laboratory, with AI, machine learning, data science, and all that. And then the magic will start happening over time. So as I come to the end, friends, the future is not yet written fully, it's being written. Technology alone won't save us, but with the right investments in infrastructure, people, governance, and innovation, we can move forward faster. Let us design AI with African values, build it on African foundations, you and me foundations, and deploy it for African people, for you and me. KMTC, policymakers, clinicians, we all have our roles. The question is, shall we play those roles? Because we need to remember that behind every line of AI code or algorithm, there needs to be a human life, a life of a client, potential client, or a nurse who understands why we are doing all this. I believe with courage, with wisdom, courage because sometimes it inspires fear. We'll see a day when here in Kenya, we are able to fully deploy these capabilities. We have the plans, we have the passion. Shall we turn those into action, a step at a time? Thank you.
Wow. Thank you so much. I was looking around and then it's like the room was coming to standstill. Being told, bring your domain. Thank you so much, sir. Yes, you will share the speech with Madam B. And I need to let you know, you're not alone. Your audience, we have already taken that. Personally, I'm using AutoCode data for maternal mortality using natural processing language. So we are there, yes, in Kitui County. So we are there, and that's artificial intelligence. So unaona inaenda na wazee, so vijana mko wapi? Yes, I'm doing that, and I'm impressed. And so I took my domain, medical domain, to Kitui County, and I can map the causes of maternal mortalities efficiently. Most mortalities go unreported. Those are the things Dr. was reporting here. A lot of things are happening, they go unreported. My paper will be out sooner than you expect. Yes, so I think we need to see another face. I have an able co-chair here. This is how we are going to do it. I'll seek your permission, Madam B, kindly, Dr. B. Now that you went to school together, I never went to school with him. I would like you probably, if you have time, sir, maybe we can have your questions, comments. So we finish that. And then audience, we have something for you. After that, we have 2 more presentations so that we let him answer his questions and then he keeps us on board. And that session will be driven by my co-chair, Dr. Peris Kibet. But before Kibet takes over, then mtu anakaanga na mali yake amewekelea kabla ulizwe maswali. So I would want you help me gift your schoolmate, gift him something. You know, we must be having something for him.
I'm assuming. Na kama hakuna mniambie mimi nitafute mimi mwenyewe. Na ninaiona. And as I go to sit, Daktari, as I go to sit, I will look for you at personal level, because the things you're talking here, that is the shift I've taken. Thank you so much, sir. Bless you, sir. Yes.
Both are yours.
A good classmate.
Thank you. Thank you very much, Dr. Dirango. You have lived to the expectations. I had no doubt that you are going to give that kind of presentation. I think for the audience, this is the second time it has been reminded to us. We had the CC. He talked about the need for passion, for care, the need for us to collect data from where we come from. We have been told you need your domain and the AI, and you need the African data, and that will come from us, each one here, from the students to the staff to all of us. That's a challenge. KMTC, we've been challenged. The issue of building a hub for AI. We are in almost every part of this country. Can we provide that opportunity for Kenyans? Can we be the source of that data that is going to inform this particular something that WHO is speaking? Because we gave the data for Africans, not for the people from Europe. Thank you. I don't want to take a lot of time. Dr. Kibet, go ahead.
Thank you very much. Thank you, Dr. Dirango. We are so proud of you and also your organization. Every time we do something, we say, how about AMREF? So you've been our benchmark, and you have also introduced us, even other benchmark people, MIT now, and also Edith Cohen, that's what I got to know, and many others. So thank you very much. This has come at the right time, really right time, artificial intelligence. I have taken notes, sir, because AMREF is one of those institutions that I go to learn my basic computer packages from AMREF. And every time I do my CV, I quote AMREF. So I've never gotten any other, good quality artificial intelligence like the one I got at AMREF. I think I'm one of those pioneers in 2001. I don't know where you were around that time. I don't think you are also there. So thank you very much. At this point in time, we really want to say thank you very much for that presentation. Your classmate is my mentor, therefore you are also my mentor. We want to get the questions and answers, after which we will have some short presentations. So questions and answers at this point in time. So if you have a question, please let me have. I can be assisted by the Secretariat. Thank you. And keep your questions short.
Thank you, Dr. I'm Meshak. Dr. I think I'm one of the beneficiaries of AMREF International University. I'm taking there my second master's in health system management. And I think AMREF is one of the best. I went to KU, I went to what I'm getting from AMREF International University is very unique. They each, the quality. Now, Dr. back to my question, my concern. How can AMREF and the KMTC collaborate in terms of funding opportunities? Like for my case, I'm interested in getting an opportunity, write something, and that's what I do. On a weekly basis, I must write a proposal so that I get some funding for a particular research. For instance, at the moment, I have a proposal on referral systems at level 4 hospital in Kisumu County. And I'm looking for funding. I think, Dr. now that you are here and the KMTC is here, these are the big lions.
Yeah, keep your question short, kindly.
Thank you.
Yeah. So the question is, how can KMTC collaborate with AMREF? Let's just ask like that so that we can have as many.
Yes, thank you, Dr. for that presentation. Francis is my name. Recently, I just listened to one artist, a voiceover artist in the UK, who had sold her rights to her voice in the year, I think it was 2020, before the advent of AI. Then I think the other day she was told that your voice is being used in every train in the UK. And she was very shocked. When she went there, she checked her contract and she saw that the company is covered by the contract. So the question is, when it comes to mitigating our risks, is it a lost cause because they say AI has to copy things that have already been either written, drawn, or published? Is it a lost cause, or do we have a chance to improve our IP rights so that they are catered for even in the age of AI? Thank you.
Thank you. Thank you. Let's have the next one. I think it will be almost the last.
Thank you so much. My question is with regards to the lack of...
Please say your name, please.
Oh, I'm Areva. My question is with the regards to lack of personal touch when it comes to AI. It may not be able to replicate the warmth and the empathy that comes with a real human being. Also, as we are now, are there any guidelines for AI use, especially when it comes to critical decisions, for instance, life and death decisions? Do we have any ethical guidelines for such?
Thank you very much. I think we'll allow Prof. Daktari to answer those three questions. Thank you, sir, if you can answer. The last question is about the personal touch, that AI does not have that relationship, and that AI sometimes also, we might not be, I don't know if we have ethical guidelines. I hope I got it. Yes, thank you.
So maybe come here. It's okay. Let's start here. Yeah, so once again, thank you for the questions and thank you for the affirmations. Meshach, on your question on your reflections on potential collaboration between AMREF and the KMTC, it's a yes. Let us exchange contacts. I'll give you my card and we have already exchanged contacts. We challenge you to build a data science laboratory. I believe you have it as a space, or I mean, not a physical space, but you have the idea. We are doing the same in AMREF, and then we collaborate. Remember, AMREF, we are catalytic. We are catalysts. We don't have clinics. You're the ones who run those clinics across the country. So we are happy as we do that to see KMTC as a core partner, as a core member of the partnership or coalition to make sure that the AI journey really goes to the front lines, really connects with the grassroots. So we are happy to even explore an MOU around that. We are happy to.
Wow, MOU it is.
Yeah.
Yes, yes.
Happy to do that.
Wow, that's nice.
Then the second issue is on rights. The whole issue of intellectual property rights for AI, they are complex because even those people who have developed like the ChatGPTs and the like, I think the owners of the photos that were used to train them have come up to question and ask who gave them the right to train using their images. And these companies have been doing a lot of times behind the scenes settlements, negotiations with the owners of the IP rights, just to make sure that they do not have catastrophic legal suits that could stop their companies and all that. But to your question, Francis, and this is the same thing I'm telling everyone in this field, and that's why I came here. Let's assume that we have an AI project. What's your name, sir? Buduka. That you have a project and you're going to try a data science solution or an AI machine learning algorithm to help us predict maternal outcomes and help improve care. The question is, do you allow other people to come and do the study and then publish, or do you make sure you are the primary investigator in that study and that it goes through ethical review, if we have one, or KMRI, and as you publish, you're not seeing what was done in the project, but you're at the center of it, working with other co-investigators, so that even if they are data scientists or machine learning algorithm experts, they are investigators with you. You own the space. That's the challenge I'm giving. That way, as solutions get out in the market, you're not, by the way, you're not an observer, but you're this. As you do that, two things happen. You forever own that. I mean, you can claim that, and it helps you grow your career. Number two is you learn out of it. By the time you sit with these data people, you learn how to test models, figure out how to integrate them so that they are not a toy, a nice toy in a corner, but integrate them into a system. Like right now, the MPDSR data in Kenya, I understand it's all in paper. We really need that digitized, and then we need to begin learning out of it. Yeah, so as we do that, where are you? I want you more and more principal investigators here.
Wow.
But that will not happen if we do not have that lab to build the courage and the expertise. Don't wait to be an expert. Please believe and then learn as you do it.
Thank you.
You know the problem. Then the third area is human warmth and the ethics. Ethics, I think we already talked about it. First of all, every work we do, these models we develop, they need to pass through ethical review. We need to make sure they are aligned with the Data Protection Commission and all that. And the issue of warmth, here is the way I would put it. It's very important to build AI in ways that it's an agent for you as a clinician, as a nurse, not something that patients and all that use. It's called agentic AI. So all these things we build, how do you see them as your assistants to guide you make, for example, if you are doing out there with a machine learning enabled chest X-ray, portable chest X-ray, and you do that X-ray, clearly you're using that as a tool. It helps you refine your decision. It helps you have a higher level of confidence interval that the decision you're making is accurate. The quality you're providing is more accurate. So that's the way I would want us to look at it. But again, if we are not AI literate, then we are likely to end up sort of over delegating things to AI, and then interpretation becomes a problem. That's number one. Number two is ensuring that as we treat these AI solutions, that we have our data, Africa, Kenya's data, that's what we're using to train AI solutions. Because if we don't do that, and the way AI is being built, whether it's Gemini or Perplexity or OpenAI or Grok, all these platforms, it's possible to use our data to build APIs that connect to those AI platforms, and then they learn from our data, but they use that cloud-based engine. So that's really, again, if you're looking for guidance from it, you are getting, if you're trying to learn about certain conditions and all that, it's called fine-tuning. You have a model that's fine-tuned to our context. But how shall that happen if we are not literate? It's us to fine-tune models, to use the AI compute capabilities to build models that are, we don't have to build ChatGPT from the beginning. We have the platforms. All we need is to ask how to build the right models to connect those compute engines, and then we're able to have better assistance, clinical assistance as we make our own clinical decisions. Yeah, thank you.
Thank you very much. A round of applause for our Daktari. Thank you very much. Okay, fine. Let's read an online viewer's question. Great presentation, Dr. Ndirangu. Where do we get data to train and test AI models so that we get unbiased data from Africa? Great presentation. Where do we get the data to train and test AI models so we get unbiased data from Africa?
Thank you very much. And I think there's a question Mudhuka can also answer, because I believe you're training a model using NLP, natural language processing, using existing data. Would you want to say how you're already doing it?
I can just mention. And actually, he answered that in his last statement when he said, Kenya, Africa, we need to utilize the available data that we have. There is data in a repository. However, when you talk of data protection, the data that you want to use for training your AI, it will depend, and it has to go through ethical process. You not just go get data like you want to train AI, unless if it is validated what you want to use it for. So it goes back to a question which came from someone there about ethical principles and everything. However, now, let me get another version from him. That is what I can say about that. Am I right?
Yes, you are. It's about existing data. My friends and the colleague who asked this from online, at the moment, the problem is not our lack of data. It's our either inability or unwillingness or lack of awareness of what we can do with that data. Like Mudhuka has said, think of the electronic medical records that run across the various hospitals where we work and the data that is contained in that. Think about the electronic community health information system, where we have already seen, for example, in the last 1 year, community health promoters have referred more than 1 million clients to the clinics you manage across the country, diabetes and high blood pressure combined. And those are people who, I believe, some are coming, you enter them into EMRs. We don't know whether they are getting into chronic care model, the way HIV programs works. So think about that data. Think about all the TB data that we have, maternal health data, antenatal clinic data that we have, that has features that, like when a mother comes, where they come from, their age, of course, gender is female there, their age, their parity, and there are several other features about them. Now, that is the data that is, remember, AI and machine learning is not new. It's simply a machine doing what we have always done, which is statistical and building a model like using logistic regression, linear regression, classification, and the like, decision rules and the like. But because the machine is able to do that, you see, if you did MPH, you know that you maybe had to use SPSS. You remember the nights you spent trying to run SPSS models, and then you test it and you realize it's only fitting the R, is it R squared? It's only 60% or whatever, however you define it. You remember that struggle. The machine is able to do that within just a couple of minutes if you have good compute power. You are able to assess the fit of the model, and then you are able to test the model. Here's what you do, just for you to show you how easy it is, just 1 minute. If, for example, you have 2,000 cases of data, women, TB patients, or that, you can use 70 or 80% of that, like 1,400, to build the model using the machine. And a lot of times it will be a logistic regression model because you want to classify, you want to know the risk profiles and all that, but the machine is doing it. And so that is the training data, the 1,400. The 600 is the test data. Then you test your model with the 600 to see how well does it fit on data it had not seen. And once you see your model, if, for example, you test your model using 1,400 and you see it is giving you better risk prediction for these clients and it can improve your clinical decision making based on the features you see, then, and you see it fitting well, 80%, depending on the measures you use, then you can ask, then can we try this data in 1 or 2 or 3 clinics with clinicians and integrated into the EMR of that clinic. And all of a sudden, as the client, the nurses, patients, they're able to see the risk profiling and improve clinical decision making. I don't know whether that makes it clear. That's how we say it is. It's not a lack of data, it's our ability to experiment. Remember, it's experimenting. Sometimes you try to build these models, you realize there's no model. So you ask yourself, how come our understanding of the situation is not deep enough to enable us build a model out of this? It means we need to learn more, do more anthropological studies to understand what is causing the problems and all that. So to sum it up, machine learning AI is automating the statistics we learned, making it much faster and making it easy to deploy into systems. Remember, when you build an SPSS model, you could not deploy it into an EMR, but a machine learning algorithm, you could deploy it into the electronic community health information systems and generate dashboard. We are working on such an initiative. Yeah, that's what it means.
Thank you very much, Dr. We really appreciate you. Every time you're welcome to KMTC. Remember, we work closely. Whatever you do, we also do. One of these days, you're welcome. Thank you very much. So I want us to move very fast because of time. We have only 3 presentations, and each of them is taking only 10 minutes. So I want you to keep the questions. The first presenter is none other than my co-presenter. By the way, I didn't introduce myself. I'm Dr. Kibet. I'm also a principal of a college, Karen, KMTC. I am passionate about research. So I want to call my presenter or co-chair, who has been working with me for many years, very many years. And we are very grateful for Dr. Muthoka, who has a presentation today on incidents and predictors of HIV-associated iris. And he will give you a lot of information on this paper. Karibu sana. I will not introduce you more because already people are saying you're very passionate about AI. He's also a lecturer at KMTC here in Nairobi. And we've been working together in ethics committee, and he's part of the official of this forum. So thank you very much. Karibu, I will give you only 3 minutes.
In fact, those are enough. You had given me 10. I don't want to take 10 minutes. Maybe you can, Francis, you can just share you can load, but basically, I need us to look at a scenario whereby you institute ARVs to a pregnant woman who has never used them before. See a pregnant woman who has never used them before, and then you develop some reactions. You might say these are for HIV, or are they for ARVs? No one knows, or probably there are studies that have been published. Just go straight to, just move to the next. Okay, let me just, yes. HIV iris. Iris is immune reconstitution syndrome. It is a kind of reaction which occurs like an overlap when when the immune system is responding, and it could either be worsening or a new flare up. So that is something that has never been done, and I wanted to look at that. But more so, I did not want to look at that because it is there in public domain. I needed to ascertain after how long does it occur? The same concept that Dr. was mentioning here. If you are on ARVs, then how long does it take you before you become a case of immune reconstitution syndrome when you're pregnant? No, basically, because I'm taking 4 minutes only, that time, we call that survival time to event. We used, move to next. We used study participants here at KNH and Bagadi Hospital. Of course, we had done piloting at MTRH, and the population was between 20 to 49. We had done all the clinical parameters, and then the analysis and outcomes. We tried to ascertain now the incidence rate of that immune reconstitution syndrome. And then we did multivariate Cox regression analysis. Cox regression analysis is whereby you use data which is not controlled, so that you can analyze an array of variables to know, even if I'm developing immune reconstitution syndrome after 2 days post-ART, what could be other factors which are contributing to that? Next. Now, this is the gist of it. The incidence, we had a pool of 532 at naive pregnant women. That means they had not started at when they went to the clinic. It was their first time. And their cases that developed that was 25%. So we can say confidently that 25% of pregnant women who are ART naive would experience that syndrome. And majorly, unmasking was at 73%. So we have learned something new today. Just don't talk just about immune reconstitution syndrome, but now unmasking. That is the main giant. You can see paradoxical has taken now the other part. When you look at that graph there, it shows you risky progression. When you give this woman ART, after how long do they start experiencing clinical syndromes associated with the iris? And it was very high. You can see at 3.6, that is hazard risk. Move next. Now, the graph that you're seeing there, when you take a woman to a clinic, we usually do what we call baseline modeling for the characteristics. And you can see we are talking about maternal basal metabolic index. And you can see those who are having a higher weight, those who are overweight and above, would actually have iris much easier as those who did not. Move to the next. Still HIV staging, you can see that at early stage, stage 1, because the woman had not experienced that clinical syndrome, iris would come out very fast, and also towards stage 4, because that is where now we are having the cases of delayed HIV reactions. What am I saying is clinical HIV stages also would predict how fast or how soon iris would develop. Next. CD4 and viral load trends. At baseline, when the CD4 count is very low and the viral load is very high, that is now the key predictor for iris in terms of survival time after they have been given the medication when they did not have it. That's why you're seeing CD4 count over 500. That curve there demonstrates different timings based on the CD4 count and HIV viral load. Next. Now, this is what we call decision tree analysis, the concept that Dr. mentioned here. Decision tree analysis is one partially a very low one in terms of artificial intelligence, which can pull and tell you with precision. This is what most people or most researchers use when you're developing what we call a policy brief. Having done all that jargon, I've given you a lot of senseless jargon, but the gist of this final conclusion is lying here. Baseline CD4 count was the strongest iris predictor if it was low. Now, unmasking iris at 85% when CD4 count was below 500. Paradoxical iris, only 15. Conclusion there is unmasking iris, which was not seen there before, becomes the main culprit. Move next. Now, having said all that, when you compare the existing research that has been done, most of them were talking about viral loads and HIV viral loads, CD4 count. However, to show the precision of these findings, at least we could see some studies were trying to match what is existing. Last slide, please. If it is not there, that's the end. Yes. Conclusions, unmasking iris, as I said, then HIV stage 1 and 4, their main culprits. MBI, maternal basal metabolic index, between 25 to 29, that is overweight towards obesity, is another issue. Key insight, early and late HIV stages plus low CD4 count are the key drivers for unmasking. These I'm talking to the clinicians, nurses, and gynecologists, especially nurses and clinicians. Sometimes when you give a woman this medication, it's not just about the HIV effects or the ARVs. There is an interface between the two, and it is not just the interface, it is unmasking outcome. Last slide, I was appreciating the ones who are there. Mary Medical College, KMTC, Kenyatta National Hospital, and MTRH. Mpigieni makofi. Sandra.
You've eaten my 1 minute.
I went for?
Yes.
Sorry.
Thank you very much, Dr. Muthok. You're such a passionate person, especially when it comes to AI and also research in this area. Now, I want us to go to the next one. Please keep your questions. The next person who is going to be presenting is Grace Achieng, and then followed by the last one, which is Munyoki Nyamai. Please, Grace Achieng Otieno. Grace Achieng Otieno. Okay, if it's not there, let's have Nyamai. Dr. Nyamai, want to imagine?
Dr. Nyamai, are you in the house?
He was here. Grace? Yeah, if Grace is not there and Nyamai is not there, let's have the questions then. Yeah. If they have recorded, let's have the recorded.
You're on the list.
He's talking about a point prevalent survey of antimicrobial use at Kisumu County Referral Hospital. That is Grace Atieno. And then Dr. Nyamai is a research mentorship program for staff, the experience of Kenya Medical Training College. So it is well. So let's have the questions.
Sorry, Chair. In the interest of studentship, maybe 7 minutes.
Oh.
Yes.
Okay.
So that she has.
If you have the slides.
She's taking the opportunity because we have missed 2 presenters. Now she said, why not? This is a go-getter. Come get it. Because the others are not there. Come get it.
We are giving her 1 minute to ensure that the slides are there. So you can come and introduce yourself as you give out the slides. Yes.
Are your slides available?
So
the technical team, they are ready? Okay, you can come take the podium, please.
You okay? Okay.
Yes.
I'll give you 7 minutes.
All protocols observed. Good afternoon.
Good afternoon.
My name is Rachel Muli from Imenti campus. I'm a third-year student, and I'm honored to present my research project entitled Psychosocial Effects of Gender-Based Violence Against Children aged 13 to 17 years in Mathare Sub-County, Nairobi County. As they prepare the slides, I'd like to speak about the reason why I chose my topic and why I chose to specify it in Mathare Sub-County. So I focused on this topic because children are often the silent victims of violence, especially in informal settlements like Mathare Sub-County. Despite growing awareness of GBV, there is limited research on the psychosocial effects, particularly in low-income settings. So Mathare is one of the largest and densely populated informal settlements in Nairobi, characterized by overcrowding and poverty and unequal social services. And this predisposes the people in that community to gender-based violence and domestic violence.
The slides, the PPT for the presenter.
So, according to WHO, GBV is violence against children or people under the age of 18 years old, whether perpetrated by family or relatives or even strangers, and also by romantic partners. The problem statement. Past studies have focused on women and girls in general, and have also focused on the general causes of GBV, but none have focused on the psychosocial effects of gender-based violence against children, specifically children in Mathare sub-county. The inclusion of male criteria in my research ensures that there's a comprehensive view on GBV, that we don't just focus on female, because majority of the time people just assume that GBV can occur to female but not male. But in this instance, I want to show all of you that GBV can happen to either male or female. It does not matter. That both male and female can be victims and perpetrators. Yeah, the methodology. I used stratified random sampling. Very nice. Methodology. I used the cross-sectional design. The sample size of the children included 50, but I was able to get responses from only 40 children because of the time constraints, and this concluded to 80%. As we all know, in research, as long as your research has acquired response from 70% and above, the data is enough. I used stratified random sampling to collect data from the various stratas. I used questionnaires as a tool and used survey as a method, and also used interviews as a method and interview guide as a tool. I used Microsoft Excel to analyze qualitative data and quantitative data, and use thematic analysis to identify, to analyze qualitative data. I'm sorry for that. I ensured that I followed ethical considerations. I obtained informed consent from the parents and as informed assent from the children, because children who are under the age of 18 cannot give consent. I ensured confidentiality for those who are participating, anonymity for the identity of the children, and psychological support, because some children were not able to just answer the questions without recollecting the pain of the trauma. Yeah. As you can see, these are the psychological effects which are answering my first objective, which were the psychological effects of gender-based violence against children aged 13 to 17 in Mathare sub-county, Nairobi County. The leading psychological effects were low self-esteem and feelings of unsafety. This is because after a child experiences GBV, of course, you don't expect them to just go to normal. And the GBV impacts their emotions. Even after the GBV has already occurred and they are trying to heal, it still impacts their emotions from day to day. It was followed by fear, anger, fear, trust issues, anger, and then shame was the last one. Next slide. The social effects. The social effect, the leading one was withdrawal. They withdrew from social situations because of fear of stigma and discrimination. Difficulty forming relationships because of fear of being judged, because if someone finds out you experience GBV, what would they think? And academic decline because they lacked concentration after what had happened to them. Next. Support systems, 57.5% of the children acknowledge that they had received GBV education, either from school, from their peers, or from relatives. Yeah. 35% felt supported by adults, while only, this is very painful, only 10% accessed professional support. I mean, like, you see, GBV makes a person feel stigmatized and discriminated. So they did not want to follow up and go and get support because of fear of being judged and being isolated by other people. And this shows that as medical professions, we should feel the pain of these children and also include community-based counseling and also school-based counseling in order to reach them, because most of them won't be able to access healthcare facilities and get the counseling sessions they need. Results, these are qualitative data analysis. This is how the children responded when I asked them what GBV was. Someone said it is when someone is sexually abused because of their gender. It is when someone is treated badly because they are a boy or a girl. It is when a boy hits or insults a girl thinking it's okay because they are girls. Next slide. Conclusions and recommendations. My conclusion was GBV has a very significant psychosocial impact on children in Madare, and this is worsened by the limited support systems. By psychosocial, I mean both psychological, mental, and social impacts on the children. Recommendation, multi-sectoral response. This is whereby we all cooperate. You involve the school, the health professionals, the legal system, so that they may work together and help these children. Improve mental health services. You know, not everyone is able to go to the hospital to reach mental health services, especially those in such communities as Madare, because it's a slum and marginalized area. So it's better if the health professionals form community-based counseling services and interventions in order to reach various numbers of people. School-based counseling. Students spend majority of their time in school, like right now, as we're in school, and it will be better if the counseling is taken to them and is involved in their school daily lives, instead of waiting for it to happen at home, whereby we know students spend most of their times in school. Community outreach programs. This is very related to the multi-sectoral response, where we involve both the community, the medical professionals, the legal system, and we do community outreaches, whereby we reach people in the community, but instead of waiting for them to come to the hospital, because that is impossible. Not impossible, but difficult. Policy reinforcement. This is whereby we ensure that policies that are formulated are being implemented. The problem in Kenya is not that there's no policies. There's many policies that are against this, actually, against GBV, like the Sexual Offense Act and the Children's Act. They focus on this, but the problem is when it comes to implementation. And that is why my research wants to create awareness and help in reinforcing the policies. As I wind up, let me leave you with this. Children don't just need services, they need to feel seen, heard, and safe. And as a society, we owe them more than just survival, we owe them healing. To me, this research was more than just an academic project. It is a call to action and to create a safe space for children. Thank you.
Wow. Thank you very much. Our daughter from Imenti. Please clap the more until she sits down. Wow. It reminded me when I was a student, the first research presentation I did is when I was in third year, and it was in Cambridge. And it was an international program. And I was presenting on the Maasai community, the prevalence of dental caries. So I'm so proud. I want to partner with you, daughter. Will you mind if you can work with me so that we can even, if possible, we publish your work? Modoka, tuko hapo? We can help her, isn't it? Yeah, thank you very much. There are questions which have been given. Matthew, we are going to be reading those questions. I think. Yes, I think it is best when you ask those questions. Please help me, Matthew, get the questions here.
So we have questions and we've given to the individuals. So maybe I can just present the microphone and they can go ahead, read the question and answer. Tutaanza na Wangari.
Thank you for the questions. The first question is saying, why 9 ANC visit? During that time we were doing that project, we were trying to advocate for the more number of ANC visits someone can get. So it is not because they had any complication or what. No, it's because that facility was being piloted to see whatever we can do with male partner participation, and whatever went forward after the first phase of the project is right now we are trying to ensure that we can have male partner participation during birth. So right now it's not ANC again, it's during birth. The other question is what really discouraged men from participation? And when we did the focus group discussion, the men were saying it is because we don't know we are allowed to be there, and the society has just created a norm that we are not supposed to be there. So they lacked the information that they should be there. The other thing is, apart from health education, what can we bring into policy making? And apart from health education is ensuring that the healthcare system provide a nice environment where men feel comfortable, feel appreciated, so that they can be there. The last one, did women appreciate men being there with them during antenatal care visit? And the question was 50-50. There were women who appreciated the men being there basically because it was maybe more of a support system for them, while others felt like it's been their business is being kuna watu wanaingia kwa business yao. But after the entire research and trying to educate them, I think Kangundo right now in Machakos County as a whole is on another different level. And when you attend their antenatal care, you'll see a different perspective because men are now part of the project and are part of the program and part of the story. Yeah, thank you.
Thank you very much. So let's give the mic to the next person. Thank you very much.
I saw Wangari was straining to look at us, so I think this is better. Let's begin with George.
1 minute.
Yes, thank you so much for the questions raised. Which aid method is applicable in the facility where you conduct the study? Could it be one of the confounding factor linked to update? Thank you for this. The aid method used is laboratory test. We test for DNA, PCR at ages of 6 weeks and 6 months. Thereafter, at 18 months, the samples are taken, then we send them to Walter Reed. That is where we get the results. Walter Reed Lab in Kericho. DBS is done for those who are at 18 months. The sample is taken, then transported, and this is done by DBS, dried blood spots for infants. How did you recruit the infants? That was done through inclusion criteria. And my inclusion criteria stated that the consenting HIV positive mothers and HAEs between less than from 6 weeks to 5 years were selected or were possible for the findings or for the study. Factors hindering HAE, we have turnaround time, the time this test or the results take before the results are back. Another factor that can hinder is the knowledge, information. Maybe the information has never reached many people. So mothers might also decide not to come to clinic or the postnatal clinic. And this might also be a necessitating factor that might hinder HAE. I think those are the...
Thank you. Thank you very
so
much.
much.
Let's clap for him. Yes, take it up, brother.
Thank you.
2 minutes.
The first question, what were the confounding variables? And how did you take control of interchanging variables? Now, in this study, we had a discussion before during the drafting of this study, we foresaw what could be the possible confounding factors. For instance, no blood donated that was enrolled into this study without screening for malaria. That's one of the conditions. Because if you get positive malaria, it could affect hematological and biochemical changes. Another factor that we looked at the history of drug use. Will you be using any antibiotic that is likely or has possible effect on the parameter? And also we are focusing on what we call hemolysis. Any sign of hemolysis, that donor blood was excluded as we move. Remember in this study, once you donate blood, we have to go with that blood from day 0 to day 28. Any sign of hemolysis, exclude. And again, the issue of TTI, transmission transmissible infection. other conditions like hepatitis B, HIV, any condition that could alter the results, we factored in and we ensure that we are there to the inclusion and exclusion criteria. I think this one, we are Manita Daktari, Missy Daktari Bado. Then I also have another question here. Thank you for your presentation. If sickle cell trait donor blood is transfused to a normal patient, how will it affect the recipient? At this stage, this is a preliminary research. Now, I'm working on something. I want to do what you call, how do we extract the gene using the CRISPR-Cas technology? Then what we do, we infuse this gene externally, that's in test tube. Then can you transfuse or transfer this gene or what you call a mutated form of the RS3340 using CRISPR-Cas technology? Then we allow a rabbit to be a surrogate mother. So that what we are getting, when you get the F1 generation, we are getting what you call a mutated form of this. Because if you do this research transfusion in human being, it could be non-ethical. So that's what I'm working on. And lastly, there's how long is the ACT blood viable on storage? This now depends with it depends with the storage condition. It also depends on how do we monitor the changes. For example, I mentioned about some of the effects, some of the complications like hyperkalemia. I talked about the hyperbilirubinemia and also mentioned about the issue of hemolysis. Now it's all about monitoring. And I said as Kenya, we have shortage. Even in Africa as a whole, we have a shortage. So we are surviving on the shortage side. What if we have excess? Then we'll be suffering more because it means we'll be having more blood donated staying in our system for long and therefore risking most of the patient. I never mentioned that I come from Kombewa, KMTC, and my background is medical laboratory science.
Thank you. Thank you very much. Let's clap for him. Kombea is having the best. Thank you very much for that knowledge. Now we will give to Dr. Muthoka.
Yeah, I have one question here. Could steroid use during ARV initiation affect iris? I don't know whether you meant affect iris, the unmasking type. I don't know whether you meant affecting or treating, because it is recommended that during that reaction, corticosteroids, if I may know now, that's what you're talking about. They are actually recommended to manage severe cases of immune reconstitution syndrome. So the answer to that is yes, and positively, because they are meant to treat or to mitigate the inflammatory response with immune reconstitution syndrome. On the other side, it will depend on the cluster of ARVs. There are some ARVs that might not work very well with corticosteroids, and that is where now we come to what we call INSHI. INSHI is Institute for HIV Infection and Clinical Scientists. There is a forum which gives guidelines on what time to give corticosteroid and what not time to give. That's not very common in Africa. That has been practiced. Some South Africans and the UK, they have that forum. So the answer is yes, but to mitigate the harshness of immune reconstitution syndrome, because iris is inflammatory syndrome. A corticosteroid is used as a steroidal anti-inflammatory agent. So the answer is yes.
Thank you very much. Thank you. Let's clap for Dr. Muthoka. These people have done very well. You can have a seat. Thank you very much. Now we are heading into another session, which we want to conclude the activities of the day. And before we conclude, I want to thank you for being there in the afternoon. You are heroes. You are our heroes, I'm telling you. It is one thing to be here and one thing to be out there. And I want to thank you very much. Thank you, Dr. Muthoka, for co-chairing with me. And I want to give right now to our chair of chairs, and that is our chairman for the conference, and that is Dr. Aswani, so that he can give us a way forward for tomorrow and also to say something about how we are going to be doing our work tomorrow. Thank you very much. Please come, Chair, and give us a way forward. And then we will ask our sister, Madam Nyabuti, to come and pray and end the session for us. Madam Nyabuti can be walking so that you can say the last prayer. Thank you.
Yes, let's appreciate our chair for the session. Thank you, Dr. Kibet. Yesterday morning, I said that as a committee, as we sat, came up with the themes, we selected plenary topics, and we went out to look for plenary presenters. Together with the papers you people had sent in, I said, I was looking forward to learning taking place, knowledge being shared. I don't know whether I was too far away from what we are receiving. I was on point. Why are you not clapping for me? Thank you. I want to appreciate each and every presenter who has graced our occasion, and much more so those who have remained in attendance as our audience. And I want also to inform that with the blessings from the office of the CEO, I think the information we have is that our conference continues tomorrow, despite the changes that came with the gazettement yesterday. It is not possible for us to say we stop and then look for a day next week to complete the exercise. And so we will continue. We'll try to see how much we can be able to hasten our sessions so that hopefully we shall end at lunchtime. But let's meet here tomorrow to continue to complete our conference. I want to promise that even tomorrow's presentation, very juicy. Thank you, Madam Nyabuti.
So much, Dr. Swan. You are in spirit. Spiritually would say that. Thank you, Dr. Kibet. Thank you, all of us. Let's bow down for a word of prayer. Father, in the name of Jesus, we exalt you and honor thee. Thank you so much for your presence, and thank you for taking us through this day. Lord, we are grateful for what we are seeing and for every presentation that has been done here. We thank you for what you're doing in our institution, Kenya Medical Training College. And we pray that, Father, you will continue escalating us to higher and higher levels. Lord, even as we come to the end of this day and this session, we pray that, Father, go with us, direct us, and as we plan to come tomorrow, you will bring us all safely. We thank you. In Jesus' name we pray. Amen. Thank you.
Yes, at 8.
Okay, can all of us be here by 8 if we want to leave early? It's Friday and it's a holiday. So we be early and we leave early. God bless you. Amen. Amen.